By simulating a natural cough, Cough Assist T70 is an effective, comfortable way to help clear the airway. It gradually delivers a large volume of air to the lungs, similar to a deep breath, then quickly reverses the airflow to pull secretions out. Cough Assist T70 is designed to be easy to set up and operate. To power the device, press the power cord firmly into the back of the device and plug the other end into an AC outlet. If you prefer, you can attach the optional lithium-ion battery into the detachable battery slot on the back of the device. A DC power adapter can also be used to connect to an external power source, such as a car battery. Cough Assist T70 can be used with a mask, tracheostomy tube, or mouthpiece. To build the patient breathing circuit, attach a bacteria filter to the breathing circuit connection. Attach the circuit tubing to the bacteria filter. Press the filter onto the connector on the side of the device. If the patient will be using a face mask or mouthpiece, attach it to the circuit tubing. If the patient has a tracheostomy tube, place a trach adapter on the circuit tubing. If the trach has a cuffed tube, inflate the cuff. Help the patient into as upright a position as he can tolerate. Press the round Start-Stop button on the front of the Cough Assist T70 to enter standby. If the device is running on AC power, the button will illuminate. Check the treatment settings to make sure they match the doctor's prescription. Before the first treatment session, it's a good idea to let the patient feel the airflow so he knows what to expect. This is helpful when working with children. Consider giving the patient an opportunity to get familiar with the mask or mouthpiece. You may also want to work out a stop treatment signal in case he needs a break. Press the rectangular right button below Therapy to begin treatment. If you are operating Cough Assist T70 in manual mode, slide the control lever to the right to trigger an inhalation, or press forward on the optional foot pedal. When the inhalation is complete, slide the manual switch to the left or press back on your heel for an exhalation. Position the mask, mouthpiece, or trach adapter on the patient. When using a mask, make sure it is well fitted to eliminate possible leaks. If you hear or feel an excessive air leak during the inhalation period, support the back of the head with your hand or a pillow to improve the seal. If you're using a mouthpiece, nose clips may be needed. Instruct the patient to open his mouth and actively inhale during inhalation and exhale during exhalation, which will open the airway for unobstructed airflow. Ask him to keep his mouth open and tongue down throughout the therapy. Encourage the patient to be relaxed and passive during the inhalation and the exhalation cycles. When providing a treatment in the manual mode, you can see how long you are delivering the inspiratory pressure and how long you are delivering the exhaled pressure on the screen. The center position on the lever activates a pause. Depending on patient preference, you can pause for a few seconds after exhalation before initiating the next in-breath. Exhalation pressures appear on the left as negative numbers on the Cough Assist T70 screen. Inhalations are shown as positive. Both appear in real time. A simple screen view with less respiratory information is also available through menu options. The detailed screen provides additional clinical information. For the initial treatment, you may want to begin with lower pressures to give the patient a chance to get comfortable. You can gradually increase pressure as described in the pressure and timing adjustment portion of this program. A cough cycle is defined as inhale plus exhale plus pause time. Deliver 4 to 6 cough cycles in rapid succession, followed by a rest period of 20 to 30 seconds. Repeat this sequence, 4 to 6 cough cycles and rest period, 4 to 6 times for a complete treatment. When the treatment is finished, press the right button to halt the airflow and return to standby. The patient's prescription will determine how many treatments are to be administered each day, for example, a treatment every 4 hours. If the doctor orders the treatment as needed, the patient can determine how many treatments he receives during the day, depending on how often he's to clear secretions. Cough Assist T70 can be operated manually, which you have just seen demonstrated, or in automatic mode. In automatic mode, inhale, exhale, and pause times are controlled by the time settings entered. When using the cough track option, the device will automatically detect inspiration effort and respond with an inhalation. With automatic operation, there is no need to toggle the manual switch between inspiration, exhalation, and pause. Cough Assist T70 will do it for you and display the pressures in real time. Here again, the patient should actively inhale and exhale. You can pause the treatment at any time by pressing the right button under Standby. After the treatment, clear any secretions from his mouth, tubing, and patient interface. It is important to wash the breathing circuit and patient interface with mild liquid detergent and water. The parts must dry completely before next use. The bacteria filter cannot be washed, so you should replace it if it becomes blocked with mucus or trapped moisture. You should clean the air filter at least once every 2 weeks and replace it with a new one every 6 months. 3 unique prescription settings can be stored in Cough Assist T70, so you can quickly select treatment pressures based on a patient's current needs. On the upper right-hand side of the screen, if you see a small open lock icon, you will be able to make changes to the settings. Changes can be made to the settings during standby or therapy. A specific prescription can be entered during standby, but titrating is easier to accomplish during therapy. To enter prescribed settings, press the left button under Settings. A setting menu will appear. The first item on the list will be highlighted, in this case, Preset. Press the Modify button. You can select which one of the 3 presets you wish to modify. Press the OK button to confirm the preset. You can select other settings by using the center Navigate buttons. Let's say you want to change the pressure temporarily while a patient is being introduced to treatment for the first time. Use the center Up-Down button to move down the list until inhale pressure is highlighted. Press on the right button under Modify. Use the center Up-Down button below Edit to lower the pressure to the new setting. For an initial treatment, a low exhale pressure of -10 to -15 cm H2O may be a good starting point for an adult. Once the patient is accustomed to the therapy, exhale pressures of -40 to -45 cm H2O may prove more effective at clearing the airway. Press the right button under OK. Press the right button under Modify to change the next item on the list, which is Inhale Flow. Use the Up-Down Edit button to adjust. If you try to change a setting beyond the available parameters, a Limit Reached message appears. In this case, after you have entered the correct pressure, press OK to accept the new setting. Use the right button under Modify to highlight inhale time. A typical inhale time for adults with a low flow setting is 3 to 4 seconds, 1 to 2 seconds in adults with higher settings. For small children with low flow, 1 to 2 seconds is typical, 0.5 to 1.5 for high flow. OK accepts the new inhale time. All the settings listed can be adjusted in this manner. When you have made all of your modifications, press the left button under Finish to return to standby. Cough Assist T70 comes with an SD card inserted in the SD card slot on the side. An SD card icon will appear on the top right corner of the screen. Your clinician may ask you to remove this card in order to review information about your treatment. From the standby screen, press Up on the center button under Menu. You will see a list of items. Use the down button under Navigate to move down the list until Safely Remove SD Card is highlighted. Press the right button under Select. A Remove SD Card message will appear to let you know that the card can be removed. Press the left button under Exit to return to standby. The SD card and other features make Cough Assist T70 easy for caregivers and patients to use in the hospital and at home.
Добрый день, уважаемые коллеги.
Hello, dear colleagues, dear friends. It's a pleasure for me to welcome you today. We have this Saturday afternoon, and we have quite a big program ahead of us. I see that some of you already are watching us, on our YouTube channel. I hope that there'll be more of us, more viewers will join in. But in any case, everything we will discuss today is going to be recorded, so you will be able to re-watch it. So this conference today is organized by the Живи сейчас, Live Now Foundation. This is a foundation to help patients with ALS, and it's been founded in 2015, but even before that there was the ALS patient care service and the monastery of Martha and Maria. They were also dealing with this, and the joint efforts have led to the creation of the Живи сейчас, Live Now Foundation, which now is quite active. It is receiving grants and private donations to organize the system of care for patients with ALS all over the country. And this conference in particular, this is one of the educational initiatives of the foundation aimed at spreading the word so that more and more people would be aware of how to cope with respiratory insufficiency symptoms with ALS patients. It has been supported by the President's Grant and by Philips, our general sponsor of this conference. We acknowledge their input and we appreciate it highly. Another partner of this conference is the Association of Palliative Care. I hope that our listeners will include doctors, specialists of palliative care, because equipment now is mostly being procured under palliative care. They deal with symptoms, but also this conference is of interest for intensive care specialists, for intensivists, for pulmonologists, anyone who might encounter this disease. Another partner of this conference is the Buyanov Hospital, the Neurology Center, April Rehabilitation Center, and Врачи RF, doctors.rf portal in Russia. Now, let us proceed with the agenda. You are now watching and hearing this YouTube broadcast. So, a few technicalities. Below the picture, you will see a link. This link will lead you to the agenda. If you click the link, you will see the agenda. And there you will also find the link to the foundation page, where you can donate something to support the foundation and its initiatives, educational initiatives. If you have any questions, you can type them on YouTube chat. I already see that there are comments there. People say hi. I also would like to say hi to you. I hope there will be more and more viewers, and they will open this broadcast soon. It's going to be an interesting event because we will have presentations by people who have quite a significant experience. They have been dealing for a long time with care for patients with ALS, and essentially the main idea here is to explain to you, if you don't see many ALS patients often, what one should do if you encounter a patient who has breathlessness, or if you have a suspicion that they have some respiratory insufficiency. So what are the options? What are the interventions which you as a doctor can offer? You will hear quite a lot in details about all of them. So this conference I would like to stress it. It's not exclusively to non-invasive mechanical ventilation. It's not only about palliative care. It's about a comprehensive approach to care for patients who, in the course of, in the progression of the disease, might encounter some respiratory issues. And you will get answers. Why do these issues emerge? How do you diagnose them? What are the approaches to support maintenance and rehabilitation? What are the choices? What are the options that patients and doctors and the family have when they manage the patient? The curative care and palliative care, what are also the options? That we will have a presentation on that topic specifically after lunch by David Steinhorn. Then there will be Richard Sloan talking after him on palliative care. He is our colleague from Dorchester, from the UK, and he has helped us a lot in the aspects of providing care, palliative care for patients with breathlessness. Then we'll have a presentation by John Robert Bach, one of the leading specialists in the world in non-invasive mechanical ventilation. He is really a very prominent figure in this field. Then we'll present Russian experience and by Dr. Stabnitsky and Larin. They will also explain Russian experience for non-invasive ventilation. So we have quite an interesting agenda, and I hope that you will stay with us in this new format, which still is new for most of us, but there are certain advantages in it for sure. You can go and have a cup of coffee. You can go for a small workout, perhaps, if you sit for too long, and then you can get back to the conference. So I would like to remind to those who have just joined us that under the picture in the description you will find the link to the agenda and the link to the page where you can donate to the foundation and to its educational initiatives in particular. Feel free to ask questions in the YouTube chat. I will be distributing these questions. I will be addressing these questions to our renowned lecturers. And we will be able to have a discussion in the forms that are available. So if you disagree with the presentations, it would be actually great if we would have some polemics. I will highly encourage and initiate fruitful discussions. Let me introduce myself. My name is Lev Brylov. I'm a physician, a neurologist. I am in charge of general neurology in Buyanov Hospital and the medical director of Живи сейчас, Live Now Foundation. So I welcome everybody here, and now, before we proceed to presentations, I would like also to see any questions and comments. Okay, I will be the first to present. I have been dealing with this issue for quite a long time. My thesis was in ALS, and I have been seeing quite a lot of patients in that time, but still, slowly I have seen other issues in the pathogenesis of breathing insufficiency that probably would be of interest for you, because they can influence the strategy of treatment. It's important, first of all, to figure out what is going on, and then one can figure out what can we do with this. So, I will present on pathogenesis of breathing insufficiencies in ALS patients. Let's switch the slide. Next slide. No, sorry, apologies. If you could please roll back. I have a lag in my YouTube stream. I will not look at the YouTube now. Okay. So, amyotrophic lateral sclerosis is one of the forms of motor neuron disease. When the upper motor neuron has a lesion, we talk about primary lateral sclerosis. So if only upper motor neuron is damaged, then the disease might not spread onto the lower neuron. If it doesn't happen within 4 years, then it has its own name, primary lateral sclerosis, and it has more beneficial prognosis. And there are certain peculiarities in it. If there is a lesion of lower motor neuron, we talk about progressive muscular atrophy or spinal muscular atrophy, and when there is a joint lesion, then it is lateral sclerosis. So it kind of is obvious if we see lesions in both upper and lower motor neurons, then we talk about ALS if we exclude other possible conditions. But on the next slide, you will see that there are different phenotypes with different types of motor neuron damage. You see in orange, it's upper motor neuron lesions, and in green or blue, it's lower. So you see that we can have more symmetrical, less symmetrical lesions involving upper, lower, or only certain segments, for example, only of the bulbar section. Then we talk about isolated bulbar paresis. So, with this, I would like to say that there's quite a big diversity, quite a big spectrum of the disease, and on one end of this range there are diseases with isolated lesions for only upper neuron, on the other end of only lower motor neuron, and then in different ratios they might combine and they would cause different clinical manifestation. I'm not talking about another axis of the disease, the cognitive impairments, because on that axis there is also a certain spectrum from full norm to frontotemporal dementia. It's a bit outside of the today's scope, but still I had to mention it. And the progression of the MND is happening through step-by-step engagement of the spinal column and in the brain. Here you see that, for example, if it starts with the neck section, then clinically we have the hand engaged. Then as the disease spreads onto other sections of the brain and the spinal cord, then the patient starts having complaints on weakness in the other arm, in the legs. We have bulbar symptoms. So pathomorphological and clinical studies show that the disease develops like an oil spot. This is quite an old term, and it slowly spreads over the neural system, engaging motor cells and engaging adjacent units of the nervous system, and then clinical manifestations appear. So how does ALS affect breathing? We will see this on the next slide. Here In the onset of the disease, breathing impairments, they are not often. It's only in 1 to 3% of cases. Mostly, breathing insufficiency comes out later. So probably the neurons which are responsible for the breathing function, they have more resistance capacity, because we saw that that spreading is kind of universal, but obviously it doesn't impact neurons which regulate breathing as much, because they are engaged well on later stages of the disease. Quite often we see patients who are fully tetraplegic, but they still have respiratory function preserved. So in terms of theory, it's possible. The representations of the upper motor neuron in the cortex, it's quite plastic in both the brain and in the brain stem. Another theory is that one of the mechanisms of adaptation to the loss of motor neurons is the increase of motor units in other neurons. So when cells die, then other cells overtake the function of motor neuron, like the phrenic neuron overtakes the function. And also, I will talk later about the muscles that are involved in breathing. So additional auxiliary muscles engaging in the breathing is another way to compensate for the loss. That was the first idea I wanted to explain. And the other idea here on the slide, you can see how the breathing regulation is organized. We have the central motor neuron department. So there's the corticospinal pathway when the neurons start in the cortex and then they innervate the spinal medulla, and the bulbar spinal when the neurons start in the brainstem. So the first motor neuron lies either in the cortex or in the brainstem. The second is in the medulla, and then we say that these neurons lead to respiratory muscles, but we'll talk about that later. And there's also a back loop of regulation, when the regulation is conducted through chemoreceptors, which provide information to the brainstem about the changes in the content of CO2 in blood. If it goes up, then the so-called respiratory drive is activated. So the person starts breathing actively when CO2 is accumulated. So let's remember this structure: the upper, the lower motor neuron, and it's organized differently in terms of respiratory muscles. And there is also this feedback, this loop, depending on the CO2 content and the respiratory drive. So we can have issues at the levels of the upper or lower motor neuron and at the level of the regulation of the whole respiratory process.
That is, the neurons can react differently depending on the level of CO2. That's one mechanism for regulation. Another mechanism for the regulation is the regulation of the so-called conscious breathing. We are also going to talk about it a bit later, when for this or that reason we want to breathe in deeply and all that. In most cases, we breathe without thinking about it. This is an unconscious process, but there is also a conscious process which also plays a certain role in this, even though that role is not that significant. So we have discussed these levels, and on each of those levels, there can be disruption of those functions. There can be a problem as a result of which there is a disruption of functions. So my task as a neurologist in this lecture is to diagnose correctly what kind of respiratory disorders are present. So if there is this respiratory disorder, it is caused by the lesion of neurons in this part of the nervous system. It is important not just to have a correct diagnosis, but also to think how and in which way we can fight this problem, depending on where its source is. The following slide, please. Let's not forget that except the process, the respiratory process itself, it is important to mention, if we talk about ALS, about bulbar disorders. There are bulbar muscles, and their functioning impacts, first of all, the functioning of upper respiratory tract. That is why it is important to remember about that, because the functioning of these muscles may bring certain problems for the patient and for us as people who deal with care and cure. Bulbar disruptions are much more often in the onset of disease in 30% of cases. The so-called bulbar ALS form develops. So this function doesn't have any compensatory functions to offset it, and the lesion of upper motor neuron calls for pseudo-bulbar syndrome with the muscles of face and larynx and tongue, as well as lower jaw reflex spasm. And it seems to me for a neurologist, it is a rather important reflex that you have to always check when you have patients that you suspect to have ALS. Also, to follow the course of the disease, it shows that the upper motor neuron is affected. Then, if the lower motor neuron is affected, it's already bulbar syndrome with the lower tone of facial muscles, as well as the larynx and fibrillations of tongue muscles. This shows us that lower motor neuron is affected. Clinically, except for this presence of reflexes, or for example their weakening, or if upper motor neuron is affected, if for example we have this soft breathy voice, which is associated with the tone of the larynx, but mostly it mostly happens in the isolated lesion of motor neurons. And if we talk about peripheral, for example, if it's larynx paralysis, this is a weaker voice. It sounds very soft and breathy. Actually, if you notice that the voice changes, that this also shows that the respiratory muscles have become weaker. So what are the problems that bulbar disruptions cause? First of all, we're interested in breathing today. These disruptions complicate coughing. Why? Because coughing is a process which happens in the following way. We inhale, we close our vocal slit, then we exhale and open our mouth, and we cough. We have high speed of airflow, and therefore cough cannot happen if we cannot inhale properly. It cannot happen if we cannot close our vocal slit, and we cannot cough if we cannot use our exhalation muscles. And if we cannot close our vocal slit, and it is bulbar muscles that are responsible for that, then cough is also complicated. Also, bulbar muscles can cause obstruction episodes in the upper respiratory tract. We're going to talk about that a bit later. So this causes the closure of upper respiratory tract, and therefore it is impossible for a patient to breathe. Also, bulbar muscle disruptions can cause aspiration, disruption of protection in the respiratory tract and the airways. That's also another their function, except generating voice, cough, and all that. These muscles protect airways. They close our larynx when we swallow, and so that no food gets in. Therefore, the disruptions in these muscles may cause aspiration, and as a result, inflammation in the lungs, which also complicates the breathing process. So, we have to look at the whole breathing process, the combination of various disruptions in breathing, and we have to take into account that bulbar muscles may also be involved. So we have talked mostly about how these systems work, how they can be affected, and which symptoms develop as a result. And now we'll talk in a bit more detail about more clinically significant types of breathing disorders and what these disorders can be associated with. So let's go deeper into this problem, and now let us talk about the weakness of the respiratory muscles. Again, I'll remind you that upper motor neuron is located in the brainstem and in the cortex, and the lower motor neuron is located on the presented spinal levels. And respiratory muscles are divided into inhalation and exhalation muscles. We inhale actively, normally, thanks to the chest muscles. We can expand our chest wall, and exhalation, when we are calm, happens passively due to elastic recoil. It comes back to its previous position, and the exhalation muscles are not as relevant. They don't work as much in this case. And that is why the main respiratory issues, which are clinically significant, develop due to the inhalation muscles. Out of those muscles, the main is diaphragm. It ensures 2/3 of the effort that we develop when we inhale. 2/3 of this effort depends on the functioning of the diaphragm. It is controlled by diaphragmal nerve, which goes from the level C3 to C5 level. And also weakness of diaphragm causes hypoventilation. We have to remember two main notions, I believe, that we are going to discuss further. That's hypoventilation, that is impossibility to ventilate lungs and that is associated with the weakness of muscles. First of all, diaphragmal muscles. That is the main issue that emerges in ALS. The second issue is obstruction. When the airways close, we'll talk about it later. And the third problem is impossibility to cough, and that impossibility to cough is associated with exhalation muscles. If they are not activated in calm state, they are still activated when a person has to cough. And the lesions of upper and lower motor neurons that you can see here cause the situation that a person cannot properly drain its airways, so the risk of inflammatory complications rises significantly. And these inflammatory complications in the lungs are the main reason of patient's death. So this is a very serious problem. Okay, so we have discussed how nervous systems disruptions causes respiratory problems. We have understood what causes the weakness of respiratory muscles, which muscles are involved in the breathing process, and on the following slide I will show you what is the clinical manifestation of this weakness. We see here that respiratory disorders, first of all, become obvious when the patient sleeps. Mr. Stupnitsky is going to tell in his lecture about that in more detail, but I'll just briefly say here that this is a very good way to demonstrate the involvement of those muscles and if they have problems. You see that this is the REM stage of the sleep, and we see that PTC CO2 starts growing. That is, respiratory insufficiency starts manifesting itself. And this tells us that the diaphragm doesn't develop enough effort during the exhalation. The lungs are not emptied out properly, and that is why CO2 accumulates. Why we talk about the diaphragm? Because it is in the REM sleep that other muscles are switched off that participate in the respiratory effort. The brain switches them off, so only the diaphragm remains, and when it becomes weaker, therefore, REM stage of sleep is the clearest place to see that. That is the earliest sign of diaphragm weakness. When there is respiratory insufficiency or other respiratory issues and accumulation of CO2 in REM stage of the sleep. And as compensation, the brain starts, and a lot of research shows that the brain starts switching on other muscles during the REM stage and starts waking up the humans to actually switch these muscles on. So the structure of sleep is disrupted, and REM stage in bulbar syndromes and diaphragm weakness become smaller or even practically disappear. So the structure of sleep is disrupted, and this causes other issues, including the vascular problems and others. We see here that this chain, which started from motor neurons, reached weakness of the diaphragm, finally led to sleep structure disruptions. So this is hyperventilation. Then, except disrupting sleep, hyperventilation also causes other respiratory symptoms like breathlessness and others. But these are the very first manifestations. They emerge in REM sleep. So this was about hyperventilation and diagnostics and confirmation of diagnosis using this method. Another issue that we face and that we have already mentioned, this is obstruction. Obstruction of airways. Obstruction of airways can happen during sleep, and then this is called obstructive apnea. We encounter it in 45 patients with ALS. And another important thing to note, for those people who have been dealing with this problem for some time, in most cases, there is an opinion that obstruction of airways happens due to the fact that bulbar muscles get weaker and they simply cannot hold airways open. And when there is a low pressure in the trachea, for example, during the exhalation, they simply fall in. During the inhalation, the pressure inside trachea lowers, so it just passively falls in. Well, the research actually shows that this is not really that obstructive apnea is more often registered in patients with preserved bulbar function. And most probably this process is active, and we are going to talk about that as well a bit later. This, I think, is important to note, that these airways obstructions are more an active than a passive process. Why doesn't it happen passively? Because I already described a mechanism serving that before. If there is a weakness in bulbar muscles developing, then in parallel, tongue atrophy develops. And tongue, to some extent, closes the entrance to airways, so the weakness and lowered ability of the muscles to hold this open for 100% is compensated by the fact that the tongue becomes smaller in its volume and liberates this entrance into the airways. And in this way, one problem compensates another. And again, if we look at the record of breathing during the sleep, so the upper curve shows TCCO2 and the lower curve shows saturation with oxygen. We see that there is no hyperventilation, there is no weakness of muscles, everything is okay. The situation just when the situation falls, it means that there is an obstruction in upper respiratory tract, and this is an active obstruction. I'll talk more about the mechanisms of this obstruction a bit later. The following slide, please. And 2 more slides forward, and then we'll come back. Okay, let's go to the larynx spasm slide. Yes. And the obstruction can happen not only in sleep, but also in daytime hours. And then this is called larynx spasm when the patient is awake. We observe it in 50% of patients with bulbar spinal amyotrophy, canalis amyotrophy, and 19% of ALS patients. So this is also an active process, the spasm of the vocal slit, which causes temporary. It lasts between several seconds and less than a minute in most cases. So when a person says that I cannot either breathe in or breathe out,
very often there's also anxiety, and people with ALS often call ambulance, or their relatives call ambulance when there is an event like that, even though it's enough to just stay calm, to wait through it, and to take some symptomatic drug like lorazepam. It usually is good in these bouts. They might be provoked by reflux or smoking, but the reason is the disruption in the neurons that take part in swallowing and speech. There's no really clear and topical mechanism of how it happens. It's difficult to tell where will this reflectory arch be over, but still. This is we have the active spasm of upper airways, both in the daytime and during sleep. And this is an important sign of breathing irregularities in ALS. It has to be distinguished from hypoventilation, which is caused to the weakness of respiratory muscles, first and foremost the diaphragm. Let's get back two slides back. Breathing irregularities. So if you could switch 2 slides back. Yeah, now about breathing irregularities. This irregularity happens, well, the regulation happens at 2 levels, the brainstem and the cortex. In the stem it's involuntary regulation, which depends on the CO2 content. And there are receptors to H2O3 in the carotid sinus. So it happens that, you see, on the curve of PCO2 to minute flow, you see that this curve, well, it's not a curve, but we see dependence. There is this upper line that starts from, well, almost from 0 in this scale, and you can see the increase in PCO2 gradually, this normal ratio shows that slowly PCO2 increases and slowly the minute flow increases, the minute volume. So if you hold your breath, then the CO2 would increase in your blood and the breathing center would get worried, and they will send more and more signals and they will increase the volume, or you will start breathing more often. So the ALS patients, some of them, not all of them, have an irregularity in this mechanism. You see this other line where, well, it starts at 38, and you see that there's quite a wide spectrum, a wide range of PCO2, where the breathing center is not actually reacting to its increase to the increase in blood. And when PCO2 is 42 or 44, we see that the minute volume is lower than at the normal curve. So the patients have lower need, well, not rather a need, but they have less responsive respiratory center to the hypercapnia. So essentially, they don't respond as actively. And these are these patients in whom hypercapnia does not cause the activation of the breathing center. And it has a drawback. The drawback is that hypocapnia leads to, like, if there was some hyperventilation, we have less activity of the respiratory center, but we'll talk about this a bit later. This is the irregularity and its mechanism. In some cases, I think the person can, well, to some extent, be protected. So this mechanism protects the patient. And they don't have breathlessness even when breathing irregularities are quite high. We do see these patients, and it's always really curious when you look at the gases, at the gas content in blood. They don't have actual breathlessness, and the reason is this particular breathing disturbance. Next slide. Well, this is the cortex mechanism. If you could switch the next slide, please. Yeah. The cortex irregularity, the so-called breathing apraxia. You see, the norm when there is the nasal flow, the movement of the chest and the abdominal wall, it's quite normal, regular, so regular breathing. And the symmetric changes of the nasal flow. And the lower picture, there are three same curves, but in an ALS patient who had involuntary breathing. So let's say the upper one was during sleep, and the lower was when the patient was awake, and when they were asked to have a voluntary deep inspiration. So it has led this desynchronization of the chest movement and abdominal wall movement. So breathing apraxia is probably the best name for this. There was a study when they identified this issue. It wasn't associated with any other cortex irregularities, with any other apraxia or any other types of cognitive disruptions. They have found no association. So it was a local disorder related to apraxia in breathing. I think it's an interesting mechanism, but I want to underline that clinically it's not very significant. Okay, we have discussed the main issues and their topical sources, the sources of these issues in breathing irregularities, hypoventilation, and these are the obstruction of airways, the disruptions of breathing regulation at the level of the brainstem and the cortex, and coughing irregularities. We will keep mentioning that. But now I would like to talk about those breathing disruptions which happen when we have our interventions, when we have the non-invasive ventilation. Let's skip one slide. Yes, and we will watch a video. Here you're about to see a patient, and please pay attention to the tongue. And you will see that the tongue is not very clear, but if you look closely at the tongue, it goes deeper inside in the moment of inhalation. When there's positive inspiratory pressure, the tongue goes back. You can't really see it well. So, inspiratory pressure kind of pushes the tongue back inside. Most often it's linked to flaccid paresis of the tongue muscle. So the researchers who have found this, they have published this case, and they have linked this kind of mechanical issue with the use of oronasal mask. So their suggestion was, if you could please switch the slide back. Oh, I don't see the picture. There was a picture right next to the video. Strangely enough, I can't see it. Well, it might get back if we try to open the slide again. Now, if you could open it again. Please open the slide. No, if you could open the same slide again. But don't turn on the video. That is weird. Anyway, so their solution was to add this chin strap that essentially straps the chin shut when they use the oronasal mask, or they use only the nasal mask. This is, like, it's like a strap, an elastic strap. Oh yeah, here I see it. There, that's good. So you see, there is this nasal ventilation, and this essentially a chin strap that keeps their mouth shut. In this way, we manage to avoid the tongue going back and causing airway obstruction and ventilation inefficiency. So you see, sometimes the ventilation has drawbacks that provokes its own inefficiency, and there are, of course, some ways to fight that. So, in order to note this issue, you have to be actually attentive. Most often you have to do a polysomnography study to figure out if these obstructive events happen during the non-invasive ventilation. And in real life, in real experience, sometimes it's not possible, but you see, in this case, they just managed to note it just visually. I really like this case because they just looked attentively and they noted an issue. Next slide, please. Another issue that is caused by non-invasive ventilation. This is the obstruction of upper airways and active contraction of the muscles. Here you see the vocal slit. Here above the vocal slit is open, and then the vocal slit is it's when there's ventilation, it stays shut because of the flow that hits these receptors in the slit. This is active contraction. It's not just weak muscles. This is kind of very, very active contraction, and it happens if you press forward. There was one study. No. There should have been another picture next to that one. This is weird. There should be another photo on the right. It was animated, and well, another picture was supposed to. Anyway, it's about this. It's about the thyroarytenoid muscle. There was a study that said that this muscle is contracted because of the flow from the ventilator, and then there's an obstruction in the non-invasive ventilation. Now let's open the next slide. So the obstruction can happen because of the tongue or the construction of the thyroarytenoid muscle. And there's another mechanism which is very interesting. This is a change in the sensitivity of the respiratory center. If you could make this picture larger, yeah, here you see the following. You will see that we have an episode when breathing has stopped, but the second curve, this is volume ventilation. What has happened? We had an active obstruction of the upper airways related to the ventilation. As the result, the ventilator has sensed the incomplete volume and started increasing the volume. The respiratory center then responded to the reduction in PCO2, and it had this excessive response because they had an irregularity. So they suppressed the activation of respiratory muscles for some time. So the result of the active obstruction as a response to hyperventilation caused by the ventilator, the respiratory center responded with central apnea after obstructive apnea. So you see the problem actually increased. So these two mechanisms in some patients, and this doesn't happen in every patient, these effects of non-invasive ventilation they are valid only for some populations of the patients. But in this study that I'm showing, it was shown that these are mostly patients with irregularities, with pyramidal irregularities in bulbar muscles. Previously, I've been showing you the phenotypes when patients have high reflexes and spastic tension of bulbar muscles. They have these types of irregularities, and most researchers say that this is due to brainstem disturbances in breathing regulation. So due to these mechanisms, non-invasive ventilation might be ineffective. I have tried to collect all the known mechanisms of this ineffectiveness, and I have just presented them. And John Bach will also mention this in his presentation, and he will show you that patients with spinal muscular atrophy can be ventilated almost endlessly, and non-invasive ventilation is always effective when the parameters are properly chosen, and there are also auxiliary conditions when there is the cough assistance and so on. But the patients with ALS, in like some portion of ALS patients, cannot have non-invasive ventilation prolonged for a long time because they might have these issues provoked by the ventilation. I think this is interesting, and in one's clinical practice, the causes of this ineffectiveness, well, we don't talk about it often. That is why I wanted to present these mechanisms. Next slide. This is my final slide, and it shows that when we have breathing disruptions, but actually they can be ALS patients so without breathing disturbances, but the process can be influenced by prescribing opioids. When PCO2 goes up, you see on the square picture the black line is normal. We see the increase in PCO2 and respiratory volume also goes up. In the patients, when PCO2 goes up, they have breathlessness and it causes discomfort. It's a very big burden for them. But if we give opioids that act on respiratory center, the curve changes, and the same PCO2 values cause less of the activation of the respiratory center, so the person has less breathlessness. So as we know these mechanisms of different tissues emerging, we can respond appropriately. Next slide, please. I would like to say thank you for your attention. If you have any questions, then I'm ready to answer.
Так,
Okay. So there are no questions in the chat. Okay, then. I'll just wait for maybe 2 minutes. Our following speaker is ready. But if you have any burning issues now about what has been mentioned, you can ask them. But you don't need to be in a rush. I'm going to spend the whole day with you. Okay, then. As there are no questions for now, let us move to the following presentation from Vasily Shtapnitsky. He's a pulmonologist, the Dean of Pulmonology Chair in the Medical University Nemetov Pirogov, and a person with great experience in looking after patients, including those with ALS. He's going to tell us about the diagnostics of respiratory disorders in ALS. Thanks a lot. I hope that you can see and hear me. I hope that everything is working well. I see myself in two windows at the same time. I'm working with this system for the first time. Okay, then. I probably have to say those words, the following slide, right? For the presentation to appear. Yes, probably. Okay, I'll turn on the phone. Maybe somebody's messaging me that I'm doing something wrong. Yes. Okay. Does it all work? It works, I hope. Colleagues, I'm going to start my presentation. My name is Vasily Stupnitsky. I'm a pulmonologist. Let's move to the following slide. I'm going to talk about the diagnostics of respiratory disorders in ALS. I'm going to stop on several definitions that I'm going to use. So that we don't have any misinterpretations about any definitions, I'm going to talk about MIP, EMEP, about FVC, about big speed of cough and hyperventilation. As this MIP and MEP are determined through the maximal expiratory and respiratory pressure that a patient can create, inhalation, exhalation. FVC, that's the volume of air that the patient can exhale after the maximally deep inhalation. So that's the physical capacity of air in his or her lungs. A peak cough flow, that's the maximal flow during the strongest cough. Hyperventilation, this is an episode of respiratory insufficiency during sleep associated with the growth level of CO2 and the loss of saturation. And respiratory insufficiency, failure, is incapacity of the air system to maintain this level of PCO2 and PO2. When we talk about hyperventilation, it's in sleep. This is an episode which occupies a part of the whole of sleep, and a respiratory failure is something happening during the day and during the night. So hyperventilation is something that is an early stage of respiratory failure. The following slide, please. And the main problem that we're going to discuss today is the fact that ALS is the main indication to non-invasive lung ventilation. And the main method of therapy and supporting care for patients with ALS is respiratory support, in particular non-invasive ventilation. Through the mask, as Mr. Berlov has said, there is a special device which supplies air under positive pressure through a special interface. The following slide, please. Yes, thanks. What are the main clinical manifestations? I'll stop on that just briefly because Mr. Berlov has provided the main information you, because the main clinical manifestations in ALS from the point of pulmonology is that the atrophy of skeletal muscles, even though we understand that, of course, the disease primarily impacts the neurons, but then there's atrophy of inspiratory expiratory muscles plus bulbar muscles are affected separately, and according to the scheme from top to the bottom we see that the strength of inspiratory expiratory muscles goes lower, the capacity of the lungs as well, the mechanism of swallowing and cough is disrupted, physical activity also becomes lower, it falls due to general muscular and the table, and the first problems actually happen when the FVC is lower than 10%, and respiratory failure during the daytime forms when FVC is lower than 1 liter. Plus the growing weakness of respiratory muscles causes cough disruptions for the sputum, also lung inflammations, and very often to infectious episodes which bring the patient into the clinics. Worst case scenario, the patient die. Best case, on invasive ventilation of the lungs, but this is not a beneficial outcome for the patient in either case. I decided to portray all this scheme in the form of this set of errors. And left to right, this is disease progression. The first symptoms are not respiratory, that's muscular weakness. For example, arms, legs, sometimes swallowing is disrupted. And in the beginning, this is just they are not nimble as they used to be, but then there's full palsy, impossibility to move or to do any physical activity. A bit later, there is lower strength in the respiratory muscles. That's the fall in FVC. Then peak cough flow also gets lower. You see, I hope that you see the arrow. Now there are symptoms of sputum stasis, then a bit later breathlessness, and those adverse symptoms that actually make the patients go to the doctor to have some respiratory support. It is not sure, we're not sure when, but at some stage, this night hypercapnia and hyperventilation forms, and then there is daytime hypercapnia. But of course, some stages can be interchanged. Some may emerge earlier, some later. What is this actually? What does it have to do with my presentation? Using different diagnostics methods, functional diagnostics, evaluation of patient's breathing, we can understand at which stage the patient is and understand how urgently the patient would need some interventions to correct respiratory failures. ALS is a disease with constant progression, inevitable progression. This is one of the peculiarities of this disease, which makes ALS so unique. We have different patterns presented here, different ways of disease development and the course of events, from fast progressing disease, when you see the disease just shoots out during the first year after the symptoms onset, and there are slowly progressing diseases in the green curve, you can see. But most often this is a disease which causes death on the second or third year. Of course, there are more or less aggressive forms of ALS. We have to take that into account when we deal with respiratory support, because it is clear that there are patients who urgently need help, but there are patients who you can actually observe a little bit more. These are the data of the same study. They tried to find those predicting factors. What is the characteristics of fast progressive and slow progressing case? But of course, one of the most exact predictors would be the change of ALS FRS scale, which manifests the motor disorders. The faster the patient loses the points, then the faster the disease progresses. Also, very shorter time from the onset of symptoms and to the diagnostics. Here it's clear. The more aggressive the disease is, the faster it is the diagnosis put. Then age, senior age, means more aggressive disease, and also preservation of FVC. Also preserves the health of the patient, which is totally logical and something that can be expected in such patients. There are several problems that I faced when I worked with literature. There is a great study under number 1. I'll just provide a quick summary of this study. They found very weak correlation between diaphragm atrophy, so the morphologically they looked at the patient's diaphragm, and it turned out that FVC very weakly correlates in those changes, degenerative changes in the diaphragm. So the patient can have very good FVC, but already manifested atrophy of diaphragmal fibers. This means that we cannot always predict the disease progression using that. Another Japanese study showed very interesting information. They tried to find the point which would predict this aggressive disease progression, and this point turned out to be very high, say 78% from the initial FVC. So practically, when this volume decreases by less than a quarter, this means that there is serious progression of ALS and respiratory assistance may be required. And another study, which was conducted in patients with early stages, showed that patients who have less than 75% of VC, every second patient already has hyperventilation. These are rather sad news, because we always believed, and I told you, is that normally 40 or 50% of lung capacity, that's the classic sign that we have already those disorders. But here, these are different things, that very early signs of disease progression, the disease may be very aggressive. So in the lower part of the slide, you can see the nature of the disease progression. In 4 months, after the baseline, just look at the 94% in the beginning, in the baseline, and in 4 months is 85%. So the patient loses 10% of lung capacity in 4 months. The disease progresses very quickly, and the assistance is required urgently. That is why we need very clear and checked algorithm of diagnosing respiratory failures in ALS patients. As for survival rates, these are the data from one of the most well-known respiratory centers in the UK. As for survival, ALS shows the worst results, even when non-invasive ventilation is used. You see that survival curves with ALS patients are very pessimistic, and if we try to find the survival median here, it's 1.5 years on non-invasive ventilation, which is even different from other unfavorable diseases. Like, for example, Hobel, they have 4 or 5.5 years with patients with CPPD. This doesn't mean that ALS is something that shouldn't be dealt with. Of course, we have to deal with that, but we have to be very attentive to the disease progression when we see respiratory failures getting worse. The following slide, please. Of course, I have to show our results. We have few published data, but these are the curves that we received among patients who had non-invasive ventilation. If we talk about 50% of survival rate, that's about 400 days, a bit less than those 18 months they have just mentioned. That's our experience. And the patients, yes, 335 days, that's right. 1 year on non-invasive ventilation and 269 days without non-invasive ventilation. These are the patients who refused or for some reasons did not get this assistance. Of course, it is a non-randomized study, but even in this non-randomized study, we can see the difference and the impact of non-invasive ventilation on survival in ALS patients. So what are the examinations methods that are used? They are very simple, and their simplicity gives us the advantages. The advantage of diagnostics is that we're supposed to have simple. There's spirometry, measuring the volume of lungs. That's both LC and FVC. We have to do it in supine and prone position. Sometimes the difference can be very marked. Then the strength of respiratory muscles, MIP, MEP, and SNP. The strength of inspiratory and expiratory muscles. Also night pulse and oximetry. Also O2 saturation during the sleep. Polygraphy, this is polysomnography in some expert cases, capnometry, to evaluate the gas composition in a non-invasive way, and if necessary, also gases in the blood using portable device. So on this slide, we have a summary. Here you see, well, these are the old data. This is an old slide that VC less than 50% already presupposes the presence of respiratory insufficiency. We can say that even those who have 75% may already have some issues with breathing, and that happens rather often. But I think that if 50% for sure, you have to expect problems in each patient who has that result. Peak flow less than 180 also points to serious disorders in sputum discharge. As for the functions, functional disruptions, there's restrictions, the limitations in inhalation due to the weakness of inspiration muscles. So yes, these are the necessary devices. Just one slide forward, please. And one more time. Okay. So, we show the main devices that we use. A portable spirometer with pulse oximeter. That's in upper right-hand corner. Very handy, fits in your pocket, measures very well using spirometry indicators. And there is also the functions of night pulse oximetry. There is a special sensor there to analyze data. Then also the device to measure the strength of inspiratory muscles. You can insert this in the nose, or you can use mouthpiece to measure intranasal pressure, which coincides with MIP, and then also the measurement of CO2 in the blood. And to the left, you see portable analyzer for the content of gases in arterial blood. So that's a portable device which doesn't require calibration. It works with cartridges. You can use capillary blood for that. Very convenient for these very small and modest tasks. Here, this is the spirometry they can see. I advise everyone who works with respiratory patients to do spirometry because this is a very simple and efficient and very talent method, but it has a very big disadvantage. Even the only one, it very strongly depends on the efforts of the patient and very strongly depends on the correctness of its application. So very many mistakes are explained by either the maneuvering is done correctly or the patients cannot cannot put the mouthpiece into the mouth correctly, which often happens with ALS patients. But if you do everything correctly, you see this curve. The red curve is restrictive. So we see the restricted VC. And if we look at the curve to the left, volume and time, we see that the patient doesn't exhale as much as he or she should, and this is called restriction. Plus, the form of the curve is preserved. And as you can see to the left, the FEV is normal. This means that these indicators are normal. The indicator which points to the presence of obstruction. Very often the patients have obstructive disorders written in their medical history, but if you look at the results of the spirometer, then you can see that they don't have any obstructions as such. This is not an obstructive disease. This is associated with the weakness of inspiratory muscles, a small volume of inhalation, and the impossibility to inhale properly. So this is a clinical example. As you can see, again, this is an old publication. As I understand, this is a slow progressing patient. They observed him for 5 years. So this is the spirometric curves in the course of disease progression. Figuratively, you can see that this is a sort of a balloon, which first was, they used it well, but then you can see that there are almost no, of course, at the end of 1996, the patient had very, very low vital indicators and vital lung capacity.
This is not a patient with ALS, this is a patient with Duchenne's muscular dystrophy, but it's very depictive to show the changes in the respiratory muscles and the vital capacity. You see, the curve has two parts. There is the plateau and the downfall phase. This is because the disease develops in teenagers. But what's important here, when we have a series of the VC, when we have this data set, we can see the progress of the disease. If the patient is not losing VC in absolute figures, it's good, but when they have this drastic downfall, then of course we talk about a very aggressively progressing disease. So it's important to track. Sorry, let me switch it off. We can track this spirometry data, and this gives us a powerful tool, not just for diagnostics, but also to look at the progression of the disease. Next slide, please. Here you see the correlation. Can you enlarge on the slide? Thank you. Here you see the correlation. There is the inspiration peak and expiratory peak in ALS patients. What's important here? There's a certain group. There are patients in ALS with good MEP, MIP. They are in upper right. There are also patients with weak respiratory muscles. They are in lower left. And the patient actually moves from upper from the upper corner to the lower corner. Here you can see in the upper part of the screen there is a dependency of vital capacity and the strength of breathing muscles. In healthy subjects, they don't have much of the correlation, but in patients, we see it very well. As the disease progresses, as muscles become weaker, these spirometry indicators also go down. The VC goes down, which is natural. The weaker the muscle is, the lower is the volume that the patient can breathe in or out. This is confirmed in other nosologies. This is a group of neuromuscular patients with Duchenne dystrophy, and it also shows the same progression, how vital capacity goes down, and it's like 5% decrease every year. Almost all neuromuscular diseases have this progression and the same dynamics. So measuring it in series is very important, because we can immediately look at the disease profile. If it's highly progressive, which is progressive fast or not so fast. So there is also this very rare form of ALS when the motor function is restored, and now they are trying actively to find the predictors for this function restoration. Next slide. This is another correlation. Just a few words about it. Here you see the correlation in the upper left between the MEP and the coughing peak flow. It also goes down. So it's not only the VC that goes down. If you remember the previous slide with three groups, MIP, MEP, and coughing, it goes in parallel. The patient has difficulties with breathing, with coughing, and in swallowing and in speech. ALS patients develop all that simultaneously. This is a very interesting indicator. So what is happening as the vital capacity decreases? The spirometry and MIP, MAP are here changing. Left is 0, and then horizontally it's centimeters H2O. So in hypercapnia, it was measured in kilopascals here. So 6 here is the threshold. Hypercapnia in patients develops as spirometry metrics go down. They try to find the more detailed ratio, and well, it's difficult. For me, it's the MIP. MIP is a very good predictor of hypercapnia. VC is not as good as a predictor, but still, here you see it's 75% is of FEV. If you look up, there are 3 patients with hypercapnia, even though they only have a quarter of reduction in vital capacity. So it's not always a good predictor, but still, in general, it might be. This is a very interesting thing. I very often provide these as a point in arguments. Here, we don't really see the correlation between the vital capacity and the hypoapnea index, which means if the patient is developing apnea, it's not fully related to the to only the vital capacity reduction. There might be also rather relation to musculatory weakness, which makes sense, but still it's not very strong relation. So you see, patients with vital capacity 70 to 80%, which is normal, they still might have obstructive apnea with quite a high index. So when they detect apnea or desaturation in patients in normal vital capacity, there's a question: should we ventilate these patients or not? It's a very difficult question. But in terms of apnea, yeah, probably yes. But in terms of ALS, well, we have to think, because in this situation, it is not a manifestation of some breathing disruptions. This study is very interesting. The researchers here took, well, the initial recommendations are shown on the right. These were the threshold for breathing support, and they have shown low specificity and sensitivity of this method in percentage. You see, the results were not so good for PCF, for MIP. Well, the sensitivity was good, but the specificity was not good. So they tried to liberalize the threshold for indicating the ventilation, and they had the increase in sensitivity, but the specificity went down. This is a problem of functional diagnostics in ALS. Using functional diagnostics, it's not always possible to find the metrics when the non-invasive ventilation is indicated. This is another study in patients with Duchenne's dystrophy. I like it a lot. Here, they wanted to show which spirometrics are related to the development of breathing insufficiency. Here, the reduction of VC less than liter 820 showed the sensitivity 87 and specificity only 51. But if it was lower than 680, then the sensitivity and specificity were very high. So essentially, if the patient has less than 700 milliliters, then it shows that they probably need almost 24 hours ventilation through the mask or the mouthpiece. And probably John Bach is going to mention that. And also, you can look at the ratio of the vital capacity and volume. So there are some good predictors, but it's not always feasible. Breathlessness in patients with ALS. This is another symptom you have to note. Here, the information is that ALS patients have breathlessness with hypercapnia or without hypercapnia, but on average, it was higher in patients with hypercapnia. It has the score of 2 points out of 4 in this standing position, and you see the relation in sitting position. So here we also have the correlation between the breathlessness and the CO2 content. Yeah, here it's essentially a similar slide. Let's skip it. Let's go further. Another interesting study, which is often quoted, patients with 60% VC, they decided to check the ventilation through pulse oximetry and transcutaneous capnometry. In 38% they have found daytime hypercapnia, and also 26% had nocturnal hypercapnia detected. So essentially almost 70% are candidates for non-invasive ventilation. They had 8 definitions of hyperventilation at the moment. It was daytime hypercapnia, daytime excess of basis, nocturnal saturation, mean saturation, PDCO2 increase 55 millimeters for over 10 minutes, or the increase, and so on. These were 8 definitions of hyperventilation that were in the literature as of 2016. So the prevalence varied from 10 to 61% depending on the definition used. So it doesn't give us really a clear picture. Moreover, we have some ambiguities in spirometry data, which sometimes are predictors of hypercapnia, sometimes are not. We also have different definitions of hyperventilation that give us a different picture. Well, humans are not that robotic. So things change slowly, and if we have patients with ALS, we have to look at different hyperventilation definitions. We should look at blood gases and nocturnal pulse oximetry, look at VC and so on. This is how nocturnal pulse oximetry looks like. A real patient with hyperventilation during sleep. In magenta, we see a decrease of saturation lower than 88%, and this really was an outstanding case. The patient had saturation lower than 60 all night long. Of course, the patient needs respiratory support in nighttime, and maybe after some time they will also need it during the night. This is a device called Tosca, like the opera. Transcutaneous capnometry. This is one of the golden standards of diagnosing hypoventilation during sleep. This is another small example. This was one of my first patients. I think it was 2010 or even before that, maybe 2009. The patient had hypoventilation during sleep time. Saturation decreased to 85%, and during REM sleep, the decrease went down to 70%. Next slide. Here, there are capnometrics. The blue is capnometrics and the magenta is saturation. So you see CO2 is at 50, when there's ventilation it goes down to 40. Then she had a leak. You see the mask fell off and the saturation changed and the CO2 increased slowly, but then it also went down, and at 2 o'clock it's only 40 millimeters of mercury. There are other important symptoms that need to be mentioned, the symptoms of hypoventilation. There is the increased daily drowsiness. We have the Epworth scale. It's universal for the screening of breathing disruptions. We have morning headache, fatigue, incomplete sleep, often waking up. And I often ask patients how many hours do they need to be rested when they sleep. And there are other symptoms: no dreams, nightmares, or when patients want to go to the toilet. Apnea is not specifically a symptom for ALS. We have said that there is no direct correlation with vital capacity decrease, and also snoring actually decreases as muscles weak. So and the patients also lose weight and they stop snoring, but unfortunately it doesn't protect them from respiratory insufficiency. So treatment of this condition is non-invasive ventilation. We have four options of breathing failure. We have two variants of hypoxemic and hypercapnic. It can be acute or chronic. So for our patients, it's only about hypercapnic ventilatory failure, because essentially all the breathing insufficiencies are because of the accumulation of the CO2. Thus the need for non-invasive ventilation. Here we see the Mech method of respiratory support. It's used in both children and adults through nasal or nasal-oral masks. It can be used at home or for inpatients, and of course it's a long-established procedure. Neuromuscular patients were one of the first patients who started having non-invasive ventilation with very good results. Yeah, this is once again how patients with neuromuscular diseases, or not only neuromuscular, how they look. They are adapted to masks quite well. Some use mouthpieces, some use full face masks. And there's an important secret here. The more masks you have, the higher is the chance that you will be able to choose a proper ventilation parameter for your patient. If we talk about breathing insufficiencies, I can't say this that clearly. They can be acute and chronic. Well, acute usually is when there's infection episode or atelectasis, sometimes there's sputum stasis or something else. And chronic, so they can progress from small episodes of this saturation to 24-hour insufficiency. Acute breathing insufficiency is like an episode. The indications are any hypercapnia, any hypoxemia, breathlessness in rest, breathing rate over 25 a minute using additional muscles, or paradoxical breathing. Any patient in whom 3 out of 5 of these criteria are found is a candidate for non-invasive ventilation. If the patient has a cold, and 3 out of these 5, it is a direct indication for non-invasive ventilation in acute respiratory insufficiency. This is one of the latest recommendations from 2016 by the British Thoracic Society, and here they talk separately about acute respiratory failure, and for neuromuscular diseases they have the corresponding recommendations. You'd see that there's respiratory acidosis. Anyway, you can open these recommendations. Just open the British Thoracic Society. It's all available for free. There are very good algorithms and guidelines. Next slide, please. Quite a good review on acute respiratory failure, but let's skip it. Prolonged and continuous ventilation. Well, this is a situation when the disease is progressing slowly. In 1999, there was a very good report in the Chest magazine, which had a chapter on neuromuscular patients. So the indications for ventilation in chronic failure, the hypocapnia is over 55, and the nocturnal hypoxemia is lower than 88% for over 5 minutes. You see, the neuromuscular patients are the only patients where, from since 1999, you can use only spirometry as the indication for non-invasive ventilation.
So the recommendations were extended. I really like the recommendations from the German Pulmonology Society. The revision of recommendations was in 2017-2018. For neuromuscular diseases, there are very strict indications: any hypercapnia in the daytime, any in the nighttime. more or equal to 45 millimeters. Difference daytime, nighttime 10 millimeters. Also, the increase of more than 50 millimeters for more than 30 minutes during the night, and also the lowering in 3 months by more than 10% in 3 months for VC. So coming back to the beginning of the lectures, measuring this lung capacity at least once in every 3 months are necessary to find fast progressing patients with ALS. So there are other recommendations of 2016 for patients with ALS to offer ventilation when the respiratory function is disrupted, when CO2 saturation goes, hyperventilation systems are present, VC less than 50% insults, or less than 80% forced ventilation plus symptoms, or the same for SNP less than 40% or less than 65 plus symptoms of hyperventilation. Here we show several situations which are not really clear. For example, the patient has good VC and doesn't have any symptoms. We want to offer ventilation, or for example low VC and there is hyperventilation. Of course we are going to offer, but there are also two categories of patients: when there is low VC but no symptoms, or for example when there are manifested symptoms but no decrease in VC. Then of course we have to do some additional examinations to, so to say, catch the patient that we need. So that is why my question is the following: should we break recommendations and start early ventilation support? I think yes, we have a lot of data to say that ALS can be very aggressive and have early progression. Here we have the data from a small study, 36 patients randomized. Early start of ventilation for patients with early onset. There was a small improvement in the prognosis. Also a small group of patients, if the VC was more than 75%, less than 75% with ventilation and without ventilation, then we see more or less the same results for patients with less than 75% VC against ventilation. Their survival is comparable to those with normal VC. So we can influence. Starting from 75% of capacity, according to the study, you can start ventilation and achieve better survival results. The retrospective survival analysis, depending on the time of ventilation onset. Here it is hard to understand the cause and effect, but maybe in case of early ventilation, there was more time until lethal, and maybe also it lowered the risk of tracheotomy about twice. So that's also another argument for early ventilation. Also, this was a small study. Early ventilation in case of VC of 76 to 79%, 2-3 hours a day only of ventilation. Here, most probably because there were very few hours ventilation, the survival wasn't different. Maybe, unfortunately, if the protocol was stricter for non-invasive ventilation, then they would have managed to achieve more marked positive results. Another study. Ventilation started again with VC of more than 70% and daytime symptoms present, or more than 75% plus desaturation index less than 15. The difference was shown in favor of those who had desaturation, and actually there was no fall in lung VC. Because, of course, ventilation cannot influence neuromuscular degeneration. Observation protocol. The patients were observed against the background ventilation, evaluated their symptoms every 3 months, symptoms, spirometry, pulse oximetry, and gases in arterial blood. Turned out that the patients who were clearly observed every 3 months had better survival rates, which I believe is an additional argument in favor of early ventilation and also regular observation of the state of such patients. So some information about bulbar patients. This is a ventilation regime showed better advantage for patients with bulbar ALS and also better survival rates. That's in favor of saying that bulbar ALS is not a counterindication for non-invasive ventilation. And also, using special regimes, you can conduct such ventilation. Is that then the following one? A bit more about sputum discharge in the cough. That's a problem that ALS patients have. They recommend 2 methods here. That's manual methods, using AmbuSec for expanding the lungs, and manual compression of the chest wall, and active coughing using cough assist device. You saw the video of that in the beginning of our event. There was a demo for this device. For ALS patients, you can use standard approach for determining peak cough flow. If their results are lower than 270 liters per minute and they already have symptoms of sputum stasis, we have to offer some manual methods of sputum discharge, or if their peak cough flow is lower than 180 liters per minute, then we can offer them this artificial replacement of cough function, this cough assist device. The main mistakes that we encountered, that's oxygen without ventilatory support. That is a counterindication for ALS patients. Mucolytics without cough assist, and again, similar to oxygen, the amount of sputum only grows, and that has adverse effect on patients. Ignoring respiratory support for patients who already have indications for ventilation, and intubation, and without the attempt of non-invasive ventilation. I believe that after listening to our presentations today, you are not going to make these mistakes, and you are going to offer your patients cough assist and a device for non-invasive lung ventilation. There are indications for mechanical lung ventilation. I think this is a more ethical issue. Of course, we can talk about urgent and regular indications. As for the urgent ones, that's intolerability of non-invasive, inefficiency of non-invasive ventilation, severe bulbar syndrome with aspiration, inefficiency of non-invasive sanation of airways. What does it mean? It means that before intubating the patients, we have to try non-invasive ventilation first. We have to see that it is not efficient and not tolerated well. We have to try cough assist. We have to see that it doesn't manage the functions. Only then the patient can be intubated. Plantar tracheostomy is also possible. That's upon the consent and wish of the patient. More than 20 hours of ventilation is needed. And for example, there is severe breathlessness which cannot be corrected. So to sum up, presently, there are many ways to evaluate indications for non-invasive ventilation. And first of all, these are symptoms, patient survey, patient examination, non-invasive method for saturation, nighttime, daytime pulse and oximetry, spirometry as well, and a great role is played by changes observed at least once every 3 months, sometimes more often, strength of respiratory muscles, which is more precise than spirometry, night pulse oximetry, that's an accessible and simple way to diagnose during the time, capnometry, if possible, gases in the blood if you have the chance to do so. And also, there are several recommendations. There are classical recommendations, general ones. There's Chest Journal, 1999, and the German Society of Pulmonologists. There are also some specific recommendations of ALS Patients Association. And probably my main message here is that presently we can recommend ventilation to patients on earlier stages of the disease if there are symptoms and VC less than 75%, or even more as a way of prevention, or for example proactively, as they say, without waiting for respiratory problems to develop. We have to provide this non-invasive ventilation, because if we hurry a little bit and we provide the device 1 month early, it's not going to be as scary than if we are late 1 month with the non-invasive ventilation. That is why a proactive ventilation idea, that is the main message of my presentation, which I would like to wrap up with. If there is a chance for ALS patients to provide this device, it is better to do it beforehand without waiting for serious respiratory issues. If there is no chance to do so, then you have to be as careful as possible when following the respiratory indications among the patient. Thanks a lot. Thank you, Vasily. Here, I would like to discuss with you a little bit and ask you several questions to clarify. Yeah, of course. Your recommendations about your vision that we should provide ventilation to ALS patients as early as possible, based on some objective criteria. But still, we have experience of working with patients who do not want to have ventilation. Even when they're fully informed, they still refuse. There are patients, but that's already the second question, who actually have no access to this type of assistance. So I wanted to emphasize for our audience, and you'll probably agree with me, that such treatment is to be discussed with the patient's family. You have to explain the advantages and disadvantages, and our task as the doctors is to talk to the family, to discuss it, and to bring that message home to them. And it is quite possible that the family and the patient will refuse from early start of ventilation, or maybe agree to that. But then they also have to understand all the pros and cons. Do you agree with me here? Yes, I do. Well, it's interesting because ALS is a rare disease, and there are not that many patients with it. At least fewer than those with the corona virus, but it has lots of aspects, and I simply chose one aspect to consider during this hour that I had. This is the aspect of mechanical respiratory support. And of course, there is an aspect of symptomatic assistance right next to it, when the patient can refuse early ventilation and also refuse proactive ventilation, choose the method of symptomatic correction, and then the patient is going to be right in his or her own way as well. When I was preparing for this presentation, I based it on the assumptions that mostly, at least now, despite all our efforts, most patients in the country are not on a way towards something. I mean, they are not informed enough, and therefore the disease progresses spontaneously. So now I was trying to convince those doctors who are listening to us now, who will be listening to us, that there is this method to assist the patients, non-invasive ventilation. But of course, I think that we should further discuss some palliative approach for balance. That there are some other ways to lower the severity of symptoms in the patient. And non-invasive ventilation, apart from many advantages, also has many disadvantages. We didn't talk about lesions and all that. Yes, we'll talk about that later, but just wanted to make this little remark. And now just several short questions. I ask them quickly, and then you answer the question quickly. Okay, then. So, let's suppose that we divide these respiratory problems before the symptoms, an early stage of ALS, and then there is stage of symptoms, and there is greater. So early stage. To sum up, what are the methods that you believe to be adequate for diagnosing respiratory insufficiency? So for early pre-symptom stage, so that we are proactive in NIV, if, for example, the patient consents to that. What are the methods of diagnostics at the early stage? At the early stage, is spirometry, plus spirometry, both prone and supine, and the strength of respiratory muscles, and probably screening for hypoventilation, either survey or some conversation with the patient, and also Epworth scale. I think that in this situation of pre-symptoms or early diagnosis onset, we are not talking about respiratory issues in the patient yet, but okay, answered. Okay, nighttime. Actually, nighttime pulse oximetry is already for the symptom stage. At the early stage, it is not going to yield any meaningful results, and even if it does, it must probably due to some accompanying diseases. Okay, the symptom stage, when it is about control of ventilation efficiency, like you start ventilation, how do we control its efficiency? What diagnostic methods do we use? Daytime pulse oximetry. If there's chance, also daytime gases in the blood, night pulse oximetry, and if possible, capnometrics. So these are the 4 methods that we use. Okay. And if we talk about the grave stage already of the disease, is there a point to keep controlling the breathing function? That's a very good question. It seems to me that during the grave stage, we talk more about the symptoms here, because the grave stage is the stage of grave symptoms, and we should not refine our art in adjusting the device. We have to help the patient manage those severe symptoms. In this grave terminal stage, we move more towards palliative care. We have to pay more attention to the symptoms and to some mechanical changes in the patient's state. Okay, then, thank you for your presentation, for your answer. There were also questions about MIP, MEP, and SNP. What is this or what? Yeah. Okay, actually in the beginning I provided definitions. MIP is maximal inspiratory pressure. This is the strength of inspiration muscles. MEP is expiratory muscles. And SNP is the sniffle nasal inspiratory pressure, which is actually measured in the nasal canal. These are the methods for diagnosing breathing. They can be measured if we are in the functional diagnostics. And the method is very simple. The patient with the mouthpiece breathes in the tube. The valve is closed completely. The patient makes the strongest inhalation possible, and then the device measures. Then the strongest exhalation, and also the device measures the pressure in the airways. There are non-invasive devices working according to the same principle, and you can use this sensor into the nose. You close one nostril, and the patient inhales through another one, and the pressure is measured. I actually saw great intensive care experts in 64th Hospital, if you know where that is, who, when they weaned the patients off the system, they constructed from the old manometer the device for measuring the strength of musculars, and actually also the device for peak cough flow measurement. These intuitive things very often emerge when we work with respiratory patients and we want to objectively measure their results.
Это давление, которое...
I would just like to add that SNP, the nasal pressure, well, at least the specialized centers are using this to measure when the mouth muscles are weak, when the patient can't hold the mouthpiece. Then we can use the sniff test, and this is a good indicator that can change the VC measurement when the mouthpiece cannot be used. So the question whether the certificates will be provided. Yes, they will be. Well, oxygenation was not probably for this thing, and we will have another discussion when we'll have our international speakers talk about the minuses of the non-invasive ventilation. Well, the three presentations which we'll have after lunch, they will go into detail about the advantages and disadvantages. You will hear what they got to say. There will be interpretation, don't worry. The non-invasive ventilation, it will also be a topic after lunch. Now we talk about the diagnostics of breathing irregularities. Inaudible question. Can this prevent laryngospasm? Well, let us have it also after lunch. All these questions are gonna be answered as much as possible, of course. Oh, I have another question on how much time is required for ventilation. This is also a topic for after lunch. Stay tuned. There are a lot of interesting things. Vasily, thank you. Thank you. Once again, I would like to say thanks to Philips, which supported this conference. Now we will have a small promotional video, and then we will talk about rehabilitation in ALS and respiratory rehabilitation. It's an interesting topic, highly relevant for our patients. So stay tuned. You will hear the next presentation after the video.
A long way, but it's still not seamless. Systems don't always communicate. Clinicians can't always see the full picture. Patients can feel lost in the system. That's why Philips is on a mission to remove the limits of care, helping people manage both illness and health with clinical intelligence that helps to get it right the first time, bringing data, technology, and people together seamlessly. This is what drives us. It's what gets us out of our beds, to help get people out of these beds, healthier, happier, faster. Because today, health knows no bounds, and neither should healthcare. Innovation and you. Philips.
Меня поправляет.
So, I would like to clarify regarding the certificates. We cannot allocate any more NMO points, but you will have a certificate, a letter which says that you took part in this conference. So, if you're interested in having this letter, then of course we can provide it to you. Next presenter is Timur Ivanov, the neurologist and rehabilitologist who had big experience managing patients with ALS. As a, rehabilitologist or a physical therapist, he will give more information on what are the methods used for rehabilitation. Timur, the floor is yours. Hello. We'll talk about physical motor rehabilitation. As the topic is respiratory insufficiency, then the focus is going to be on breathing exercises, but I must know that breathing exercises is only a part of a big set of physical rehabilitation in a comprehensive approach. And then the next slide. We'll talk a bit about the experience of managing patients with ALS. I see patients in our rehab center. I have about over 200 centers that we're consulting in our center and over 2,000 sessions. So I have some experience managing this disease, and I will try to summarize it. So, we will talk about applications of physical therapy, exercises for ALS patients. As it manifests in decreased respiratory function, well, we presume that there is a natural progression of the disease, so the task of the physical therapy is maintaining respiratory function on every stage of the disease. So, the foundation for my 2 days presentation is several studies on the effectiveness of physical therapy techniques to patients with ALS. In 2016, there was a series of studies which wanted to assess the effectiveness of different methods. They included breathing exercises, pulmonary devices, training devices, the ambu bag, and auxiliary techniques. The results of these studies have shown that the biggest effectiveness is there in breathing exercises and in training devices. And also it was proven that this influences the lifespan and life quality. So it's important to use all possible methodologies we can offer. Unfortunately, there are not so many in physical therapy, but still, one shouldn't neglect those because it's all backed up by evidence. Unfortunately, there are not so many studies in general, as well, the disease is not that widespread. But I hope that these studies will continue, will go on. In our country, we also have some experience. We could actually have a study here on the effectiveness of different physical therapy techniques. As I said, the disruptions of the breathing function in ALS patients can have different manifestation, and the task of the physical therapist is to start the application as early as possible to help with the symptoms. So the main application points, what do we work with? First of all, we want to preserve the pulmonary function. We want to maintain coughing strength. We want to make breathing easier. We want to provide the patient with techniques to maintain the rhythm and volume so that they would be more skilled. And so that they would use this exercise to improve how they feel. This all helps preventing secondary complications. And of course, in ALS, the rate of pulmonary complication is quite high. So, rehabilitation is a very good thing to help prevent the complications. Another task is to try and to expand the autonomy of the patient so that they would be free from additional machines and devices. The task at this stage is to try to extend the autonomy period as much as possible so that they would be free from additional devices. And the reduction of distress and anxiety. It shows that physical exercises, including breathing exercises, they improve the mental and emotional condition. When people see this effect of this, they are less anxious, they have less laryngeal spasms, because it also can be corrected through relaxation techniques and breathing. Positive results can be achieved. Let us move on and let us start talking about the main principles. It's very important for patients with ALS to have proper positioning. And it's the main foundation for physical therapy, for pulmonary physical therapy, as the diaphragm, the main muscle, which is the strongest muscle that takes part in breathing, it has to be properly positioned. It has to be relaxed. And as muscle weakness develops, as palsy develops, patients often are in this crouched position, which causes complications of breathing in, and the chest essentially is kind of locked, so the volume also is lower because of that, because the diaphragm is not used and pectoral muscles are not used at all. So it's important for the patient to have a non-crouched position. If we talk about prone position, well, the head still has to be kind of elevated so that there would be no curve in the lumbar region. For example, on this picture, it's not actually very, very good position. We see that there in the lumbar region there is some caving, so some support should be put behind the lower back so that the diaphragm would be fully relaxed. And when patients are in this position, from my experience, I saw that usually the excursion of the chest is lower, so it's more difficult to breathe. So in the positions on the side or in prone positions, some additional support should be added. Essentially, in prone positions, it's not very comfortable for patients. Most choose either on the side or semi-sitting position. So proper positioning is very, very important. It ensures less discomfort for the patients. When we talk about the position on the side, sometimes it's difficult to elevate the head, we recommend to use these long cylinder pillows that would help relieve parts of the patient's weight. It can be used under the arm, and also it can be used for the positioning of the head so that it would be straight and proper. And then it would be comfortable for patients. They would not feel breathless, because very often if we have sessions at home, we try to find the position where breathlessness stops. So if the patient had difficulty breathing, they go into this resting position, then the breathlessness stops. If, for example, the patient finds difficulty sitting all the time. So, once again, and this is important. And also, the mattress shouldn't be way too soft when there's not enough support. When the person lies curled as if in a hammock, it's also not good. When the mattress is firmish, it's usually more comfortable for patients. That is why we always recommend using functional beds. This is also important because functional beds can help elevating the head bit. And this position is very useful. We can have physical exercises. Once again, as I said, it's important also for the patient not to slide down into this crouched position, which provokes the decrease in the quality of breathing. I would also like to add about standing position. If the patient has weaknesses in the muscles of the trunk, then in standing also the center of mass can be tilted frontally, and first of all there's a risk of falling down, and also the quality of respiratory function is decreased. So if the patient is standing, they also should be properly positioned. Then they can be longer without breathlessness. In my experience, when we were selecting orthesis for patients, I can recommend the chin support that would keep the chin up so that the head would not get tilted down or shifted forward. And then it makes it easier for them to work, and they find it easier to breathe. Number 2, it's always good to have different types of reclinators that will support the straight condition of the spine. But of course there are its nuances. The nuances are that most ortheses, when people buy them on their own, when there are these classical elastic ortheses which are very wide, sometimes they go over the lower chest, they are not really good in this case because they limit the chest excursion and people feel breathless. So you need to be very peculiar with the model, which would help a body stay straight but would not limit breathing. I favor the 8-shaped reclinator when it goes around the shoulders and at the level of the shoulder blade. It helps the shoulder blades stay together, and so there's no crouching in the chest section, and the clavicle is extended. This is actually the orthesis which is often used for clavicular fractures, but also it depends on the patient, because sometimes when the muscles are too weak and you put on an orthesis, there's pain syndrome, so one should put some cushioning so that the pressure would be not too high.
In general, the patient knows that when we use a recliner during walking or when they have to sit for a long time, especially when there is no back support, that helps them to keep the equilibrium and their balance, and they feel less breathless. As I have already said, for the holder, it's also very important to use that a special orthesis which is based on the chin, and the second part is fixed on the chest, so that the patient could rest his head or her head and not to hold it constantly in a tense state. As most orthopedic ortheses, which just restrict movements but do not provide support, they don't work for most patients. They buy them, but they are just as tired, and very few actually work. And the ortheses which actually provide a rest for the head, they allow to walk longer and to sit as well, and they also lower the frequency of breathlessness attacks, and it's easier to work on breathing exercises when these devices are used. Let us talk a bit about physical exercise. What kind of physical exercise we use in our work? First of all, having analyzed the study on breathing exercises, even such regular procedure as deep breathing with short breaks can help the improvement of well-being and breathing if you do it regularly. The task is to draw a deeper breath in and a deeper breath out. The technique is about occupying a comfortable position so that the person doesn't go down, because even in this crouched position with lowered head, the patient will never be able to make a proper inhalation. It's just going to be physically hard for them to do it out of this position. So before you recommend this exercise, pay attention to the position of the person, if they are comfortable enough, if they have support. If we talk about prone position, it is best to use armchairs with high back and also with the headrest, because the weakness of not just back muscles but also the neck muscles do not allow do not allow the patient to sit well, and the head bobs forward, and it is hard for the patient to breathe well. But with the rest, with the headrest, the patient is not tense to maintain position, but if you are already comfortable, then you can work out good breathing. Here you need not rush. The rate has to be average or slow, and you have to strengthen on the length of inhalation and the length of exhalation. The longer they are managed, the more efficient the breathing is. Actually, there are much more breathing techniques, both like in traditional therapy, but also there are non-traditional, like Qigong or yoga. They can also be used to help patients with breathing disorders. Here it is important to match them at a certain stage when a person manages this exercise still, so that it is not too hard and it is not too tiring. One of the principles of supporting rehabilitation for ALS patients is that the exercises need not be too hard. There shouldn't be too much fatigue after that, so that the person just does it, and then after that they feel very tired and they have to restore for a long time. So these exercises have to bring this feeling of a physical load, but they shouldn't be too much. Sometimes it is hard to match it. I said that okay, it is at least 10 inhalations, but for somebody even 10 can be too much. So they have to start from 5. For somebody 10 can be too easy, and they can do 15, for example, during the exercise. So here you have to evaluate the initial state of the patient and therefore select this individual frequency of this exercise. As I said, there are lots of them with active application of abdominal muscles. And this depends on how the muscle's activity is preserved, and also involving additional muscles. If we talk about initial stages of the disease, then actually there are no counterindications for these exercises. If, of course, there are some challenges, then some exercises are going to be very hard to perform, and it is better to not use them. Also, there is a big problem that we have to face is the coughing. Very often they suffer because they are unable to cough. This is very uncomfortable. This lowers the quality of life. And we also teach techniques which are mostly about active involvement of abdominal muscles and the movement of the spine. If the arm strength allows, self-help also used. You have to help yourself to do active exhalations, especially in the end of the exhalation. You help with the cough to try coughing using this crouching. This can be either self-help or we teach relatives and carers. You push on the lower part of the chest, and together with the patient, they help them make this intensive final exhalation and cough. Sometimes this approach is something like any approach but we don't use the fist. We use the palm there between chest and abdomen. When diaphragm is attached, and we also help to strengthen this abdominal push so that we could help the patient's cough. Very often we also need a rest. If there is a muscular head muscles weakness, you have to stand behind the patient, also hold the head of the patient so that he or she doesn't spend too much effort to maintain the head, and so that the patient could make those pushes, and sometimes they manage to do it very well. We have to try coughing in every way. Sometimes they can't manage doing it in the prone position, but very often they manage to do it in the position of lying on the side. You also have to be comfortable, put a cushion behind, and then you can try helping the patient cough in this lying on the side position. Also using self-help when the patient helps him or herself to make that push during the coughing reflex, or the care helps. Okay, let us move on. This is a big part of breathing exercises is the use of additional devices, auxiliary devices. We have great experience of using breathing devices. One of them is the Philips device. There are two types. One of them for inhalation and one for exhalation. So the main point of this device is that they create resistance with the help of a valve. The valve can be regulated to create resistance to inhalation or exhalation. There is a scale, which is very important because we can by looking at the scale, we can regulate the load on inhalation, exhalation. We match a certain load that wouldn't overtire the patient, so that they could manage inhalation and exhalation. It's easier to exhale most often. The inhalation device is harder to use, so here you have to look closely and to choose the load. You have to try what the patient can do, and out of that maximal thing that the patient can perform, we leave 50 or 60%, so that the patient could make several efficient inhalations. Mostly we recommend to perform 15 cycles, inhale, exhale, using both devices, both for inhalation and exhalation. This is done daily, and 2 days rest. So 5 days workout, 2 days rest. From my experience of maintaining patients, this yields very good effect, especially the initial stages. We measured VC when the person came to consult. In a month of repeated consultation, we did repeated measurement of VC. In my practice, about 10 people actually even had better VC the second time round. Because a month is not a big period in time to say that this is a sort of a long-term effect. Of course, this is a compensatory effect because you train muscles that weren't used previously, which are now more included. But this also says that still, this is a workout for the patient. As I said in the beginning of my presentation, there are studies which confirm that. And also, I wanted to tell you a bit more about the use of this device, as well as doing spirometry. And the patients with bulbar ALS, very often they have weakness in facial muscles, and it's hard for them to actually catch and hold this mouthpiece on the device and do a proper inhalation exhalation. But we found a way out. Instead of a standard mouthpiece, we use a cane, which helps to actually hold it all tighter and do the breathing workout using this device. Sometimes there are challenges with holding to it because there are, for example, flail arms, and it is hard to hold it in your hand. And before that, you also have to clamp it on, to clamp the nose, so that the air doesn't escape through the nose, but only through the mouth. So the patients need assistance when there is that, and some of them you have to fix this device, for example, on the table, on a sort of stand, because not for everyone it is comfortable to hold it. Sometimes it's just impossible to do it, and the patients complain that it is hard to actually maintain this. So, for example, some things have to be fixed on it, and then it helps to change the cane. So where would you get that cane? Sometimes they're sold separately, sometimes they are not. They might be suitable for spirography, for example, but they are not sold everywhere. Sometimes patients have a hard time finding them, but there is a good solution: to take a cane from the diving mask. So this is a mask which is used for diving, made out of plastic, the simplest one, but this should be adult mask, not for children. The children's masks do not match. The radius is wrong. But otherwise they work very well. Sometimes sometimes it doesn't, it's not sealed very well, but you could use several layers of tape to remedy that. And also the patients can work out using this device without any problem, even though before they couldn't hold the mouthpiece, the traditional mouthpiece, correctly. Of course, there are some criteria who we prescribe this device, who we don't prescribe. Of course, we prescribe it if there are some manifested changes. The patient won't be able to do a full-fledged workout. And according to our criteria that we selected, less than 60% of VC, that means that we do not already prescribe this workout. If it's 60% or more, then we recommend the patients to use this respiration device. Also, apart from that machine, we have an experience of using AmbuSac. We have big experience of using AmbuSac for children, for patients with spinal muscular atrophy. And also in the study that I quoted in the beginning, it actively uses that technique of inhalation, strength inhalation with the help of ambu bag. In my practice, I didn't use that bag too much, but according to other studies, you can actively try it. I think that's also a possible variant for supporting rehabilitation. So moving on. I also wanted to tell you about the methods and activities that you can apply. In case of respiratory disorders, we use a comprehensive approach. In our center, we also involve active classes with a speech therapist, because a speech therapist works not just with speaking, but also with breathing and swallowing. This therapist also helps patients do certain exercises that ease their breathing. As speaking is directly connected to breathing, that means that classes with speech therapist help maintain breathing function. And also, lately we have been actively using all over the world. Such direction is developing as music therapy. In our center, we also applied it for some time. There are whole protocols of music therapy to with breathing exercises, and music therapy itself has an active impact to improve respiratory function. There is a study that you can also refer to about the efficiency of this therapy for breathing disorders. And I'm already reaching the end of my presentation. What else I wanted to say? Probably just repeat that breathing exercises and the use of these respiratory machines is just a part of comprehensive approach. This is not just physiotherapy, but all methods that we try to use for helping patients. That is why it's very important to include in your classes and your workouts not just breathing exercises that we have described in a lot of detail recently, but also other physical exercises, because there is a study on physical exercise that showed that using physiotherapy, workouts and exercises helps improve the state of the patient, and also indirectly impacts or even directly impacts the breathing function, respiratory function. That is why here you have to be as you have to use all approaches possible. You shouldn't just restrict yourself to breathing exercises, but instead use all methods of physiotherapy. And of course, this helps to improve the quality of life and extend patient's active life, which is also very important. Okay. So these are the sources that I used. Most probably that's it from me. If you have any questions, I'll try to answer those. Thank you. Yes, thank you, Timur. Thank you for the presentation, for sharing your experience. There is a question from the chat. I have heard that you could use singing as an exercise, both pleasant and useful. Well, as I have said, this is a variant of music therapy, and that's really useful, and it can be done. I also would like to point out that if you look at the website of our fund, in the patients section, there is a whole video of a class with a music therapist, which includes elements of singing, singing warm-up exercises. So, yes, this is possible, but it's important to understand that singing is also not a simple process. You have to understand how to use it correctly, how to use your voice. So I recommend you to watch the video with our music therapist. There is a class on improving respiratory function. Okay, from myself, I'm just going to add that we participated in a study of music therapy and its efficiency to stabilize respiratory function as well as speech and swallowing. Hopefully the results will be soon published. But it is important to note that music therapy is a therapy which puts forward certain tasks to stabilize this or that indicator which deviates from the norm. but this doesn't cancel out examinations and objective criteria. So depending on the set of problems that are identified, this is one of the ways to intervene.
So it's not just singing something. It has a therapeutic effect with certain indication, and musical therapy might also include playing instruments, and talking to the teacher, and there are many aspects. In our country we already have it, and as far as I know, Mr. Hello, Professor Hello is the most well-known specialist in musical therapy. So if you have some professional interest, take a look at these courses. Well, I don't see any more questions from the chat, but I would like to ask one question on my own. In your experience, have you seen a lot of effect from pulmonary rehabilitation? Like, how do the patients describe the effect of these exercises? Because now, well, there is this trend, and there was even a study in the US about the impact of pulmonary rehabilitation on the metrics of ventilation. Now we don't, in our country we don't have that evidence that it really helps. But as there are not so many patients, often even the feedback, which even might be anecdotal, but still it's useful. Do you have any of these case studies or examples of people? What was the effect? Yeah, these feedbacks, they come all the time. I can give a few examples. Like this morning, like in the morning, I had online consultations for patients with ALS, and just 1 hour before I joined in to this conference, with the patient we have discussed that they got some recommendations, and the patient was so thankful. They said, oh really, it does help a lot. So I just heard this positive feedback 1 hour ago. And if we talk about the general perception, the assessment, well, of course it helps. Of course it improves one's condition, because, well, breathing is an essential part of our condition. When we are nervous, when we are anxious, we have breathing rate going up, breathing is more shallow, so there is a clear correlation. Even if we are not talking about some therapeutic effects, there is a psychological effect. As soon as a person starts controlling their breathing, they feel calmer. In most patients, a note positive trend when they start applying breathing exercises. I don't think I have met a case when patients experienced some worsening or some negative effect of breathing exercises. Yeah, sometimes they find difficult to make it, but overall, mostly the perception is very positive. They are quite happy to use the techniques. Thank you so much for your responses, for sharing your experiences. I would like to say thanks to Philips, who helped us organize this conference. To say thanks to Живи Сейчас Foundation, the Live Now Foundation, which implemented all that. If you want, you could donate to this foundation. The link is there in the comments, because we plan a lot of educational activities which could be quite useful for practicing physicians, because there is a need for that. Thanks to everyone who took part in the morning session. Now we will have a break until 3 o'clock. At 3 o'clock we will have David Steinhorn from the United States, and he will tell us about two possible ways two possible paths which patients and their families and doctors could choose: the palliative or the curative path, to alleviate the symptoms or to compensate the breathing irregularities. How this choice is made, this is very important, but in most educational programs this is underlooked and underrepresented in literature. Next, we will have a presentation by Richard Sloan. And as far as I understand, he already is following our webcast. Hi, Richard. He was listening to the first part, and he will be here with us. He will be presenting in the second part, talking about symptom control and palliative care. Then we'll have a presentation by John Bach, who is a world-renowned specialist in ventilation for patients with neuromuscular disorders. He is an author of many books, and he is a guiding light for many when they have questions on non-invasive ventilation. So he kindly agreed to also join this conference. So this would be our lineup for the second half. And we will discuss summations of non-invasive ventilation, choosing the path for palliative care. We'll also talk about the Russian experience. I will try to also have lots of lively examples and probably some discussion in that part, so that also you would be able to hear answers to all the questions. So, see you after the break. And now it's time for some workout, for a quick bite. See you at 3 o'clock Moscow time.
Natural cough. Cough Assist T70 is an effective, comfortable way to help clear the airway. It gradually delivers a large volume of air to the lungs, similar to a deep breath, then quickly reverses the airflow to pull secretions out. Cough Assist T70 is designed to be easy to set up and operate. To power the device, press the power cord firmly into the back of the device and plug the other end into an AC outlet. If you prefer, you can attach the optional lithium-ion battery into the detachable battery slot on the back of the device. A DC power adapter can also be used to connect to an external power source, such as a car battery. Cough Assist T70 can be used with a mask, tracheostomy tube, or mouthpiece. To build the patient breathing circuit, attach a bacteria filter to the breathing circuit connection. Attach the circuit tubing to the bacteria filter. Press the filter onto the connector on the side of the device. If the patient will be using a face mask or mouthpiece, attach it to the circuit tubing. If the patient has a tracheostomy tube, place a trach adapter on the circuit tubing. If the trach has a cuffed tube, inflate the cuff. Help the patient into as upright a position as he can tolerate. Press the round Start-Stop button on the front of the Cough Assist T70 to enter standby. If the device is running on AC power, the button will illuminate. Check the treatment settings to make sure they match the doctor's prescription. Before the first treatment session, it's a good idea to let the patient feel the airflow so he knows what to expect. This is helpful when working with children. Consider giving the patient an opportunity to get familiar with the mask or mouthpiece. You may also want to work out a stop treatment signal in case he needs a break. Press the rectangular right button below Therapy to begin treatment. If you are operating Cough Assist T70 in manual mode, slide the control lever to the right to trigger an inhalation or press forward on the optional foot pedal. When the inhalation is complete, slide the manual switch to the left or press back on your heel for an exhalation. Position the mask, mouthpiece, or trach adapter on the patient. When using a mask, Make sure it is well fitted to eliminate possible leaks. If you hear or feel an excessive air leak during the inhalation period, support the back of the head with your hand or a pillow to improve the seal. If you're using a mouthpiece, nose clips may be needed. Instruct the patient to open his mouth and actively inhale during inhalation and exhale during exhalation, which will open the airway for unobstructed airflow. Ask him to keep his mouth open and tongue down throughout the therapy. Encourage the patient to be relaxed and passive during the inhalation and the exhalation cycles. When providing a treatment in the manual mode, you can see how long you are delivering the inspiratory pressure and how long you are delivering the exhaled pressure on the screen. The center position on the lever activates a pause. Depending on patient preference, you can pause for a few seconds after exhalation before initiating the next in-breath. Exhalation pressures appear on the left as negative numbers on the Cough Assist T70 screen. Inhalations are shown as positive. Both appear in real time. A simple screen view with less respiratory information is also available through menu options. The detailed screen provides additional clinical information. For the initial treatment, you may want to begin with lower pressures to give the patient a chance to get comfortable. You can gradually increase pressure as described in the pressure and timing adjustment portion of this program. A cough cycle is defined as inhale plus exhale plus pause time. Deliver 4 to 6 cough cycles in rapid succession, followed by a rest period of 20 to 30 seconds. Repeat this sequence, 4 to 6 cough cycles and rest period, 4 to 6 times for a complete treatment. When the treatment is finished, press the right button to halt the airflow and return to standby. The patient's prescription will determine how many treatments are to be administered each day, for example, a treatment every 4 hours. If the doctor orders the treatment as needed, the patient can determine how many treatments he receives during the day, depending on how often he's to clear secretions. Cough Assist T70 can be operated manually, which you have just seen demonstrated, or in automatic mode. In automatic mode, inhale, exhale, and pause times are controlled by the time settings entered. When using the cough track option, the device will automatically detect inspiration effort and respond with an inhalation. With automatic operation, there is no need to toggle the manual switch between inspiration, exhalation, and pause. Cough Assist T70 will do it for you and display the pressures in real time. Here again, the patient should actively inhale and exhale. You can pause the treatment at any time by pressing the right button under Standby. After the treatment, clear any secretions from his mouth, tubing, and patient interface. It is important to wash the breathing circuit and patient interface with mild liquid detergent and water. The parts must dry completely before next use. The bacteria filter cannot be washed, so you should replace it if it becomes blocked with mucus or trapped moisture. You should clean the air filter at least once every 2 weeks and replace it with a new one every 6 months. 3 unique prescription settings can be stored in Cough Assist T70, so you can quickly select treatment pressures based on a patient's current needs. On the upper right-hand side of the screen, if you see a small open lock icon, you will be able to make changes to the settings. Changes can be made to the settings during standby or therapy. A specific prescription can be entered during standby, but titrating is easier to accomplish during therapy. To enter prescribed settings, press the left button under Settings. A setting menu will appear. The first item on the list will be highlighted, in this case, Preset. Press the Modify button. You can select which one of the 3 presets you wish to modify. Press the OK button to confirm the preset. You can select other settings by using the center Navigate buttons. Let's say you want to change the pressure temporarily while a patient is being introduced to treatment for the first time. Use the center Up-Down button to move down the list until inhale pressure is highlighted. Press on the right button under Modify. Use the center Up-Down button below Edit to lower the pressure to the new setting. For an initial treatment, a low exhale pressure of -10 to -15 cm H2O may be a good starting point for an adult. Once the patient is accustomed to the therapy, Exhale pressures of -40 to -45 cm H2O may prove more effective at clearing the airway. Press the right button under OK. Press the right button under Modify to change the next item on the list, which is Inhale Flow. Use the Up-Down Edit button to adjust. If you try to change a setting beyond the available parameters, a Limit Reached message appears. In this case, after you have entered the correct pressure, press OK to accept the new setting. Use the right button under Modify to highlight inhale time. A typical inhale time for adults with a low flow setting is 3 to 4 seconds, 1 to 2 seconds in adults with higher settings. For small children with low flow, 1 to 2 seconds is typical, 0.5 to 1.5 for high flow. OK accepts the new inhale time. All the settings listed can be adjusted in this manner. When you have made all of your modifications, press the left button under Finish to return to standby. Cough Assist T70 comes with an SD card inserted in the SD card slot on the side. An SD card icon will appear on the top right corner of the screen. Your clinician may ask you to remove this card in order to review information about your treatment. From the standby screen, press Up on the center button under Menu. You will see a list of items. Use the down button under Navigate to move down the list until Safely Remove SD Card is highlighted. Press the right button under Select. A Remove SD Card message will appear to let you know that the card can be removed. Press the left button under Exit to return to standby. The SD card and other features make Cough Assist T70 easy for caregivers and patients to use in the hospital and at home. By simulating a natural cough, Cough Assist T70 is an effective, comfortable way to help clear the airway. It gradually delivers a large volume of air to the lungs, similar to a deep breath, then quickly reverses the airflow to pull secretions out. Cough Assist T70 is designed to be easy to set up and operate. To power the device, press the power cord firmly into the back of the device and plug the other end into an AC outlet. If you prefer, you can attach the optional lithium-ion battery into the detachable battery slot on the back of the device. A DC power adapter can also be used to connect to an external power source, such as a car battery. Cough Assist T70 can be used with a mask, tracheostomy tube, or mouthpiece. To build the patient breathing circuit, attach a bacteria filter to the breathing circuit connection. Attach the circuit tubing to the bacteria filter. Press the filter onto the connector on the side of the device. If the patient will be using a face mask or mouthpiece, attach it to the circuit tubing. If the patient has a tracheostomy tube, place a trach adapter on the circuit tubing. If the trach has a cuffed tube, inflate the cuff. Help the patient into as upright a position as he can tolerate. Press the round Start/Stop button on the front of the Cough Assist T70 to enter standby. If the device is running on AC power, the button will illuminate. Check the treatment settings to make sure they match the doctor's prescription. Before the first treatment session, it's a good idea to let the patient feel the airflow so he knows what to expect. This is helpful when working with children. Consider giving the patient an opportunity to get familiar with the mask or mouthpiece. You may also want to work out a stop treatment signal in case he needs a break. Press the rectangular right button below Therapy to begin treatment. If you are operating Cough Assist T70 in manual mode, slide the control lever to the right to trigger an inhalation, or press forward on the optional foot pedal. When the inhalation is complete, slide the manual switch to the left or press back on your heel for an exhalation. Position the mask, mouthpiece, or trach adapter on the patient. When using a mask, make sure it is well fitted to eliminate possible leaks. If you hear or feel an excessive air leak during the inhalation period, support the back of the head with your hand or a pillow to improve the seal. If you're using a mouthpiece, nose clips may be needed. Instruct the patient to open his mouth and actively inhale during inhalation and exhale during exhalation, which will open the airway for unobstructed airflow. Ask him to keep his mouth open and tongue down throughout the therapy. Encourage the patient to be relaxed and passive during the inhalation and the exhalation cycles. When providing a treatment in the manual mode, you can see how long you are delivering the inspiratory pressure and how long you are delivering the exhaled pressure on the screen. The center position on the lever activates a pause. Depending on patient preference, you can pause for a few seconds after exhalation before initiating the next in-breath. Exhalation pressures appear on the left as negative numbers on the Cough Assist T70 screen. Inhalations are shown as positive. Both appear in real time. A simple screen view with less respiratory information is also available through menu options. The detailed screen provides additional clinical information. For the initial treatment, you may want to begin with lower pressures to give the patient a chance to get comfortable. You can gradually increase pressure as described in the pressure and timing adjustment portion of this program. A cough cycle is defined as inhale plus exhale plus pause time. Deliver 4 to 6 cough cycles in rapid succession, followed by a rest period of 20 to 30 seconds. Repeat this sequence, 4 to 6 cough cycles and rest period, 4 to 6 times for a complete treatment. When the treatment is finished, press the right button to halt the airflow and return to standby. The patient's prescription will determine how many treatments are to be administered each day, for example, a treatment every 4 hours. If the doctor orders the treatment as needed, the patient can determine how many treatments he receives during the day, depending on how often he's to clear secretions. Cough Assist T70 can be operated manually, which you have just seen demonstrated, or in automatic mode. In automatic mode, inhale, exhale, and pause times are controlled by the time settings entered. When using the cough track option, the device will automatically detect inspiration effort and respond with an inhalation. With automatic operation, there is no need to toggle the manual switch between inspiration, exhalation, and pause. Cough Assist T70 will do it for you and display the pressures in real time. Here again, the patient should actively inhale and exhale. You can pause the treatment at any time by pressing the right button under Standby. After the treatment, clear any secretions from his mouth, tubing, and patient interface. It is important to wash the breathing circuit and patient interface with mild liquid detergent and water. The parts must dry completely before next use. The bacteria filter cannot be washed, so you should replace it if it becomes blocked with mucus or trapped moisture. You should clean the air filter at least once every 2 weeks and replace it with a new one every 6 months. 3 unique prescription settings can be stored in Cough Assist T70, so you can quickly select treatment pressures based on a patient's current needs. On the upper right-hand side of the screen, if you see a small open lock icon, you will be able to make changes to the settings. Changes can be made to the settings during standby or therapy. A specific prescription can be entered during standby, but titrating is easier to accomplish during therapy. To enter prescribed settings, press the left button under Settings. A setting menu will appear. The first item on the list will be highlighted, in this case, Preset. Press the Modify button. You can select which one of the 3 presets you wish to modify. Press the OK button to confirm the preset. You can select other settings by using the center Navigate buttons. Let's say you want to change the pressure temporarily while a patient is being introduced to treatment for the first time. Use the center Up-Down button to move down the list until inhale pressure is highlighted. Press on the right button under Modify. Use the center Up-Down button below Edit to lower the pressure to the new setting. For an initial treatment, a low exhale pressure of -10 to -15 cm H2O may be a good starting point for an adult. Once the patient is accustomed to the therapy, exhale pressures of -40 to -45 cm H2O may prove more effective at clearing the airway. Press the right button under OK. Press the right button under Modify to change the next item on the list, which is Inhale Flow. Use the Up-Down Edit button to adjust. If you try to change a setting beyond the available parameters, a Limit Reached message appears. In this case, after you have entered the correct pressure, press OK to accept the new setting. Use the right button under Modify to highlight inhale time. A typical inhale time for adults with a low flow setting is 3 to 4 seconds, 1 to 2 seconds in adults with higher settings. For small children with low flow, 1 to 2 seconds is typical, 0.5 to 1.5 for high flow. OK accepts the new inhale time. All the settings listed can be adjusted in this manner. When you have made all of your modifications, press the left button under Finish to return to standby. Cough Assist T70 comes with an SD card inserted in the SD card slot on the side. An SD card icon will appear on the top right corner of the screen. Your clinician may ask you to remove this card in order to review information about your treatment. From the standby screen, press Up on the center button under Menu. You will see a list of items. Use the down button under Navigate to move down the list until Safely Remove SD Card is highlighted. Press the right button under Select. A Remove SD Card message will appear to let you know that the card can be removed. Press the left button under Exit to return to standby. The SD card and other features make Cough Assist T70 easy for caregivers and patients to use in the hospital and at home.
Добрый день, уважаемые друзья.
Hello, dear friends, and we continue our conference on respiratory failures in ALS. I welcome everybody who has just joined, and I say hi again to those who have returned after the lunch break. The second part of the conference will take place in English mostly, so I will also use English But if you stay on this YouTube channel, you will be listening to the interpreters. If you want to listen to the presenters in the original language, switch to the English version of the webcast, and you can find the link to the English version of the webcast in the comments.
David, thank you for joining us this morning. I think you have just sunrise in US.
Yes.
And I want to introduce David Steinhorn. He's unique specialist in terms that he has experience both in critical care and in palliative care, and he can talk this so-called both languages, both with ICU specialist and palliative care specialist. So he's going to talk about choosing the way for patient with ALS, either palliative one or curative one. And just for you, David, to put you on one page with us, I would say that we had 3 talks before lunch. The first one about pathogenesis of respiratory insufficiency, on diagnostic procedures, and the third one on respiratory rehabilitation in patients with ALS. So thank you for joining us, and could you please tell us how to choose this way, please?
Thank you. Can you hear me now? So I'd like to thank Lev for the invitation to participate in this conference. We met several years ago when I was teaching in Moscow and did a consultation on an adult woman with ALS. And I'm going to talk a little bit about palliative versus curative approaches. Next slide, please. You're going to hear some of this same material from Richard Sloan when he speaks, so I will go over this very quickly. He can spend more time on this as needed. I think for the audience and the listeners, it's important to understand that the old way of thinking about palliative care and curative care is depicted in the top of the slide where it says curative, and when curative is no longer possible, palliative becomes the option. But I think that you all know much better than me that in patients with ALS, from the time of diagnosis to the time of death on average is on the order of 5 or 6 years, which means that the middle graph there depicting a decreasing opportunity for curative therapy is the norm for most of these patients with ALS, where there is decreasing function. Next slide, please. This is a contemporary discussion of the different ways in which we see death occurring for patients. We know that in the upper left corner, there are many patients who are healthy and then have a major loss of health. This can be a motor vehicle accident or a workplace-related injury or overwhelming sepsis, in which case death occurs quickly. In the lower left corner, we see lethal anomalies that are more common in the young child, where healthcare status is poor to start with, and they die in a matter of hours or weeks. The upper right corner, we see many treatable diseases such as COPD, congestive heart failure, liver failure, renal failure, in which the patient is healthy and then develops a diagnosis of a significant healthcare challenge. They are sick, we resuscitate them, we bring them back to a healthy state, then they may get sicker again, and they never achieve the same degree of health that they had before. And what you see in the ALS patients with cystic fibrosis and similar conditions is in the lower right corner, where there is a progressive condition where they get acute exacerbations, such as an aspiration pneumonia or other sort of acquired illness setback. We treat them and they get a little bit better. Then they have yet another episode of setback. We treat them and they get a little bit better. But progressively and over time, these patients tend to deteriorate. And that's what we see in the ALS patient. We see in patients with advanced cystic fibrosis as well. Next slide, please. All of our decision making is based upon good ethical reasoning and good ethical principles. If you look at the bottom of this slide, however, we're going to start there where I talk about ethical or cultural relativism. What this says is that the societal norms are important determinants of what is ethically and morally correct to do. So that in a society where there are infinite medical resources and opportunities for treating patients, there may be a certain standard of care that is professed for an ALS patient, whereas in societies and cultures where medical resources are much more limited, or where legal or societal norms may drive decision making. For example, treatment and resuscitation of elderly patients who have had strokes and are in congestive heart failure. This may be something that in some countries medical resources are not invested in. And in other countries, the patient and the family may have the right to ask for whatever cares they feel they want. But the ethical principles that in the West, the EU, and North America, and English-speaking countries tend to be focused on are autonomy, which says that the patient has the right for determining their health care. Beneficence, which says that we always work for the best interest of the patients and not necessarily for the best interest of society or for the insurance companies. Non-maleficence says that we will do no harm in our treatment. There's a lot of controversy surrounding this right now with all of the experimental therapies for COVID-19 virus, where there is significant concern about the use of things such as hydroxychloroquine, which in fact does have for certain patients the potential for significant harm. And so we have to be careful that we don't do things that potentially lead to harm. Justice says that we will provide fair and equitable use of our resources for all patients and not base the care upon the patient's socioeconomic status, their insurance companies, etc. Very important point here is the principle of non-paternalism that says that we do not make decisions for the patients, that we do not substitute our judgment for the patients. And this is, I think, very important because in many societies there may be a limitation of information provided to families, and the medical system may make the decision on behalf of the patients. And the last principle that we focus on is that of fidelity, which says that we're honest and truthful and we don't deceive patients based upon the information we give. Next slide, please. These are fundamental principles that most of us would agree to. Now, based upon that, I wanted to talk a little bit about medical bioethics. I started in bioethics early on early on in my career in the intensive care unit because I believed that good bioethical reasoning would help us make the best decisions for patients. But as you can see, I translated here in Russian that often what happens is that bioethics tells us what is ethically appropriate, but it doesn't allow us to make better decisions for patients, so that we end up providing extended therapy for patients that may not benefit them. Next slide, please. Patients all around the world have rights. These rights have been recognized by the World Health Organization, by the Russian Health Ministry, by the Council of Europe, and others. But again, cultural relativism says that what is right in one country and correct in one country may not be correct in another country. I recognize this and I acknowledge that even as I speak to you about how we would approach some of the ethical decision making in patients who have ALS. Next slide, please. You are clearly the authorities in the Russian healthcare system and understand better than I do how these sorts of principles can be applied, what is permissible, what is legal, what is socially acceptable. And so we have to keep that in mind as we have this discussion. And at the end of this presentation, I'm going to have two cases that I talk about briefly that will illustrate these points. The World Health Organization defines palliative care, and this will be in Richard Sloan's talk after mine as well, as improving the quality of life for patients, identifying and assessing signs and symptoms of distress and suffering, relieving suffering and distress in patients, and in particular treating pain and other problems such as psychosocial and spiritual distress that patients may feel. Next slide, please. The WHO says that we affirm the value of life. We accept death as a normal process. We don't intend to hasten or postpone death, and I think this is an important concept, that our focus is on the well-being of the patient and not a preformed agenda to hasten or delay death when it's a natural process. We focus on the comfort and quality of life for the patients, and the quality of life for the patient is often defined by the patient themselves. In the last case study that I will present of a 38-year-old with ALS, you will see the quality of life is defined by this individual. And next slide, please. There are 5 important questions that we need to ask patients as we get to know them and we form our relationship with them. We need to ask about the patients, what this patient was like before they became ill. Ask the patient what their hobbies were. Ask the patient what their life goals of care are, what is important to them. We have to find out how the patient understands their illness so that we can provide the necessary information so they can make their own best decisions. We determine what are their worries, what are their fears. We find out from them, where do you find your strength? Is it from your family? Is it from your children visiting? Or is it in God or Bible verses? Or do you find your strength in life in your work and feeling like a productive, contributing member of society? And then we have to achieve consensus. We have to find out what are the family's values, and we have to discuss what are the achievable goals. We know that in ALS patients that life expectancy is limited to 5 or 6 or 7 years, even with use of technology such as tracheostomy and ventilation. We know that life will be limited ultimately, and we have to determine what are achievable goals, what is realistic for us to achieve, and how does this fit with the family's values in preparing them for end of life. Next slide, please. In Western cultures, there are provisions for what are called advanced directives. You'll have to translate that. We have several different forms or documents, such as the healthcare power of attorney, which allows us to give the right for legal decision making to a third party when the patient cannot make decisions for themselves. We have a living will. That is a document that the patient develops in conjunction either with their families or their legal resources to define what it is that they want done as their disease progresses when they are no longer able to make decisions for themselves. We have do not resuscitate orders that are very common in North America that define very clearly the extent of medical care that the patient desires. When the healthcare status deteriorates or when cardiorespiratory insufficiency develops, and we assure that the patient's wishes will be carried out if they are no longer competent to make decisions. Next, please. I sent to Lev Briavlev, and I hope that he sent this out to you as well, a document that is in Russian that's called 5 Wishes. The 5 Wishes is a very common worksheet for patients and families to help them frame. They're important decisions used when the patients are still cognitively intact and able to make decisions and discuss things, and avoiding the question that does not make death go away, which is to say that by not asking the patient and the family these questions and not having them deal with these questions, we don't prolong life and we don't prevent the deterioration that will occur. So it's important for physicians to take the initiative, or social workers or chaplains to take the initiative to discuss these issues with the families. Next, please. The 5 questions that are on the 5 wish list are the following. Number 1, who is the person that I want to make decisions for me when I no longer can make these decisions? This is something we need to ask the patient and their family to think about and to prepare for when the time comes that the patient can no longer make decisions for themselves. What kind of medical treatment do I want, and what treatment do I not want? We have many patients and families with advancing motor neuron disease who do not want to have a tracheostomy and mechanical ventilation done, but they may want non-invasive ventilation with BiPAP, CPAP, or other sorts of non-invasive treatments done to provide comfort, to optimize the quality of their life, and to prolong their life reasonably, but not to prolong their life artificially through surgeries and medical interventions. The question of how comfortable do I want to be? We know that many patients with advancing motor neuron disease develop air hunger and dyspnea as the disease progresses, and many of these patients will tell us they don't want to feel as if they're suffocating. And so having them be very clear on how much medication is acceptable for comfort is important. Some patients may say, I want to be as alert and conscious as possible, and I'm willing to tolerate the air hunger that may occur. And for these patients, we would attempt to use less sedating medications. It's important to have them define how I want people to treat me. Do I want my family to make all the decisions for me, or do I want to have a living will define the treatments that I want? And in this slide, of course, there are a number of websites that are available for you to go to look at some of these sources for helping patients make decisions. But I encourage you to look at the Russian version of 5 wishes that I sent to Lev, and he can distribute to all of you through the website. Next, please. Next slide, please. Often I think we recognize that artificially extending life is not the best option. And when motor neuron disease progresses, respiratory insufficiency becomes a bigger challenge for the patient. It's time to consider when medications to provide comfort are appropriate. Richard Sloan is going to cover some of these in his next talk as well, but I want to start by emphasizing the fact that all of these medications that we use are used to provide comfort for the patient, to alleviate anxiety and fear, to make them as symptom-free as possible, and that there is a progression of these medications as the patient's disease progresses. It's important to recognize and for the listeners to understand that the dose of morphine that leads to decrease in air hunger and dyspnea is much lower than the dose of morphine that we use for analgesia or advanced pain management in cancer patients. And I think around the world there is enormous fear about morphine for 2 reasons. One is the fear that morphine will lead to addiction, and most of the literature on addiction says that when morphine is used as a medically prescribed therapy for patients with advanced pain syndromes And for patients who have dyspnea and air hunger from motor neuron disease, from advancing COPD, from advancing congestive heart failure, that morphine is not an addictive agent. Patients will become physiologically accommodated to the morphine, but they will not become addicted in the sense of an addict who has a psychological need to pursue the drug for the effect that they get from it psychologically. These are very distinct entities from the medical perspective, addiction versus physiologic habituation. And so again, the morphine doses are used typically at lower doses than we use for advanced pain syndromes, and they take the edge off, they relieve the sense of air hunger. Benzodiazepines may be very helpful, again used at lower doses, and Richard Sloan will talk more about that, as well as drying agents and compassionate sedation, which we'll talk about in the case study at the end. Next slide, please. Compassionate sedation, again, is covered somewhat in Richard's talk, as well as the doctrine of double effect. And this is, I think, important because as I have taught in Serbia and Russia and other Eastern European countries, and as I've talked in Southeast Asia, there is a lot of confusion and lack of clarity on the idea of double effect. And double effect says that we have good indications that we use medications like morphine or benzodiazepines for, and they may also have a negative side effect that we don't want, but we're willing to accept in order to achieve the good effect. So this is something Richard will go over a little bit more in his talk. And I want to once again emphasize that we are not using these medications to hasten death or to shorten life. This is not euthanasia we're talking about, and this is not the same as physician-assisted suicide, which is becoming more and more acceptable in the West. Next slide, please. Death with dignity is also known as physician-assisted suicide. There are strict criteria for this. Some of the ALS patients may in fact be qualified for this sort of approach. This is only available for adults, except in the Netherlands, where physician-assisted suicide or death with dignity may be legally acceptable for pediatric patients. There has to be a terminal illness of less than 6 months. The patient must be mentally competent and certified as such by their physician, must make this request twice, a couple of weeks apart, and must make the request in writing on their own, and they must be able to take the medications themselves. This picture shows a patient that I was consulted on, a 66-year-old woman in Sacramento, California. Last October, I was asked to evaluate her. She had multiple system atrophy, a condition seen in adults with advanced neurologic deterioration, neuromuscular deterioration. She was mentally competent and very intact, and she had requested the opportunity to control the timing of her own death, and she was certified as appropriate for California's Death with Dignity statute. She received a prescription from her physician that she had filled at the pharmacy for a large dose of barbiturates that she would take when she determined the time was right. And because my colleagues were involved in supporting her spiritually and emotionally, I went and I evaluated her, and in fact she was appropriate for this because she was losing her ability to eat by mouth and swallow. She lost her ability to speak effectively, and she felt that she had accomplished everything she wanted to in her life. And several weeks after I visited her, she took her barbiturate overdose and then died about 12 hours later. She was comfortable. The family was comfortable with this decision. This is something that may not be available at this point in Russia, but for patients with ALS and advancing disease, this may be a potential option. Next, please. When we choose to not extend life artificially, when a patient chooses to discontinue mechanical ventilation or non-invasive ventilatory support, there are several principles that are important. The first thing is we as medical providers must not abandon them. We must continue to support them even through the terminal phase of their life and their disease. We should not judge them based upon the decisions that they've made, and we need to provide ongoing guidance for them. If we personally, as professionals, healthcare professionals, have moral distress over the decisions that the family is making, we have an obligation to find another healthcare provider who is qualified to care for them, to take over the care and the guidance of their care. We need to partner with the families, perhaps who have already experienced ALS and what death is like, and let these families become part of our community support network for patients with advancing disease so that they can coach the families of the patients with acute ALS and help them to just make some appropriate decisions. Palliative care is a humane alternative when life will not be prolonged. We assist with symptom management, with advanced care planning. We also anticipate grief and loss in the bereavement process that will invariably occur when these patients, the end of life occurs for these patients. Next slide, please. This is a case study that I'm going to present that I was involved in about 6 years ago. This was a very tragic situation of a young professional, biomedical researcher. He had 2 NIH grants to do research in molecular biology of disease, and he was diagnosed in his mid-30s with ALS. He was a football superstar through the university. He was married and had 2 children, ages 4 and 7 years of age. And his father was a family practice physician, and his mother was a clinical psychologist. So he had an optimal support system for making some of these decisions for his life. In discussing what his personal goals were, he was very clear. He wanted to live long enough to see his youngest child start school, and he wanted to live long enough and have an income in order to finish buying his house so that after he died, his family would be secure and have a place to live. This is a picture of him you can see in his motorized wheelchair in his laboratory with the microscope next to him and his various assist devices. This was a man who was very positive and very engaged in life. Next slide, please. The principles of ethical principles that applied to him were autonomy and beneficence. Autonomy said that he had the right to make decisions for himself and decide how he wanted his life to progress in the face of this degenerative condition. And beneficence meant that everything that we did for him needed to be in his best interest. I met him when he had become wheelchair bound about 3 years before, and then he had become ventilator dependent about 2 years before. When I met him, he was unable to speak, and the only way he could communicate was using eye gaze technology with his computer. He was continuing to write research papers and apply for grants with his eye gaze technology. And he was finding that he had a progressive loss of function over the year preceding my meeting him in 2015. And he developed significant autonomic dysfunction as part of his advancing ALS with severe intractable abdominal pain. Next slide, please. He was on very high doses of opiate analgesics, high doses of benzodiazepine sedatives, and he still was not adequately relieved in terms of the pain that he was having. And he found himself losing even control over his eye gaze technology. So when I met him in late 2014, 2015, his pain was so severe that he needed to be heavily sedated out of consciousness from time to time. His youngest child had started school, and he decided that it was time to allow his life to end. His life was being maintained artificially through ventilator with a tracheostomy tube, and he was on gastrostomy tube feedings. But he was suffering significantly physically, emotionally, and he was ready for this to end. Next slide, please. In preparation for his end-of-life care, this is a picture of him on Father's Day in 2014, where his daughter had gotten him these glasses to wear for Father's Day. So they took this picture. It was one of the last pictures they took of him. In preparation for the end-of-life care and discontinuing his artificial life support, we had a child psychologist work with his children in preparation for this. The play therapist took some of his T-shirts and made pillows out of these T-shirts for the children because they would have the father's smell, his scent on them, and the children would have this to make associations with the father after he was gone. The wife and the patient's parents agreed with his decision and supported this fully. The ALS physician, who was his specialist and brought me in, also accepted his wishes that it was appropriate for this man to allow his life to end. But he wanted to donate organs if possible after death. So we admitted him to the hospital for pain management and knew that this hospitalization would lead to end-of-life care. Next slide, please. He wanted to know exactly what was going to happen to him, what medications I was going to use so that he would not feel suffocation and so that he wouldn't suffer when the ventilator was stopped. I told him I planned to use propofol in addition to a narcotic analgesic and benzodiazepine sedative as well. The problem in these situations when patients have been on high doses of opiates and benzodiazepines is it's hard to know because of the physiologic accommodation to these medications. It's hard to know how much of these drugs are going to be needed to alleviate pain and distressing symptoms at the end of life. Whereas if you have a patient that's naive to opiates and benzodiazepines, it's much easier to predict what the response is going to be. For example, when we discontinue life support in patients with cystic fibrosis or other conditions where artificial life support is discontinued, we have a good idea how much opiate and benzodiazepine may be needed in order to provide comfort and alleviate distressing symptoms. In patients such as advanced cancer patients who have been on large amounts of opiate analgesics and benzodiazepines for anxiety, it's more difficult to predict how much opiate is going to be required. So in these cases, I often will add a new class of analgesic or sedative medication. And in this case, because he was in the hospital and I had intensive care unit privileges, we plan to use propofol to provide significant degrees of sedation for him while we took care of his pain and other discomfort with the narcotics and benzodiazepines. In North America, dexmedetomidine is a frequent agent that's used for what's called compassionate sedation. When I told him I was going to use propofol, he got a smile, and he didn't get a smile, but he laughed on his eye gaze technology, and he said, "That's just what Michael Jackson used at end of life, wasn't it?" And I told him exactly that was the same medication. Next slide, please. He wanted donation after cardiac death, which meant that we had to heavily sedate him with the propofol. We took him to the operating room for organ harvesting. He was asleep under the propofol, narcotics, and benzodiazepines, and then his mechanical ventilation was stopped while he was under general anesthesia. And his heart stopped 35 minutes after discontinuing artificial ventilation. He was pronounced dead, and his liver and kidneys were able to be used for transplantation. Next slide, please. So this patient was of a rational, sound mind. His suffering was far greater than his fear of death. He was very clear on what his goals were and his intentions, and his wishes were respected, and his life plan was fulfilled by our approach to his care. Artificially extending his life for more weeks, months, or years would not have improved his quality of life. It just would have prolonged his suffering and his misery. Next slide, please. We need to focus on how to make care in the hospital for these patients as humane as possible. Patients in the ICU lose their identity, their ability to communicate, they lose control over their lives. And so the things that we can do to make them have as much control, autonomy, and comfort as possible are the things that will humanize the ICU setting, which is where many of these patients with advanced ALS are cared for at the end. I encourage you to read this article that was published last year just to put perspective on this. Next slide, please. There are complementary medical modalities that we have found to be very helpful in our palliative care and end-of-life practice. Massage therapy, Reiki therapy, and other modalities provide enormous comfort for patients and even for the families at the bedside. They have no toxicity, they're inexpensive, and they provide human touch, which is something that is much needed when patients are in a terminal phase of their life. This is a set of studies that we did in Chicago 10 years ago, where we offered Reiki therapy or massage therapy to patients and to their family members, and we saw a dramatic improvement in patients' sense of distress, pain, tension, upset mood, and discomfort. So these are things that we can provide very compassionately and humanistically for patients in a terminal phase of disease. Next slide, please. So in summary, I want to say that the palliative care team is an important partner in caring for patients with advanced ALS. The palliative care team uses good bioethical principles and planning in helping patients make decisions for their lives. We help families make difficult decisions in a non-judgmental way, and we explain what the medical team is saying so that we can help to interpret the choices that the family has to make. The palliative care team protects the patient's right for comfort and dignity. We assure appropriate treatment of distressing symptoms such as pain, fear, anxiety, and air hunger. And we help the patient and the family with what are called life closure activities. Everybody has what's called unfinished business at the end of life. Unfinished business are all those things that we wanted to do but haven't had an opportunity to do. And a common formula in North America is giving a patient the opportunity to say goodbye to their loved ones and to important people in their lives, to say I love you, to say I'm sorry for those things that I did that I wish I hadn't done, and to also allow their loved ones to say we're sorry for the things that we did that we didn't have control over. So this is part of what's known as completing one's life's business or life closure activities. And the palliative care team is very helpful in terms of helping patients and families express these sorts of decisions that they make. We don't impose our own values, but we try and achieve consensus and help patients and families make the best choice through kind and honest discussion. And we don't attempt to artificially prolong life beyond what is useful for the patient, but we also do not hasten death. We acknowledge the death as a reality and a part of the disease process and a part of life, and we try to make this as natural and meaningful as possible for the patient and family. And I think with that, it is the end of my presentation. Thank you.
Sorry for that, I was just didn't turn on my microphone. Thank you for your talk, and I have the first question for you. What do you think is the best timing for the talk about choosing different ways for a patient with such devastating disease as ALS? I mean, some physicians think that we should start to talk about options like palliative care only on the late stage of ALS. What do you think about it?
Well, I can tell you that in North America, and I think this is true in the UK and EU as well, that the philosophy has shifted quite a bit, and that leaving these discussions until the terminal stage of illness creates problems in two ways. One way it creates problems is that the patient's disease is advanced and their symptom burden is greater at that time, so their ability to think rationally and carefully about the decisions they need to make is significantly impaired. And the other important part of this is that if you leave this discussion and these decisions, that is to say, if you leave the involvement of the palliative and hospice care teams to the end of life, there will not be the time for the family and the patient to develop the meaningful and supportive relationships with the hospice and palliative care team that will allow them to feel comfortable with these people participating in their care. So the answer to your question is, we believe very strongly that the discussions, the beginning of the discussions about planning for end-of-life care and options for end-of-life care should happen sooner rather than later. And sooner in this case, for example, may mean year one, in the second or third year of the diagnosis, as it becomes clear to the patient and family that the condition is progressive, as it becomes clear to the patient and family that function is going to be lost. The first year, I think, of the diagnosis is the time that you're getting the patient and family familiar with the fact that they have a degenerative condition that will ultimately be fatal. And so that is the time early in the first year where you begin to talk the following way. You say, in the coming years, we will need to talk about some of the options for the future. You know that this will be a progressive disease, and ultimately your life will be shortened by the fact that you have a diagnosis of ALS. And right now we're going to focus on maximizing your pulmonary function, your respiratory rehabilitation. We're going to focus on keeping you as functional and healthy as possible. But as the next couple of years go on, we're going to have to start looking at other options as the disease progresses, and we will deal with that in the future. The reason for bringing it up this way, that is, that we will talk about this in the future, is what we call giving a patient a warning. In the West, it's called firing a warning shot, which means we give them a warning that in the future we'll have to deal with this. But we're not going to talk about it right now. Telling them at the outset that we're going to have to deal with this next year or in the future, depending on the progression of your symptoms, gives them a psychological preparation for the future discussion that will be very difficult, as we all know. But giving them this warning, give them what we call in the West a heads up, a warning or foreshadowing of what is going to come. This is an important part of what's called breaking bad news. If we give the patient all the bad news at the very beginning, number one, they won't remember 90% of what we say. And number two, it will be too overwhelming for them to process. So giving them a warning that in year 2, year 3, we're going to be talking about some of these difficult things, lets them prepare over the course of time. And if they want to know more, they'll ask you more. If they don't want to know more, you'll bring this up after 6 months or 12 months as there is disease progression and the symptoms make it clear that you need to have these discussions. I hope that answers your question.
Yes, thank you very much. And one more question. Do you think that one specialist can marry, so to say, both these approaches, palliative and intensive care approach, in one head? I mean, or do you think that we need to introduce palliative care physician into the process as a separate specialist?
Well, I think
yes,
I think there is an advantage in bringing in a palliative care consultant. The intensive care unit physician has large responsibilities for all of the patients on the intensive care unit, has significant obligations, and may not have an hour's time to sit with the patient and the family and have these discussions. Whereas if you bring the palliative care consultant in, the palliative care consultant can dedicate 30 minutes or 45 minutes of time to having these discussions with the patient and the family. So bringing in another consultant, the same way you may bring in a nephrologist to do dialysis, or you may bring in an infection disease consultant. You bring in the palliative care consultant who can dedicate the time and the energy to having this conversation with the patient and the family. I think that this is a wise thing to do, but I want to qualify that. I want to say that the intensive care specialist, somebody's speaking Russian in the background, I don't know who that is. But the intensive care specialist must also have the sensibility, must have the wisdom and the sensitivity to the fact that not all of our patients in the intensive care unit will survive. And that for those patients who are not going to survive, we need to offer an equally high quality end-of-life care or palliative care for them, so that the intensive care specialist must be wise and sensitive to the realities of the patient care. The intensive care specialist should not abandon the patient and family and throw up their hands and say, well, I have nothing more to offer, I'm sorry. This has been a big problem, for example, in oncology, where the patient goes to the oncologist and after 3 or 4 or 5 years, the oncologist says, I'm sorry, I have nothing more to offer. Your cancer has come back and you need to go and see the hospice doctor. Those patients feel abandoned by the oncologist with whom they've had a relationship for many years. And this is part of the cruelty of the Western healthcare system, where we just abandon patients to another specialist who they haven't ever met before. So that's partly why early referral to palliative care is useful to establish the relationships even before we know the patient will not survive. And it's important for the primary provider, intensive care or oncology or neurology, to not abandon the patient.
Okay, thank you very much. And we have a couple of questions from audience. So what is the difference between dignified death and euthanasia?
Well, death with dignity means that the patient themselves must take the medication. It is not administered by a physician or a nurse. And so that's why it is known with death with dignity. It gives them the means, the medication for doing what they choose to do, but it is not the physician or the nurse giving the medication that leads to death. In my 35 years career in the intensive care unit, I think there has only been 1 or 2 times that I've had to give high doses of medications with the intention of shortening the life because the patient was suffering. And most of the time, it is more like the 38-year-old ALS patient where we provide heavy doses of sedation and provide compassionate sedation, and then we discontinue artificial life support. Typically for patients who choose death with dignity, they are not on artificial life support. They are not ventilated. They don't have a gastrostomy tube. They typically decide that it is time for their life to end, and medical authorities certify them as mentally competent to do this. Again, the healthcare system, the physicians and the nurses are not giving medications to end the life. And in the case of the ALS patient that we use propofol and sedation for, he died from his ALS because he was unable to breathe on his own. We simply gave compassionate sedation and medication to alleviate the air hunger that he would have felt if we had discontinued ventilation without sufficient medications.
And one more question. Do high dose of barbiturates hasten the death?
Yes, high doses of barbiturates will hasten death from the perspective that high doses of barbiturates in somebody who is naive to barbiturates will depress and stop respirations, and that will lead to death. And so there is no question that high doses of barbiturates, which are the medication used for death with dignity, will hasten death. I believe that that is true. And that's why many of us will use agents like dexmedetomidine along with opiate and benzodiazepine because dexmedetomidine typically does not suppress respirations but does suppress consciousness and awareness. It's very confusing and ambiguous, but I think the important thing is, what is the intention of the physician? Is it to alleviate suffering and discomfort, or is it to hasten death? And this goes back to the doctrine of double effect that says we use the medications to alleviate suffering, to provide comfort, to relieve air hunger and the perception of suffocation. We're not using them to hasten death, but we all acknowledge and recognize that these medications may have that secondary effect, but that is not our intention. Our intention is the primary good effect and not the negative secondary effect. I think Richard may say a little bit more about this in his talk as well. And it's a difficult distinction. It's a difficult distinction, and I know that this makes people uncomfortable.
Thank you very much, David. And now we're going to the next talk. I hope, David, that you could stay with us for the next 2 talks to maybe to take part in the discussion if we would have it.
Yes,
And
yes.
now thank you very much. And now I would like to introduce Richard Sloan. He was a medical director of the hospice in Dorchester, and he came to Russia several times to teach us and our colleagues on the field of palliative care, and we're very grateful for him that he opened this field for us. And his talk today is about palliative care and management of respiratory system. Hello, Richard. Thank you for joining us.
Thank you very much, Lev. It's a pleasure to be back in Russia, even if it's only online. I've had great experiences with you and your team in Moscow, and also the team in St. Petersburg. It's a great pleasure to be able to help, and I learn a lot from you people as well. Could I have the first slide, please? So, go back to the previous slide, please. Backwards, previous ones. Back more. And again. And again. That's it. Thank you. As Lev said, I was medical director of Hospice in Dorchester, which is in the southwest of England, about 200 kilometres from London, 180 miles southwest. And next slide. We live in a very beautiful part of England with lovely countryside and scenery around. Next slide. We also have the advantage of being very close to the coast. Next slide. And this is the hospice where I worked for 20 years until I retired 6 years ago. It was a purpose-built hospice. We also, as well as providing inpatient beds, we were able to visit people in their own homes and in the local hospitals to provide advice, not necessarily directly to patients and families, but advice to the clinicians looking after them. Often it was to say to those clinicians, you're doing exactly the right thing, be reassured about that, but if you need any more help with managing the case in the future, please get back to us. Next slide, please. What is palliative care? David's already alluded to this, but it's the care provided to patients with a progressive illness when it's recognised that the disease is no longer curable. So it can be any disease or illness, and although palliative care was developed largely in the context of cancer patients, it's applicable to any type of progressive illness which is no longer curable. And despite advances in medical science, not all types of heart disease, renal disease, lung disease are curable. And sadly, that's the case with ALS, although we hope that with ongoing research, palliative care will be made redundant because it will be curable. Next slide. So palliative care focuses on the quality of life, and as David said, quality of life as the patient sees it, not as we think the patient should be seeing it. So it's very important that we find out about the patient through them and their family, so that we're not trying to achieve something that they actually don't think is important. There might be something far more important that we haven't thought about. Palliative care is about the alleviation of distressing symptoms, not just physical symptoms of pain, breathlessness, whatever, but the psychological symptoms that go along with any ongoing illness that is going to result in death. And it's not just the psychological symptoms of the patient either, it's the patient's family. There's lots of research to show that the psychological distress experienced by patients with ALS is actually less than that experienced by families. So whilst much of medical teaching is focused almost exclusively on the patient, we mustn't forget the family, who will be a very important part of the patient's whole life. And if they're unsettled or anxious or frightened about the future, how they're going to cope with the person's demise, that's going to have rebound effects on the patient's well-being. So it's looking at the family unit as a whole. Next slide. This alludes to another question that Lev asked of David. Who practices palliative care and where? It's not just the domain of hospice physicians or palliative care physicians. It should be something that's practiced in every setting where a patient might be. And although not every clinician is expected to know everything about palliative care, the idea is that they should have a basic fundamental knowledge of what it's about and how it differs from mainstream medical care, so that when faced with a patient with a progressive internal illness, they understand its importance. They know who to contact if they need help and support, not just for physical symptoms, but for distressing family situations, rather than, as David said, the horrible phrase, "there's nothing more we can do," is used because of ignorance. So there's always something more that can be done to help support the patient. It may just be a question of knowing where to ask. Next slide. So this is another diagram similar to David's, which asks the question, well, where does palliative care begin? At what stage should we be starting to think of palliative care issues? This is the old model, which up until relatively recently was often the case, especially with cancer patients. The oncologists would endeavour in medical interventions to try and cure the cancer from the time of diagnosis onwards. And only after it became clear that these cytotoxic treatments or radiotherapy were not going to work and that sadly this disease was incurable, only then would the patient be handed over to palliative care type setups. And that was used. Okay. Okay. If the projectionist can hear me, can we have the next slide, please? Hello. Okay, and do I have to log in again, or? Sorry about the interruption. I was just talking about the old model where palliative care only became involved very late on in the stage of a progressive incurable illness. But that way of thinking has changed. Can we have the next slide, please? So this is a representation of a newer way of thinking. And if you look on the left-hand side, from the time of diagnosis, medical treatments will predominate, but not necessarily to the exclusion of palliative care. There may be symptom management options that palliative care has developed which can work alongside medical treatments. In the case of oncology, patients suffering from pain and discomfort whilst waiting for cytological or radiological treatments to abate that pain will benefit from palliative care medications such as morphine until hopefully the medical treatment kicks in. As time goes by and it is recognised that the disease unfortunately is not going to respond completely to medical treatments, then palliative care will become more prominent. But again, medical treatments after this stage of recognition may still be important. I'm thinking in the case of somebody with bone metastases, morphine's not very good for the pain from those sorts of problems, whereas palliative radiotherapy is. So again, the patient can benefit both from medical treatments and palliative treatments, even after the stage at which it's recognised that this disease is not curable. The other important aspect to palliative care is that it continues after the patient's death, and most specialist centres will have a bereavement care team that are there for the family after the death of a loved one. Next slide, please. So how does all this relate to MND or ALS? The time from diagnosis to recognition that the disease is incurable, well, by definition, once you've had a correct diagnosis of ALS or MND, it is by definition incurable. So palliative care will be relevant from any time after that. Medical treatments may come along in the form of assisted ventilation, and they will be very important. But again, it's the two working in tandem alongside one another, rather than it's either medical treatments or palliative care. Next slide, please. So let's take the example of non-invasive ventilation. That may be instituted at various times from diagnosis onwards. Vasily talked about that this morning. But it's important that the patient has the option of palliative medications for breathlessness, even though other interventions like non-invasive ventilation are being trialled. The patient may find it difficult to tolerate non-invasive ventilation. So what happens in the middle of the night if they become extremely breathless and the NIV is not working for them? So again, although the question was asked of David, who should be providing the palliative advice? I think if neurologists or respirologists are aware of the possibility that their intervention may not work straight away, or the patient may never tolerate it, and are giving the patient and their family an alternative, so that if plan A doesn't work, then there's always a plan B, that will go a long way to alleviating unnecessary suffering on the part of the patient and the family. Next slide. I'm going to be spending the vast majority of this talk on the symptom of breathlessness because it is such an evocative one, and handled well can make a huge difference to the well-being of both the patient and the family. I'll spend a little bit of time talking about other respiratory symptoms such as cough, but the breathlessness one I think is by far and away the most important symptom to have command over. Next slide. It's important to recognise breathlessness is not just a bit of a nuisance, but again, by definition, it's distressing. Okay, you might have a raised respiratory rate, you're not necessarily feeling breathless. If you run for the bus, you know that once you catch the bus and you sit down, the breathlessness is going to go away. It's under your control. It's not distressing. However, due to disease, illness, pathology, breathlessness, which is outside of your control, inevitably has an element of distress about it, and that's the issue that we're talking about here. Next slide, please. Where you've got breathlessness, you always have a degree of panic or anxiety. It's if you have no control over the breathlessness, it controls you. And the more breathless you feel, the more panic or anxiety you experience, and that feeds into the breathlessness. And you have what is called a vicious cycle. Next slide, please. So in overall assessment of breathlessness, of course, it's important to look at the physical causes behind the breathlessness. And if there are any reversible factors, such as chest infection, then once they're treated, that will hopefully alleviate the problem. But if there aren't any reversible factors, the next stage in the assessment becomes even more important. And I call that an exploration of the patient's experience of breathlessness. Just to go ahead and treat the symptoms without looking into what the breathlessness means to that individual patient and their family, you may not get as good results from your interventions, your symptomatic interventions, as if you've thoroughly explored how the patient and their family see it. Next slide, please. So how do you actually go about that? Whenever you're trying to find out information of a psychological nature from patients, it's always good to home in on feelings and ask the person, how did it feel when you were acutely short of breath last night? And that may often reveal emotions that the patient wouldn't have expressed to the doctor normally. Patients might feel embarrassed that they were finding it extremely difficult. They're not used to doctors asking about feelings necessarily. The doctor asks them questions and they respond appropriately. But something like breathlessness is incredibly frightening, and that's what patients, if they're given the opportunity, will tell you. Next slide. It's often good to follow up that sort of a response with an effort to quantify, well, how frightening was it? And again, these next couple of sentences, I was suffocating, I thought I was going to die. That's extremely common. more common often than physicians realize. And unless you uncover that really mortal fear, the patient may not quite feel you're on the same track as they are. You may suggest some treatment, but unless the patient and the family really understand you understood how distressing it was, they may think the doctor is missing something out here. That treatment he suggested is not going to work. If I'm going to die, I'm going to die. However, acknowledging the severity of the distress, saying, that must have been terrible, it must have been awful that you really felt it was that bad that you might be dying, but then be able to go on and say, actually, death during an acute breathlessness attack is extremely rare. It can happen, but it's very rare for the number of times patients fear on the point of dying. And the good news is there are things we can do to help alleviate the distress and allow you to get back in control of the breathing rather than it controlling you. Next slide, please. So these are things that were mentioned by Timur before lunch. Lots of simple measures which the ordinary clinician, or with help from a physiotherapist, can suggest. Sitting upright, much more effective for breathing than lying down. It's much more efficient, much less work required by the respiratory muscles when you're in the upright position. Breathing exercises, again mentioned by Timur, relaxation, visualization, music therapy, all these things humanize the experience, and they're things that the patient can do. They're not just the passive recipient of medical or nursing interventions. They can start to feel a degree of control over things rather than just waiting till the next breathless attack. Another thing that's been found very helpful is the use of a fan. For some reason, and it's difficult to explain in the physiological sense, but there does seem to be a definite improvement in breathlessness for a lot of patients if they have moving air passing by the face, either from an electric fan by the bedside or a handheld battery-powered fan, which a lot of patients, as I say, find very helpful. So these might not seem huge interventions from the medical point of view, but they can make a big, big difference to the subjective experience on the part of the patient. Next slide. David mentioned earlier about morphine and its effect on breathlessness. And before lunch, there are definite physiological reasons why morphine has a beneficial effect on the sensation. And it's not just through sedation, it's quite a separate effect from that. And it's low doses that are necessary, lower than required for pain control. Starting off with oral morphine, 2.5 to 5 milligrams as required. And if the patient is benefiting from that but needing it several times a day, it can always be converted for convenience into regular slow-release morphine capsules. Again, just to echo what David said, there's no evidence that this causes harm in patients, even with patients who've got breathing problems. We were all told in medical school you must never prescribe morphine to patients with respiratory problems because you'll kill them by stopping their breathing. That actually is not relevant in this case. If you prescribed huge doses to someone who was not used to morphine, they were opiate naive, then yes, you could do that. But in this context, small doses prescribed appropriately don't do any harm and can help a great deal. You're not trying to give doses that cause dulling of consciousness. You're giving small doses enough to relieve the symptom without that happening. Next slide, please. With or without opiates, benzodiazepines are very useful. You've got benzodiazepines of various potencies and given by different routes. A very useful medication to consider the patient having at home for emergency use is lorazepam. And it can be given sublingually, which is a huge advantage, especially in someone who's having an acute breathless attack. Swallowing becomes extremely difficult when you're fighting for breath, but the lorazepam, although it's not designed for sublingual absorption, does get into the blood system that way fairly quickly and can alleviate the anxiety component of breathlessness and thereby break the vicious cycle. In the same way as opiates, longer-acting versions of benzodiazepines like diazepam can be given once or twice a day if necessary. In extreme respiratory distress, especially if lorazepam hasn't worked, then an injectable benzodiazepine such as midazolam can be very useful in giving the patient relief from what would be otherwise unrelenting distress. Next slide, please. If you don't have access to midazolam or lorazepam for that matter, there are other medications which could substitute for them in relation to anxiety. Chlorpromazine is one which can be given orally or even rectally if the injectable version. Haloperidol, which is less sedating than chlorpromazine, is another option. Next slide. I'm going to talk next about a very simple emergency kit to have at home. This is something that's been developed by the Motor Neuron Disease Association in the UK. There is a web link there if you want to read more about it. And it's basically a box that is supplied by the Motor Neuron Disease Association into which are put various medications. Even if you haven't got access to this box yourself, you could actually use the principle to make up a box for your own patients, and supplies of medication with instructions on to how to use the medications could be included. Next slide. If you open the lid to the box, inside there are two compartments. On the left-hand side is a compartment for the carer, and on the right-hand side is a compartment for the doctor or nurse. Next slide. In the compartment for the carer, medications such as lorazepam may be present. There is a book of instructions that comes with the kit, and the instructions for the carer are: if your loved one is experiencing a bout of breathlessness, first of all check for these issues. Is the patient sitting upright? That in itself, if corrected, may or be all you need to do. If that's not helping, then give them a tablet of lorazepam under the tongue. If after 15 minutes this isn't helping, then go on to the next stage. Next slide, please. The next stage would be to utilize the medications in the compartment labeled for doctor or nurse. Again, there are full instructions inside the box that explain if the lorazepam is not working, then the patient may need an injection to a more potent drug to help alleviate their distress. And in this case, midazolam, usually 5 milligrams to begin with, repeated after 20 minutes if there's still distress present, would usually do the trick. If the patient lives a long way from medical help, or the crisis happens in the middle of the night and there just isn't access to a doctor or nurse attending the patient wherever they may be, at home or wherever, then often the carers are trained to utilize the medications in this compartment. It's quite a big thing for a carer to be asked to give their loved one an injection, especially if that injection is going to make them quite sleepy. So it may take quite a lot of coaching and reassurance that this is the right thing to do, that although the patient is going to become sleepy, they will wake up. They're not going to die here and now. It might be quite scary, but this is the right thing to do. And that can get round problems of access to a doctor or nurse to give an injection in an emergency situation. The other aspect is that midazolam can be given rectally. The injection form can be given rectally so that the drug is drawn up by the carer into the syringe and injected into the rectum. Not very nice thing to have to do, but in a crisis, again, it's something that will bring huge relief to both parties. Next slide. As I was saying, there are instructions in the just-in-case kit, and these are they. These instructions are in English, obviously, but they can be easily translated into Russian using something like Google Translate. So, as I say, you can draw up your own just-in-case kit with appropriate instructions and medications according to your culture, your country. It makes a huge difference to confidence if this sort of kit is present in a patient's home. I've prescribed it many times, and yet the number of times it's been necessary have been few and far between. And just to have it there on a shelf, ready if necessary, can be extremely reassuring, knowing that there is a plan in case of a serious problem is much more reassuring than either patient or family members fearing, what do I do? I would not know what to do if there was a case of sudden distressing breathlessness. Next slide. Just very briefly, other respiratory symptoms. Cough can be troublesome, but again, small doses of oral morphine titrated according to response can be very useful. Cough can be due to various different things. One of the commonest reasons is in a patient with bulbar symptoms, with ALS with bulbar symptoms. Not that they've got excess saliva production, it's just that they aren't able to swallow the saliva normally, so it accumulates around the entrance to the trachea and causes an irritating cough, or may be inhaled to produce the coughing lower down the respiratory tract. A traditional drying agent would be something like atropine or hyoscine or glycopyrrolate. And although these drugs come as an injection, there's a much simpler option, and that's in the form of using the atropine eye drops, using them orally. 1% eye drops, 1 to 2 drops into the mouth as required. Again, the patient can just hold it there and it's absorbed by the mucous membranes. They don't have to swallow it. And that can produce drying of saliva that is otherwise causing an irritating cough. It can be used as and when. The dose will have to be titrated. If you give too much, then the patient may be complaining of a dry mouth that's more uncomfortable than too much saliva to swallow. But again, it's a question of tailoring the dose to balance between the effects and the side effects. Next slide. You can have the opposite problem, that secretions are just too sticky to cough up adequately. And although there are a number of pharmaceutical agents, carbamazepine, acetylcysteine, that break up mucus, make it less sticky, therefore easier to cough up. This is actually a much simpler method in lots of ways. The research evidence for carbamazepine, acetylcysteine is not that great, whereas there's more research evidence to suggest that simple humidification of the airways by using normal saline, nebulized as required, can help break up sticky secretions just as well. It's important not to use water, but to use saline for this purpose. Water can have detrimental effects if inhaled too much. Next slide. I mentioned the Motor Neuron Disease Association of the UK. This has a very useful website, not just for patients and carers, but for clinicians as well, be they doctor, nurse, physiotherapist. There's a wealth of information. As I say, if it's not in Russian, if it's not available in Russian, the pages can be put into Google Translate, and you'll get a pretty good approximation to what's being suggested. Next slide. That's, as I was saying earlier. Next slide. There are a number of information sheets which the Motor Neuron Disease Association produces in Russian, and again, you can gain access to those. I'm sorry if the link at the bottom of the slide doesn't show up too well, but I can send the links back to Lev if that's the case after this conference. Next slide. Finally, I'm just going to talk on the subject of palliative sedation. During the discussions before the conference, it was very helpfully suggested that we look at this from the context of our own countries, because terminology and practice does vary according to which part of the world you're in. David's already covered a lot of what I'm going to say, but thank you for that. But this is the perspective from the UK. Next slide, please. This is how we define it in the UK. It's the use of medication to produce a reduction of consciousness to relieve an intolerable symptom which is unresponsive to all other means. Next slide. There are a couple of terms which in the English culture are probably not desirable in that they might be misunderstood. And one of them is terminal sedation. That might be misunderstood as meaning you're giving sedation to speed up death, even where there are no intolerable symptoms. in other words, euthanasia. In the UK, euthanasia isn't legal, although there have been several attempts through Parliament in the last 20 years or so to change the law to make it legal, but so far those attempts have been thwarted, and concerns about its misuse and the lack of fail-safe guards against heavy sedation being used as a form of euthanasia, they're quoted as concerns as to why it shouldn't be legalised in the UK. But euthanasia has been legal in the Netherlands and Belgium for some time, and increasingly in parts of North America. Certain states have legalised it, and in Canada as well. However, it's for these reasons, because it's not legal, terminal sedation is considered an undesirable term in the UK. The other term that can sometimes be used is continuous deep sedation. Again, possibly subject to the same misunderstandings as terminal sedation. Next slide. David referred earlier to the principle of double effect, and this all boils down to what is the intention of the medical intervention. And where the intention of the intervention is to relieve symptoms, but where it's recognised that there's a possibility of speeding up death, then that intervention is justified. When there is no other alternative, reasonable course of action to relieve that person's suffering. So although the double effect is used quite commonly, but maybe not so obviously, in relation to morphine. Yes, theoretically, morphine can suppress respiration and can cause death in someone who's opiate naive. However, if you're using it for pain or for breathlessness, and you're giving it appropriately in doses that are unlikely to speed up death, well, you're using the principle of double effect. So more often than not, where this principle is invoked, it doesn't cause speeding up of death. It's just where there is a possibility of that happening, that you're aware of it, but you're taking precautions to try and avoid that from happening. Next slide. So again, David said it's a very uncomfortable juxtaposition, really. What's the difference between palliative sedation and euthanasia? It all boils down to the intention, and euthanasia is the intention to cause death by medical means, whereas the intention in palliative sedation is to relieve distressing symptoms. And there might seem to be a very fine difference between these two, but and it is contentious. Next slide. So, common reasons for palliative sedation in palliative care. There may be breathlessness, there may be severe pain that's not responding to morphine or other measures, delirium or confusion, agitation, especially right at the end of life. These are common reasons for sedation to be appropriate. Otherwise, the patient would just continue in this state of confusion, agitation, much to their distress and the distress of those around them. And extreme psychological distress or fear of death itself. Next slide. Palliative sedation doesn't have to be continuous, and it could be temporary on the grounds that it could provide quick relief of severe symptoms, for example, extreme breathlessness, And that temporary breaking of the vicious cycle may be all that's needed for things to settle down, such that when the sedation wears off, the patient awakes and is no longer distressed. You've broken the cycle. But it may also be administered whilst you're waiting for other interventions to work, interventions that may take a bit longer than half an hour. So palliative sedation does not have to be permanent or continuous. Next slide. So these are the sorts of doses that midazolam could be given either subcutaneously or intravenously for emergency sedation, temporary sedation, 5 to 10 milligrams subcutaneously or intravenously. Increase it gradually if once the patient wakes up, once the sedation wears off, the distress hasn't settled. But it may just be a single injection required for everything to settle down. Next slide. Continuous sedation may be necessary where the distress persists after a trial of temporary sedation. So here it's important to give a one-off loading dose of subcutaneous or intravenous midazolam for immediate effect, but then to maintain the sedation with an infusion of midazolam via syringe driver and doses of between 30 to 120 milligrams over 24 hours by continuous subcutaneous infusion may be appropriate where, unfortunately, the distress is unrelievable by any other means. Next slide. It's not a good idea to try and provide sedation with morphine. Again, before more effective drugs than midazolam came along, morphine often was the drug that was given in overdose to cause sedation and relieve intolerable suffering. But in overdose, morphine can do the opposite of what you're trying to achieve. It can cause agitation and make things worse. So where you've got access to other sedative drugs like midazolam, chlorpromazine, haloperidol, that's more preferable than increasing the dose of morphine. You might actually be contributing to agitation rather than relieving it. Next slide. So these are the questions to ask before considering either temporary or continuous sedation. What's the cause? Are we missing something here? Is there something fairly simple that would prevent the distress or the agitation? Has the patient gone into urinary retention? Have we checked to see whether their bladder is palpable? If it is, then catheterization may be the answer rather than sedation. Have all potentially reversible causes been excluded or treated? Rather than go into exhaustive tests to find out a possible cause, especially towards the end of life, that might be far too burdensome for the patient. So obviously a judgment has to be made as to whether it's appropriate, whether the time is right to be going into exhaustive attempts, investigations. Next slide. So that's it basically. As I say, it's been a great pleasure to prepare this talk, and I'll be very glad if there are any questions. Thank you.
Thank you very much, David. And I just want to mention and stress the fact for everybody who listening to the translation that palliative care is a very young specialty in Russia, but it's a specialty that should be trained for trained for, and there was a question if relatives of the patient could perform some palliative care, help themselves if they do not have a palliative care specialist in the city, for example.
Yes, I think it means confidence on the part of the people who are teaching relatives what to do in certain circumstances, having backup, written backup, information, leaflets, or access to websites like the Motor Neurone Disease Association to say, this is what you do, this is safe, it's been thought through. If you have any questions, please ask them in advance. But being prepared for predictable emergencies and knowing whatever time, day or night, whatever day of the week, there is a way of coping with this is important. It would be very soul-destroying if patients were given something like the breathing space kit and told to get in touch with a doctor or a nurse if the symptoms aren't responding to sublingual lorazepam, only to discover that there is no doctor or nurse available. So it's important to be realistic, and if plan B isn't going to work 24 hours a day, 7 days a week, well, have a plan C and give the carer time to consider what they should do and time to ask questions and be prepared for a possible emergency.
Okay, thank you very much, and I hope you stay with us for conversation after John's talk, and I would like to say thank you one more time for Philips, who is helping us to make this conference, and for Foundation right now. Now we have first 1 minute of Philips here, and then we get back to talk of John Bach, who is a leader in non-invasive ventilation in neuromuscular disorders, talk on ventilation for patients with ALS.
Healthcare has come a long way, but it's still not seamless. Systems don't always communicate. Clinicians can't always see the full picture. Patients can feel lost in the system. That's why Philips is on a mission to remove the limits of care, helping people manage both illness and health, with clinical intelligence that helps to get it right the first time, bringing data, technology, and people together seamlessly. This is what drives us. It's what gets us out of our beds, to help get people out of these beds healthier, happier, faster. Because today, health knows no bounds, and neither should healthcare. Innovation and you. Philips.
Hello, everyone. I want to introduce John Bach one more time. He is a leader in non-invasive ventilation for neuromuscular patients, and he has a lot of publications and books, and we always refer to his experience when we talk about ventilation in ALS. So thank you for joining us, and we're listening to you.
Thank you, Max. Is that the first image? I don't think that's the first image. Hello? Well, first I want to tell you that it was a great pleasure to be in Moscow in October of 2017 to lecture for the Vera Foundation Charity Fund. And it's a great pleasure today to be back to speak with my...
I think there are some technical problems in translation. Not in translation, in our connection with John, so we're waiting when everything would be fixed. Okay, and while we're waiting for John for coming back, could we talk for a couple of minutes more with Richard? Is it possible? Okay. Okay. Welcome back, Richard. There's some technical problem with connection. Okay, and David still is with us online. Okay, David, we had a question previously in the first okay, it's technically impossible to talk all together. Joel is coming back soon. Okay, let us just remember what we were talking about with David and Richard. David told us that we have options in terms of palliative care and curative care, and we should discuss these options with the patient, and the earlier we do it, maybe the better, and the timing is important. Okay, and I think we now have connection back, and now we'll hear for... Okay, welcome back. Welcome back.
Yeah, technical problems. Okay, so I did say that it's great to be back speaking with my Russian and Ukrainian colleagues, and I'm very happy to do that again. Now, I'll just say slide or image or something. Yeah, I believe that is the first one. Okay, so next image, please. Next. Next. Okay, okay. Look, I want to say a few words about palliative care. I don't intend to speak about it later on, but I want to point out a couple of things. First of all, any kind of sedation or supplemental oxygen therapy for someone who is hypercapnic is likely to increase their carbon dioxide a great deal and can hasten acute respiratory failure and death. So what I want to make clear is that symptoms, respiratory symptoms for patients with predominantly lower motor neuron disease never need resort to palliative sedation or tracheostomy tubes. However, classical ALS with predominantly upper motor neuron symptoms do. It is important to understand that the diagnosis of ALS has been broken down to at least 5 conditions. Classical ALS, which is the most common, and primary lateral sclerosis are essentially upper motor neuron diseases. However, progressive muscular atrophy, flail arm and flail limb syndromes, which make up about 5% or 10% of the ALS population, are lower motor neuron diseases. These conditions, including progressive muscular atrophy, virtually never require palliative sedation or tracheostomy tubes. Next image, please. Now, this patient with progressive muscular atrophy has been continuously dependent on respiratory support since 2009. He has 0 milliliters of vital capacity and uses continuous non-invasive ventilatory support, which I'm going to refer to as CNVS, continuous non-invasive positive pressure ventilatory support, since December of 2009. He is still alive. He will never need a tracheostomy tube, provided that his condition remains mainly lower motor neuron disease. Next image, please. So my recommendation is to live day by day, hope for the best, and plan for the worst. What I want to tell you is that there's a publication recently about 89 ALS patients who got better. 36 were extremely well documented cases of classical ALS. They were likely to be men, have limb onset disease, progress quickly initially. 19% had progressive muscular atrophy, as opposed to 5% in the general ALS population. Of these patients who improved, the deterioration of 18 stopped for a period of 3 months to 27 years. 9 regained normal strength, and 7 had full resolution of denervation on electrodiagnosis. 1 patient came off of a ventilator after 17 years, and another walked after being tetraplegic for 1 year. In my experience with about 600 patients with ALS, about 10 to 15% essentially stabilize, and some have muscles that get stronger while other muscles get weaker. One woman told me that she was told that she would die in 15 to 18 months. And she was told that in 6 ALS centers. 27 years later, she was walking better and breathing better every year. So it's dangerous to tell patients when you think they're going to die. Next image, please. Patients with ALS can become too weak to breathe and cough. This causes acute on chronic ventilatory failure and carbon dioxide narcosis, or upper respiratory infections or aspiration of saliva or food can cause pneumonia and respiratory failure. This patient with motor neuron disease has been dependent on continuous non-invasive ventilatory support, CNVS, via a mouthpiece since 1954. That's 66 years. Next image, please. She and others have been using a lip cover interface, what was called a lip seal, to hold the mouthpiece in the mouth for sleep. This lip cover interface is no longer on the market. It was made by LifeCare, which was eventually purchased by Philips, but they no longer make it, although they should. However, there is another one that has been, and I think is still on the market, called the Oracle. This is a commercial opportunity for Russian companies to put another lip cover mouthpiece back on the market. I can tell you that my patients will purchase it. Next image, please. In 1987, I described nasal CNVS for this patient with multiple sclerosis, whose vital capacity decreased to 100 milliliters, and she was continuously dependent on nasal CNVS for 4 days before she responded to steroid treatments, and her vital capacity went back to 1,500 milliliters, and she came off of the ventilator. Next image, please. Mechanical insufflation exsufflation, which is the cough assist by Philips Respironics, is the delivery of an insufflation at 40 to 70 centimeters of water via an oral nasal interface or an invasive airway tube or even a simple mouthpiece to full clinical chest and lung expansion. Then immediate switch to negative pressure of 40 to 70 centimeters of water to full clinical lung emptying. Don't use this at less than 40 centimeters of water pressure. It's a ridiculous mistake to use it at 15 to 25 centimeters of water pressure. This creates 10 liters a second of expiratory flow, which can remove secretions from both the right and the left airways. If you suction a patient, even through a tracheostomy tube, you miss the left mainstem bronchus over 90% of the time. Mechanical insufflation exsufflation, which I call MIE, was on the market from 1953 to 1967, and you see one right here. When tracheotomies were being done in the late 1960s, MIE was not used through the trach tubes, a terrible mistake, and so it went off the market. In 1988, I convinced Mr. Jack Emerson, the man who put iron lungs on the market in 1931, to remanufacture MIE. After 2 months, in November of 1988, he gave me one, which I immediately used in critical care. Next image, please. And this is one that he gave me. He got a 5-gallon paint can, put a vacuum cleaner motor in it, and it came back on the market in February 1993. It's now manufactured by at least 8 companies worldwide. It must be used at 40 to 60 centimeters of water pressure through a mouthpiece or an oral nasal interface, and at 60 to 70 centimeters of water pressure through any invasive airway tube. The nice thing about the cough assist today is that it allows you to measure the expiratory flows. Right off the gauge on the machine. When those flows are over 200 liters a minute, essentially nobody needs a tracheostomy tube. But we'll talk more about that in a minute. A good thing about the cough assist from Philips is that it also permits the patients to trigger it. Next image, please. This is helpful for infants and others who cannot cooperate. And it allows people, as I mentioned, to read the MIE expiratory flows. Next image, please. Yeah, okay, so this is actually a more recent cough assist. Next image, please. What is NIV? In the Western literature, you hear NIV. NIV has come to mean continuous positive airway pressure, or CPAP, or bi-level positive airway pressure, which is never delivered at ventilatory support settings, usually because it's prescribed by what we call sleep doctors who use BiPAP to titrate away apneas and hypopneas on polysomnograms or sleep studies. I've managed 3,100 patients on non-invasive ventilatory support. without sending any for polysomnograms, and I don't use BiPAP. BiPAP has been shown to be counterproductive, actually not as good as non-invasive ventilatory support, which is why I use the abbreviation NVS. Bi-level positive airway pressure is cheaper than a portable ventilator, but it is not as good for the patient as using an active circuit on a portable ventilator with a non-vented interface. Next image, please. So NIV is CPAP, which is useless for patients with muscle weakness, and bi-level positive airway pressure used at low spans that don't provide non-invasive ventilatory support. NVS needs to be provided at 17 to 25 centimeters of water pressure for people with normal lung compliance, up to 55 centimeters of water pressure for morbidly obese patients, or it can be provided at volume preset ventilation at 700 to 1500 milliliters. If bi-level positive airway pressure is used, you must give at least a pressure support of 17 centimeters of water. For example, an IPAP, an inspiratory positive airway pressure of 21, and an expiratory positive airway pressure of 4 is essentially equivalent to non-invasive ventilatory support, a pressure support of 17, 21 minus 4. Apneas and hypopneas can be reduced from 80 to 1, but carbon dioxide often remains very high when CPAP or BiPAP are used, rather than non-invasive ventilatory support for people with ALS, motor neuron disease. Next image, please. In 2016, Cresciamano and Elliott demonstrated that any EPAP for bulbar ALS patients causes increased sympathetic activation, increased arousals from sleep, increased low to high frequency heart rate variability, reduction of non-REM stage 2 sleep, ventilator auto-triggering, predominance of light non-REM sleep, and reduction of deep N3 sleep. We have seen patients being tortured by trying to use bi-level positive airway pressure at IPAP 23, EPAP 19, justified by their polysomnograms. This is ridiculous. Polysomnography is not needed since carbon dioxide is not usually measured, and because sleep doctors do not understand that to rest the muscles of ALS patients and to provide ventilatory support, you need pressure support levels of 17 to 20 centimeters of water or more, not BiPAP of 8 and 4. So physicians think that ventilatory support can only be done through invasive airway tubes. This is wrong. These patients should never be treated with oxygen or NIV, which is CPAP and low-span BiPAP, unless they have said they want to die. Next image, please. ALS is the only neuromuscular disease that is predominantly upper motor neuron disease and causes upper airway closure, stridor, spasticity, and causes MIE expiratory flows to decrease and eventually necessitates tracheotomy to survive. Next image, please. A 42-year-old man developed symptoms and was diagnosed with ALS 8 months later. He was placed on BiPAP of IPAP 12, EPAP 4 for an ineffective pressure support of 8. and he remained short of breath. Then he came to us, and we switched him to nasal NVS at a volume of 1,300 milliliters and a rate of 12 for daytime support. He continued to use BiPAP at night, but at 19 and 4 for a pressure support of 15 centimeters of water. In 3 months, he became dependent on CNVS. He was able to frog breathe, to breathe free of the ventilator during the daytime, even though his vital capacities went down a great deal. His frog breathing deteriorated with his bulbar muscle dysfunction. Now, his MIE expiratory flows initially increased from 265 liters a minute to 320 liters a minute. So the cough assist was extremely effective in clearing his airway secretions. But then the MIEEF decreased 3 months later to 200 liters a minute, then 160 liters a minute, then 110 liters per minute, 12 months later. For 12 months, he had been dependent on CNVS with no ability to breathe whatsoever except by frog breathing. So after 12 months of CNVS, his oxygen saturation baseline decreased because of chronic aspiration of secretions that the cough assist could no longer clear because the flows were no longer adequate. And he agreed to a tracheotomy. Well, he got a tracheotomy, but 6 months later, he got palliative sedation and decided to be euthanized. Tracheotomy is never needed for ventilatory failure. I think that's the next image, please. Let's see. Okay. Tracheotomy is never needed for ventilatory failure. These patients have lower motor neuron disease, not ALS. They have spinal muscular atrophy. They have been CNVS dependent since 4 months of age with no movement whatsoever. They have absolutely no movement except to move their eyes about 2 millimeters. They have not been able to take anything by mouth since 4 months of age. When I say they have no movement, I am not kidding. They cannot move their tongue a millimeter. They cannot grimace. They cannot move a single muscle. They cannot move their finger, even trace amount, since they were infants. I told the parents of these patients and others that because they have no bulbar innervated muscle function, they will be dead within 1 year if they didn't get a tracheostomy tube. Well, now they're 25 years old and 23 years old. And I have spinal muscular atrophy type 1 patients, 27 years old, with no vital capacity. None of them have tracheostomy tubes. So I asked myself, why do these patients not need tracheostomy tubes, but ALS patients do? Next image, please. Well, I want to point out that in 2010, centers on our website, breathenvs.com, reported that 73% of 246 ALS patients used non-invasive ventilatory support, and 47% ultimately became CNVS dependent for an average of over 1 year until tracheotomy became necessary. These centers reported that 25 to 45% of ALS patients, classical ALS patients, became CNVS dependent without being hospitalized, going into respiratory failure, or getting intubated. Now, the majority, more than 50%, could not become CNVS dependent because of upper motor neuron bulbar involvement, which caused them stridor, and for that reason they needed tracheostomy tubes before they could become CNVS dependent. But in the New England Journal, over about a 5-year period, there were 13 articles on palliative care and helping these patients die, and not a single one on relieving their symptoms and prolonging their lives by non-invasive ventilatory support. Not one. So any center that deals with ALS should have at least 25% of their patients who are mainly lower motor neuron become CNVS dependent without respiratory failure and needing tracheostomy tubes. Next image, please. In a 2015 report, post-tracheostomy median survival was a little over 1 year. And in that report, MIE, the cough assist, was limited to 2 times daily and at low settings, inappropriate settings. This is like telling people with bronchitis to wait 12 hours to cough. You don't use the cough assist on a 6-hour or 12-hour schedule, or even a 2-hour schedule. You use it when the patient needs the cough. That could be every 15 minutes or a few times a day. This ALS patient with a tracheostomy tube survived 20 years and 3 months. He was diagnosed with ALS at 32 years of age and was trached at 37 years of age. So he used the trach for over 20 years and was still able to swallow food, although he couldn't say a word or move any muscles. So on occasion, people can survive 20 years with a trach tube. Next image, please. Often, ALS patients undergo gastrotomies and are trached because they are intubated and not weanable from ventilatory support. We reported the successful extubation of 26 of 28 ventilator unweanable ALS patients without resort to tracheotomy in 2 studies in 2010 and 2015. Next image, please. The patients were extubated to non-invasive ventilatory support, no oxygen, no CPAP, no BiPAP. Since tracheotomy of ventilator unweanable patients is not necessary, we sometimes remove their tracheostomy tubes. We reported the decannulation of 10 ALS patients who had good bulbar innervated muscle function. 6 had been on continuous tracheostomy ventilation for as long as 3 years, with as little as 110 milliliters of vital capacity and no ability to breathe. Post-decannulation, several could breathe by frog breathing. 4 weaned to part-time NVS, and 6 required continuous NVS, CNVS, for a mean of 32 months, including 2 for 4 and 7 years, before they needed a tracheostomy tube or would have to die, get palliative care. Next image, please. Another decannulation of a 50-year-old woman with ALS, CNVS. She was continuously dependent on tracheostomy ventilation for 2 years. She was decannulated 3.5 years after ALS onset. Next image. She was switched to a cuffless fenestrated tracheostomy tube, the tube capped, and placed on mouthpiece and nasal NVS, taught air stacking, and assisted cough peak flows, and the MIE expiratory flows were measured to assess upper airway patency. Flows of over 200 liters per minute indicate that the tracheostomy tube is unnecessary and can be removed, even though she had no ability to breathe on her own. Next image, please. So we put her on mouthpiece ventilation and covered her ostomy. Next image, please. A pressure dressing using a cane tip with the cane tip walls cut down permit CNVS to be used as the ostomy closes, and she continues nasal CNVS for sleep and mouthpiece for daytime use. Next image, please. The ACE bandage provides counter pressure because the NVS wants to push out through the ostomy, and that prevents it from closing. Next image, please. She used CNVS for almost 2 years before Comfort Care was administered because she refused to be trached again. Next image, please. This image relates to quality of life. Interestingly, after people are trached and on trach ventilation, over 40% are suicidal for the first 6 months to 2 years. But after 2 years on trach ventilation, over 90% of the patients say that they would do it over again if they had to choose. This is surprising to a lot of people. The human brain gets used to almost any circumstances. Happiness is reality divided by expectation. So you're happy if something good happens to you that day, and unhappy if something bad happens. However, you cannot remain happy or unhappy unless you are clinically depressed. So when somebody is deteriorating, their reality is worse than their expectation. If you are perfectly okay and you get hit by a truck, all of a sudden your reality is very bad, but your expectation that day was normal. So you are very unhappy. However, spinal cord injured patients, likewise, there's a high percentage of suicidal spinal cord injured patients for 2 years. After that, there's virtually no suicidal ideation. The patient's reality, their expectations have come down to meet their reality. So quality of life surveys are always designed by able-bodied people to judge the quality of life of disabled people. And usually they're used as a justification to not treat them. If a physician is trying to decide about using a ventilator for a patient, they really need to ask patients who have used ventilators and find out what they think about their life satisfaction, not about their quality of life. If someone is satisfied with their lives, whether or not you think they have quality or not is irrelevant. If someone is satisfied with their lives and happy to be alive, so to speak, I think as a physician, we are obliged to try to help them. So I want you to beware of any surveys that discuss quality of life for any patients. Now, of course, metastatic cancer patients have very bad prognosis, but even ALS patients have been told they will die in a year or two and are alive 25 years later. And almost 50% of my ALS patients become CNVS dependent without going to the hospital, developing respiratory failure, or getting trach tubes. So from now on, I hope you will consider whether or not the patient is predominantly upper motor neuron or lower motor neuron. And that's very easily done by looking at their deep tendon reflexes. So my patients with depressed deep tendon reflexes, with low deep tendon reflexes, I tell them they have a relatively good prognosis, that they're not going to need tracheostomy tubes, maybe forever. However, if they have stridor and increased deep tendon reflexes, they still may use non-invasive ventilatory support, not CPAP, not BiPAP, and not oxygen, to prolong their lives for a year or so before they may need a tracheostomy tube. But when a patient has been dependent on a ventilator through a mouthpiece or a nasal interface for a year, they have a better idea of what they are deciding about when asked if they want a tracheostomy tube or not. So this is very advantageous to use non-invasive ventilatory support settings, even if you have to use BiPAP. You do not need polysomnograms or sleep studies. You need, if you have to use BiPAP and cannot turn off the EPAP, that's okay for sleep. You can use settings of 22 and 4 and provide ventilatory support and good respiratory muscle rest for most of your patients. However, if there is, and these patients all need access to MIE, to basically cough assists, because they eventually start to aspirate and they need to use the cough assist all day very often, along with NVS. If the patient's cough assist flows are under 200 liters a minute and their oxygen saturation baseline decreases below 95%, they're going to need tracheostomy tubes or they will die over a period of a few months. The cough assist flows can go down to as low as about 120 liters per minute and still be effective at clearing airway secretions, provided that the oxygen saturation baseline stays at 95% and more. Don't ever give these patients oxygen at home unless they want to die. It not only turns off their ventilatory drive, but it makes the oximeter useless as a gauge of alveolar ventilation, carbon dioxide, airway secretions that can cause desaturation, and residual lung disease like atelectasis or pneumonia. I'm going to repeat that. No one who doesn't want to die with neuromuscular disease, including ALS, should ever be prescribed oxygen or CPAP or inadequate spans of BiPAP at home unless they want to die and tell you that. Give them full ventilatory support settings, even if you must use BiPAP for sleep. For daytime, BiPAP is not practical at all. And when a patient needs daytime ventilatory support, they usually will need a portable ventilator. Well, I actually went through my material a little sooner than I expected, but that's fine because that provides time for questions. Next image, please. Next image. Okay. No, I want to show, this was my last book. in 2004, but I'm updating that now in 2 volumes. Next image, please. Next image. The website breathenvs.com has every center that I know about that uses non-invasive ventilatory support instead of NIV in the world. And I believe you have some in Russia. There are certainly some great ones in Portugal and in Canada. One problem is that physicians tend to only treat children or adults and not both. So some centers do a great job for children, others do a great job for adults, but there are very few that do both. However, in Canada, in Portugal, at our center in the United States, we take care of babies with SMA type 1 and older ALS patients who may be 80 years old, and without having to train a new staff in how to manage them non-invasively. Next image, please. Yeah, I want to just show you that the book I am working on now is an update of the 2004 book. Volume 1 I have actually finished and it has been printed, but it is not cardiorespiratory. It is how you manage orthopedic problems, nutrition, assistive equipment, and everything but cardiorespiratory management and life satisfaction, quality of life. The only way to get this book right now is to send me a check for $25, but I'm going to have it on Amazon. But I really would like to finish volume 2 first, because the most interesting book will be volume 2, cardiorespiratory management. That book will have an absolute money-back guarantee because I think you will find it incredibly interesting. I am very critical of some expert opinion guidelines that I consider to be very bad for ALS patients and others. So I think that anybody reading it will be fascinated by the stories, the case studies, and the information in that book, which is very much like what I've just told you today. I think that was my last image. Is there another image? No, try. I don't think so. I don't think so. Okay, so there's a few minutes for questions, I think. I hope.
Yes, we do have time to discussion. Thank you very much for your impressive talk. And we have the first question about the patient you told us about who cured for ALS, if we've got it right. Could you please comment on it one more time?
No, I can't, because that was in a publication, I believe by Robert Miller, or, that was not my patient. You read the article. I put the reference there. Okay. Read the article. It's rare. I have had many patients who have gotten better, but I haven't had anybody who got 100% better. But neurologists who are highly respected have published that a number of patients have gotten completely better. I have not seen them.
Okay. The next question was about, could you please one more time comment on the difference between BiPAP and CNVS?
Yes, this is very important to understand. When we inhale, if our tidal volume, if our breath is low, is small, our carbon dioxide goes up. Now, we need a boost to increase our breath. That's pressure coming to help us get a deep breath when we inhale. When we exhale, we normally exhale completely without any muscle activity. Nobody with muscle weakness needs air to come at us to stop us from exhaling. EPAP of BiPAP, expiratory positive airway pressure, after we get an inspiratory positive airway pressure, which gives us a deeper breath, the expiratory positive airway pressure stops us from fully exhaling. That means that we need to give more pressure when we inhale to make up for the fact that we cannot exhale completely. So the difference in pressure between the inspiratory pressure and the expiratory pressure is what helps us to breathe. For people who are not grossly overweight, for people with normal lung compliance, we need about 18 to 20 centimeters of water to rest our inspiratory muscles so that they are stronger when we are breathing on our own. And that when we use 18 centimeters of water during sleep, we feel better during the day and our blood gases get better during the day. Our carbon dioxide normalizes. And if our oxygen is low, it normalizes. You don't give oxygen to normalize the oxygen saturation. You normalize it by giving adequate pressure when we inhale to give us a deeper breath with that has oxygen in it. There's oxygen in the air. 21% of the air is oxygen. So BiPAP of 22 centimeters of water pressure, inspiratory pressure, that goes to the minimum expiratory PAP, or 4 centimeters of water, is 22 minus 4, or 18 centimeters of water of pressure support. But if you can shut the EPAP off, which you cannot do with BiPAP, but you can with a portable ventilator, then you can give 18 and 0, or you could give a volume of 1,000 milliliters. And if the ventilator gives you 1,000 milliliters, that creates a pressure of 20 centimeters of water in the lung. So ventilators, you can set the volume or you can set the pressure. If you set the pressure for 20, you get about 700 milliliters. If you set the volume for 700, you get a pressure of about 20 centimeters of water. That's what you need. Volume is better because if you get 1,000 milliliters, you can hold it and get another 1,000 and another 1,000. That is lung volume recruitment. And that is extremely important to keep the lungs healthy and to help you cough. You cannot do lung volume recruitment actively with any pressure set ventilation. You cannot do it with BiPAP. You cannot do it with a portable ventilator that is set up to deliver pressure. So you can use BiPAP at NVS settings, but nobody ever does that because doctors are not aware that you can give ventilatory support non-invasively. And because polysomnograms correct apnea-hypopnea indexes without fully resting the muscles or providing or correcting carbon dioxide, and at settings that do not provide ventilatory support. It's a little bit complicated, I guess, but I really encourage patients to go to breathenvs.com. It's all explained there. And when I get this book done, money back guarantee, you will find it fascinating. Absolutely fascinating. Patients, doctors, everybody, except the experts, except the people who think they're experts. For the neurology societies in the United States and even the pulmonary societies, I don't think they're going to like the book very much. They let their ALS patients go into respiratory failure and get trached, with none of them becoming CNVS dependent or using the cough assist at adequate settings. So,
Okay, thank you. I have your first book and I like it very much, and I think that the second one will be impressive. So, but now we have opportunity to make a discussion, and I know that we have questions to each other. David, you have question, as far as I understand.
Yeah, John, I know your work. I've read your book quite a bit. I think I even gave the copy of your book to Lev when I was there many years ago in Moscow. Um, and I think that it is a good treatise on this subject. You know, of course, and I fully support people following what you say, whose goal is to survive at all costs and to avoid tracheotomy, etc. And I think that that's an important caveat because it does get back to the issue of quality of life and what individuals consider a quality of life that's acceptable. And I don't think this is the right forum to debate what quality of life means per se. But I do want to ask the question. Let me go back one step. You were exactly right in the example you presented that if you have a maximal inspiratory pressure of 24 and you've got an EPAP of 19, you've only got a delta P of 5. And with that, you won't move much tidal volume and et cetera. But I worry about patients, especially my patients with neuromuscular disease who are recovering from, say, lower airway infections. If they don't get a sufficient amount of EPAP, then they will de-recruit and maintain progressive atelectasis. So in these situations where many of our patients do develop an acute respiratory problem, how much EPAP will you use? I'm not asking how much delta P to give them sufficient tidal volume. I'm asking what you do because your philosophy has always been zero PEEP, zero EPAP. And I worry that these patients will stay de-recruited and atelectatic and not overcome their illness.
Yeah, Dave, very interesting point. See, the question is, where is the patient? Now, if the patient is still at home, what I say to the patient is normally they're using a portable ventilator, usually on volume settings. So they do a lot of air stacking and a lot of assisted coughing, and they use the cough assist. They're not getting any EPAP or PEEP. And I tell them, as long as their oxygen saturation baseline stays normal, stay home and continue using your cough assist, your oximeter, and antibiotics. Now, if the baseline goes less than 95% and cannot be normalized by using their ventilator 24 hours a day and using their cough assist, if the baseline goes down, they usually develop dyspnea symptoms, and they need to go to the hospital. When they come to the emergency room, they're sometimes taken off their ventilators. I don't want to talk about that, but they usually need to be intubated. Now, when they're intubated, they do get some PEEP. Every time I have turned off PEEP on any patient of mine, I have never seen the oxygen saturation baseline increase or decrease. What causes the majority of atelectasis is not hypoventilation, but not clearing airway secretions effectively by using MIE. The vital capacity and the oxygen saturation can increase enormously by just using the cough assist effectively. I have never seen an improvement by simply using PEEP or EPAP. So I really don't think the effect is significant on patients who usually have healthy lungs. Is there any harm in using EPAP or PEEP when someone is sick? Certainly not. And when my patients are intubated, they're always on PEEP. I really don't know how important it is or how effective it is, but we do not extubate them until their oxygen saturation baseline is normal in room air, and we extubate them to non-invasive ventilatory support without PEEP or EPAP.
I think that that's an excellent point, but I want to focus on the cough assist. For example, when I was teaching in Moscow about 5 years ago, I met with a group of parents whose children had teenagers with Duchenne muscular dystrophy, for example. Some of them were SMA children as well. But I think this pertains to the ALS patient in terms of the cough assist. And I was told that cough assist was something that the families had to purchase for themselves. Lev, can you say whether or not that is currently the situation in Russia, that a family would need to purchase outright the cough assist device for themselves?
Nowadays, the situation is a little bit better, and more patients have access to cough assist. They were bought and supplied to a number of regions of Russia and in Moscow. I cannot say that every patient have opportunity to get one, but it's better than previously.
I just want to say that. Well, can I say that when the coughlator went off the market in 1967, patients hung on to the ones they had, knowing that this was what was saving them from getting pneumonias and getting trached. And until 1988, when Jack Emerson gave me the new cough assist, essentially, the patients shared them. So when a patient got a respiratory infection, they would get the cough assist from another patient. And I got 5 cough-laters from a museum in Seattle, Washington, that was given to me by the Life Care Company before it became Respironics and Philips in 1988, but before 1988. And my patients shared 5 of these machines. So when they would get sick, they would get it within an hour or two. The home care companies would deliver it, and most of the time it's spared them from getting pneumonia and going into respiratory failure. So it is possible to share them. You know, you can do active lung volume recruitment or passive lung volume recruitment with a $30 ambu bag. You don't need a cough assist to give a deep breath. We use the ambu bag, block the exhalation valve, and pump the patient up until they can't hold any more air. So you can do passive lung volume recruitment without a cough assist.
Yes,
Yes,
and we
thank
use
you.
the sip and puff system as well for our Duchenne patients to breath stack and to maintain their FRC.
Yeah.
Yes, we're also sharing machines in Moscow. We also have this practice in our foundation. And also, Richard had a question. Richard?
Thanks. John, I heard what you said about oxygen therapy being dangerous in the presence of hypercapnia. I think I also heard you say that sedation was dangerous in the presence of hypercapnia.
Yeah.
That goes against the experience here in the UK, and there has been research done on it because of the theoretical risks that this would happen if you prescribed sedating doses of opiates or of benzodiazepines. But even if it's temporary, there's no apparent decrease in life expectancy with these things being prescribed. So I can understand there is a theoretical risk, but it's not borne out by my understandings. I'm not an expert in respiratory and NIV and all the scientific aspects, but it's theory versus experience, and it's not something that hasn't been researched in the palliative care field. It has been.
Yeah, but what you said was that there's no difference in life expectancy with or without the sedating medications. But you're talking about life expectancy without CNVS and MIE. Nobody is using CNVS and MIE at 60 centimeters of water pressure in England, as far as I know. I may be wrong, but to this day, I don't think anybody is using MIE at optimal settings, and very few people are using CNVS in England. And if the patient is 24-hour vent dependent non-invasively and they go into respiratory failure, I'm virtually positive that nobody is extubating these patients back to CNVS and MIE without tracheing them or giving them terminal palliation. Okay, so if 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 you're right about the sedatives not increasing or decreasing life expectancy, it's because you're not increasing life expectancy by using CNVS and MIE. Now, does the sedative medication have an effect on CO2? I can tell you this: if you have to give oxygen or sedatives, I switch my patients to an oral nasal interface, so away from an open system where the drive determines how much air the patient gets, to a closed system that can ventilate the patient irrespective of the oxygen and sedatives.
Thanks for that. I just think it's important that to qualify the statement that sedation is dangerous in hypercapnia by saying that not everybody wants life expectancy as the ultimate goal. And not so much a question, but a statement. Again, research paper after research paper shows that the burden of assisted or invasive ventilation falls hugely on the family. And yes, if the patient wants to live forever at all costs, fine, but have they understood what it means to their loved ones? Have their loved ones, out of embarrassment or guilt, kept quiet about, well, what does this mean for me? So I think it's important to maintain a balance in all of these considerations.
Rich, in the United States, even though it's unsustainable, our patients on ventilators get up to 24 hours a day of nursing care in most states. In fact, in New Jersey, anybody with a tracheostomy tube up to the age of 18, even if they don't need it and don't use a ventilator, gets 16 hours a day of nursing. It's completely absurd, ridiculous, and it wastes almost $500,000 a year in taxpayer money. But the United States does these things so far. I don't know if the British healthcare system provides 24 hours a day of nursing care for the patients.
It's very difficult to obtain. Nowhere, no healthcare system is perfect. No family, no patient is typical.
Yeah.
I think I'd like to come back to the other point that is missed as we talk about respiratory failure, neuromuscular diseases, and that is really, it gets back to goals of care discussions and values of the patient and the family. And I think that the healthcare system, all the healthcare systems that I'm familiar with, including the EU and Southeast Asia and Eastern Europe, etc. I think we don't help families figure out what's important to them to determine what is important for them. Is this simply quantity of life, or is it quality of life? And if it's quality, how does that family understand what quality is? And in the palliative care world, we often focus on the issue of what is meaningful to the patient in a given situation. For example, we have many patients with advanced metastatic cancer, and for them, it may be important to live 4 more months so that they can be present at the wedding of a daughter or a son, or to have these sorts of experiences as a family together. And I think the same pertains to the patients, elderly patients with advanced neuromuscular diseases. Certainly the patient that Lev and I met a number of years ago in Moscow, the 55-year-old woman with progressive ALS who did not want a tracheostomy, whether or not that was vanity or whatever it was for her, but she and her husband felt that that would not be a good quality of life. And while I know that non-invasive methods of support were certainly possible, focusing on what was important to her kind of was ignored a sense in what is the meaning in her life, what does she want to accomplish still in life.
Can I say this? Dave, I've had extremely few patients refuse non-invasive ventilation support.
Sure.
Okay, very extremely
Yep.
few. Every family is very different. I've had patients who want to die because they don't want to be a burden on their family, and families that insisted to keep them alive no matter what, and vice versa. So it's absolutely correct that every family is different. But what I want to ask you guys, as I find that even though my patients say they do not want trach tubes, and if I say they need a trach, they know they need it because I'm the last person to ever tell them that. But when they get intubated, almost all of my patients change their minds and agree to get trached if they need it to survive. Now, I'd say well over 80 to 90% of my patients literally change their mind when they're facing death. You have not had that experience, or have you had that experience?
I think it
I
depends
think it's
on what the patient and the family perceive by death. If they perceive it to be a horrible horror movie sort of a scene, seriously, I think if there hasn't been thought put into this beforehand, well, by default, nobody's talking to me about it. The doctors aren't talking to me about it because it's a fate worse than death, pardon the pun. And until people can be reassured that staying alive forever isn't everything it's cut out to be, and there are ways of having a peaceful, dignified death, it's not that we're trying to stop you from having helpful interventions to prolong life, but death isn't all bad news.
Maybe that's the British stiff upper lip. I mean, I just don't see this so much in Americans. They change their minds.
Seriously, I get the feeling that it is a cultural issue, and that
Yeah.
I think the notion of keeping alive at all costs is more prevalent in America. I might be wrong, but
I think you're right.
it's cultural issues, and it's horses for courses, to use a British phrase.
Well, I do think that that there is a cultural difference, and I think that if you were in an African village, you would just accept death as natural. If you were in the mountains of Peru, the same sort of thing. And I think what John even suggested, that in the United States, the availability of nursing care at home at enormous expense to society is something that is not available necessarily all over the world. I do know that in Moscow, with the SMA and Duchenne families that I visited, the burden was on them to do the hands-on care of their loved one. And it's one thing when it's a 5-kilo young child with SMA type 1. It's another thing when it's a 75-kilo teenager or adult who has skin breakdown and other care needs. But I think that the important point is that the American society is a society that is death averse. We do anything possible to avoid death, but we don't necessarily help families figure out what it means to live life to the fullest.
And what we mentioned from our experience, and that as soon as we started to use medications to alleviate symptoms of breathlessness, for example, patients started to make different decisions. As soon as they are breathless and they are faced to this very terrible situation, and of course they want to get something to stop this. They ready for any kind of ventilation we suggest. But as soon as we control symptoms with medications, for example, they can change decision and they can say no to ventilation. It's rather new
I'll tell you,
practice.
I've never used medications. I've never used medications instead of helping patients get deeper breaths, instead of ventilatory support. I mean, I find it difficult to believe that that's not resulting in hypercapnia. And the hypercapnia causes symptoms, morning headaches, drowsiness, and so on. So using medications instead of non-invasive ventilatory support, do you guys, Rich and Dave, do you have a feeling about that? I mean, I have never done it. It's never occurred to me to try to suppress symptoms rather than correct the problem causing the symptoms. The
That's
symptoms are not being
fine,
caused
so long
by
as
anxiety.
I think the analogy I would use is, okay, we've got a way of getting rid of the abdominal pain through surgical means. So let's go ahead and do it. Why wouldn't you give that person temporary opiates with a theoretical risk, if you gave a huge overdose, that you would do away with the problem by causing life to come to an end? Why wouldn't you want to give temporary medications whilst you're instituting more direct interventions? I do think that it's, overblown, the risk of causing the person's demise whilst not giving them humane symptomatic treatments, waiting for whatever intervention you've got to kick in. I appreciate I'm seeing it from a different viewpoint from you. I haven't got the experience that you have. Maybe I'm missing something, but I just don't see the big risks that you do.
And
But Rich,
just one point to mention. We have several patients with recordings of PCO2 during morphine infusion, with low dose morphine infusion, and we see that it doesn't go up, so we do not make it worth. So we record PCO2, it's okay, but patient gets much better. So he comes to us with breathlessness, with for example, 30 times per minute and 10 out of 10 by Borg scale, but then we give him morphine, 10 milligrams per day, and his PCO2 is still normal. It doesn't rise,
voila.
and he has Borg scale 2 out of 10, and then next day he can make his decision about ventilation and all other procedures.
Well, yeah, but you see, the CO2 is still normal. If the CO2 were abnormal, I suspect it would go up if you give them morphine. And Rich, your analogy is not exactly on the mark, because you're saying to delay an invasive procedure by giving a medication. If you're giving a medication, you are not treating the cause of the symptom. However, you're trying to delay an invasive procedure which could be harmful. That is abdominal surgery. When it comes to the ALS patient, giving the medication is not addressing the problem that's causing the symptom. And there's no harm in using non-invasive ventilation. Okay, so that's where I think your analogy falls short. I think that we should not use a Band-Aid on a cancer. I think we need to address what's causing the symptom, and that's got to be ventilation or clearing airway secretions. That's what's causing the symptom. So philosophically, that's what I want to address. And you're not doing that with medication. Are you buying time? Maybe. But
may
you're
not
also
be
giving the patient a false sense that there's a medication for his problem. Ultimately,
No,
there isn't a
I'm not.
medication for the problem.
I agree my analogy wasn't absolutely correct. On the other hand, I don't think it has to be either one thing or another. I think with caveats, patients can benefit from both the patient can have some pain relief whilst you're waiting for the anaesthetist and the surgeon to come in on call. You don't have to leave them there suffering for fear of causing harm.
Okay, David,
Thanks. It's been a really interesting discussion.
Okay.
Yeah, Rich.
And okay, and one more question, maybe the last one from me, is I mentioned that John said that he measure like the quality of life, or I don't know how to say it, like a satisfaction from the this very moment where the patient is asked for. Yes, yes. Did I understand you right? So you do not ask him for his quality of life, but you asked him about the satisfaction that he gets right now. Yes, and do you think
life satisfaction.
Yes, David and Richard, I'm very interested about what do you think about this approach to measure the I don't know how to say what to measure, but to measure the condition of the patient and to measure the effectiveness of our approaches.
Richard, take this one.
Yeah, I think. Thank you. I agree entirely with what John said earlier, that quality of life scales or tools are really prone to flaws. However, there are some quality of life tools which allow the person, for instance, to nominate the 5 major domains that give them quality of life. They're not chosen by scientists, doctors, normal people. The person themselves is asked, what in life matters most to you? Up to 5 different domains. And
you know,
in all of those domains, how are you viewing your quality of life on a score out of 10? So it's people don't necessarily consciously sit down and think about quality of life in that way, but these are tools that don't make any assumptions, are much more likely to help the person conceptualize what is important to them. It's therapeutic in that respect, and it also helps their families understand, if they didn't beforehand, what matters the most. Very often family come out as one of the major domains. How my family are matters more to me than how I'm feeling. And that can be a huge revelation to others. So, you know, burden on family often is a huge worry and needs to be considered and addressed.
Yeah, you
So
know, there's
I
a
think it's
psychologist. There's a psychologist by the name of Campbell. I think his first name was Robert, but I'm not sure. I may be getting him confused with other Robert Campbells. But I did cite his work in some of my earlier books. He looked at people with severe disabilities and tried to get a sense of what they considered important in their lives. And it always came down to them loving somebody and feeling that other people are concerned about them. So you're absolutely right. I mean, it all comes down to that. I take care of people with COPD. They're the most depressed patients that I've ever seen. They're coughing all day. They're physically able to take care of themselves, but they're more depressed than any Duchenne patient or even ALS patient. And it really comes down to their personal relationship. And it's totally that. Now, Lev, if you're talking about looking at quality of life, why are you even asking about it? It's usually because the physician wants to justify doing something for a patient. So I really don't think the concept of quality of life is even relevant unless you're asking the patients in that situation what they think about if they would do this over again. And I'm telling you, 90% of ALS patients on trach ventilation for more than 2 years say they would do it over again if they had to decide. And I'm not the only one to find that. Anthony Oppenheimer and Cazzoli did a study on hundreds of ALS patients, and they reported that many years ago. So the brain gets used to anything, and the it's if the patient wants to survive or is satisfied with their lives, as physicians, I think we should help them. Now, there are financial factors that come involved. There's familial factors. I've had families that were totally fed up with the patient and clearly would prefer them to be dead. And I've had the absolute opposite too. The problem for you and me is, what do you do if the patient wants to live and the wife wants to kill them? I mean, what do? You can't stop her,
Okay.
But of course,
And
that happens to people who don't have ALS too.
okay. We have one question from my colleague from Moscow. I would introduce him. It's Yegor Larin. He is also, as David, both ICU specialist and palliative care specialist in one person. And so he's going to talk later on this conference. But now he has a question. That's all, as far as I understood. Yeah.
It's not a question. It's about maybe a small talk. At first, hello to everybody. Very glad to see everyone. So about the PEEP and ZIP. So our practice showed that it's a complex care of the patient with the LAS if the caregivers are well educated. They move the patient and sit, and he had enough staff. He has enough staff to go outside. So usually the zero PEEP is okay. We don't need something more. And when we use MIE, like said John, so it's some kind of recruitment at the time of the deep breath. But when he's lying in the respiratory center, when there are a lack of nurses, so of course we put a little bit higher PEEP for prophylaxis of atelectasis. And I think about some tracheostomy and the decision making, we'll have some clinical cases. I will show that our experience, and I'm very interested in what your opinion about this situation will be. Thank you.
Yeah, well, I don't think there's any harm in giving some PEEP or EPAP, but I've never seen anybody feel better or a saturation improve or change because of it. And you cannot give it during the daytime. If they're using mouthpiece during the day, if you give any kind of EPAP or a PEEP, I mean, the ventilator will auto cycle. You cannot. Patients exhale into the atmosphere. They don't exhale into the tubing when they're awake, So the question is there benefit for sleep? I can tell you this. Until 1976, there was no possibility of anybody getting PEEP on portable ventilators. In 1976, volume ventilators came on the market with the ability to give PEEP. Nobody used them before that. And I actually took care of hundreds of these older patients, none of whom ever got PEEP or EPAP. There was no BiPAP until 1990, and no PEEP on ventilators until after 1976. So, and I looked at their oxygen saturations and carbon dioxide during sleep, and they were normal. So, and there was no indication that they were suffering from any microscopic atelectasis. But these people all had access to cough-laters and MIE, mechanical insulation exsufflation. See, I really think that the atelectasis is mainly caused by not clearing airway secretions effectively. And you don't need PEEP or EPAP for that. But I'm not saying that there's any harm in it. It's just that I don't think it's necessary. And if you look at Cresciamano's paper from 2016, until then, the only population of neuromuscular disease patients I ever used BiPAP for were bulbar ALS patients, because I thought that theoretically, the EPAP might help keep the airway open. Now, I didn't think it made any difference for SMA type 1 or Duchenne or any other neuromuscular disease because, from 1977, I just, patients never used it. My patients never used it. But I thought theoretically, because they had stridor, expiratory stridor, that the EPAP would be beneficial for bulbar ALS. Cresciamano and Elliott. Cresciamano has 2 papers on it, 2016. I can send you the references. I can send you the PDFs. And Elliott, they published that every parameter was worse. What she did was she used the polysomnography and found that IPAP of 12.5, EPAP of 5.5 normalized the apnea-hypopnea index for bulbar ALS. And then she changed to an active circuit and shut off the EPAP. So now the patients were on 12 and 0, and everything was better. The sleep quality, the sympathetic, everything. I mentioned it in one of my images. So all the different parameters she looked at, everything was better on 12 and 0 than on 12 and 5. Now, I don't use 12 and 0. I use 18 and 0 because I want to get better respiratory muscle rest. But I used BiPAP on my bulbar ALS patients until I read her 2 articles and Elliott's article. And now I don't think anybody needs EPAP or PEEP. I think they need effective airway secretion clearance. That's done by MIE. And when the cough flows go down, when those flows go down, you need to be trached or you die. Now, I can tell you that my Duchenne patients, their cough assist expiratory flows never go down. My SMA type 1 patients, when they're babies, they get hospitalized almost once a year until they're 5 years old. When they're 5 years old, they cooperate with the cough assist and they never get hospitalized anymore. And now they're 25 years old. I have 3 patients over 25 years of age with severe SMA type 1, 24-hour vent dependence since 4 months of age. And I told their parents 25 years ago they would need trach tubes because they have no bulbar muscles. And they don't have trach tubes, and now they're 25 years old. And their oxygen saturation in room air is normal. And they're not on PEEP. They have no PEEP or EPAP, So I think you should look at the Cresciamano papers and the Elliott papers from 2016. And again, I'm not saying there's any harm in using BiPAP overnight for ALS patients, but increase the IPAP to compensate for the EPAP. So you want to use 5, then increase the IPAP to 24, 25, something like that. And you'll get better inspiratory muscle rest, and you'll correct the daytime. If the CO2 or saturation is low during the day, it normalizes. Initially, it normalizes when you put them on nighttime ventilatory support. And their symptoms are better, they have more energy, they feel better, until they get weaker. And then, it's another problem.
And John, there's one more question from maybe the last one, because we're a little bit out of timetable, from the audience. And they ask if we can influence on this upper airway obstruction in ALS with medications, for example, with lorazepam or other benzodiazepines, because it seems to be an active contraction of muscles that cause the obstruction. Maybe we could prevent it by using of medications, or even crazy idea by using botulinum toxin to this muscle, just to prevent them from active contracting and causing airway obstruction.
It's very controversial. Some people have said they've had good results with Botox, and others have said they haven't. I would refer you to Tina Anderson's papers from Scandinavia. Tina Anderson. She does fiber optic view of the upper airway in ALS, and she describes closure at several areas. And you can see this when you use the cough assist on bulbar ALS patients with stridor, that on many of these patients, even the positive pressure causes the glottis to close reflexively. And she argues that you sometimes have to decrease the cophocyst flows to as low as 15 centimeters of water or 25 centimeters of water. But those flows are not effective anyway. Now, her papers, I think, are wonderful because and when I use the cophocyst on bulbar ALS patients, you see their chest going, retracting in stages, which means that the airway is closing. Nobody has ever described, as far as I know, being able to prevent that with medications or anything else. And it only happens in the upper motor neuron. This does not happen with SMA type 1. It doesn't happen with progressive muscular atrophy or flail limb syndrome.
Yes.
But with primary lateral sclerosis and with classical ALS, when those cophocyst flows go down and then the saturation goes down, the patients need trach tubes. So I don't think that Botox can do it, but or any medications. I don't think so.
And what we see in our patients when we try to make IPAP higher, we see that they do not like it. Actually, they say that it influences their quality of life, so to say. So they don't like this wind to the face. And what would you say about some side effects of ventilations? Maybe.
Yeah, if they're used to 10 and 5 or 12 and 5, I say to them, increase by 1 a week. However, you're really talking about classical ALS patients here, not lower motor neuron disease patients, because the lower motor neuron disease patients usually don't have problems with the higher pressures. And that's why they have a much better prognosis to use non-invasive ventilatory support than the classical ALS. Remember, less than half of my classical ALS patients can ever use non-invasive support 24 hours a day. They have to get trached or they die.
Okay.
But every other neuromuscular disease, that's not the case.
Okay.
Duchenne, etc.
Okay, thank you very much for this discussion, David, John, Richard. It was wonderful to spend this time with you. I hope you are safer in your cities due to this this pandemic situations. And as far as I understand, Igor is now in the hospital. Yes, Igor, and he made some small break for us between his COVID-19 patients. So I hope we all stay safe, and we'll keep in touch, further discussing issues of how to help patients with ALS.
Okay, I don't understand. Okay. Igor, you don't have a beard. Where did the beard come from?
No, yeah, but no. I made it shorter. It was like this.
Really?
I tried it, but now I should to make it shorter because of the respirator in COVID center.
Yeah. You guys owe me ice cream because, Churchill said that anybody eating ice cream in the streets of Moscow during the winter cannot be defeated in war.
Yes,
and I never got my ice cream. I was there in March, and I never got my ice cream. So,
Okay.
Okay.
Thank you very much. Okay, thank you.
Спасибо.
Okay. Now we're moving to the next talk on Russian experience in non-invasive ventilation. Я думаю, что теперь можно перейти.
And I think that now we will switch into Russian. We will see a small, short video, and then we'll talk about the Russian experience with non-invasive ventilation.
But it's still not seamless. Systems don't always communicate. Clinicians can't always see the full picture. Patients can feel lost in the system. That's why Philips is on a mission to remove the limits of care, helping people manage both illness and health with clinical intelligence that helps to get it right the first time, bringing data, technology, and people together seamlessly. This is what drives us. It's what gets us out of our beds, to help get people out of these beds, healthier, happier, faster. Because today, health knows no bounds, and neither should healthcare. Innovation and you. Philips.
Да, Василий.
So, Vasily, hello again. We've had quite a heated discussion. Yeah, it was very, very interesting. I enjoyed listening to it. So, modern technologies. You know, usually we have these discussions behind the scenes. They are never recorded, you know. And today we had a chance to have it recorded. So, I think everybody can enjoy this really live discussion, not merely reading a paper, but having this first-hand live experience. So, before you start, there's a question. I didn't ask it to John because, because he already responded to this, I think. And I cannot really listen to Russian interpretation at the same time because there were some difficulties with the terminology. So my question is, so the PRISM machine is positioned as CPAP. It's recommended to the patients with ALS as a ventilator. So what does John mean when he says that CPAP should not be used and only portable ventilator should be used? Yeah, let me respond to it now. So, yeah, in general, the PRISM is a whole series of machines. And in Russia, we have these PRISM 20, 25, and PRISM 30 registered, and they are essentially the BiPAP. This is a machine that came out of Somnology. And sometimes they don't have the features which higher grade machines have. John said that the most, well, at least as far as I understood, the main feature for him is to have PEEP set to 0. This is an important feature. I think there's another important feature. There is the forced ventilation and forced control of inspiration time. And the machine PRISM 30 has it. PRISM 25 does not have it, as far as I know. So, if we talk about PRISM 30, this is the machine which already now starts complying to the requirements we need for patient ventilation. Of course, in the perfect situation, the ALS patient should have a higher grade machine than PRISM 30. There is this series called PrismoVent. But now we do not, if we have either nothing or PRISM, of course PRISM is better. And this actually is valid for all other machines. For the Respironics, there's the same situation. We have higher grade machines and lower grade machines. BiPAPs also could be used, even though, well, they should be better. Oh, we can't hear you. Thank you for your response. Now let us start with your presentation. And we are a bit out of schedule, so if possible, if we could just limit your presentation to 30 minutes. I think I can manage even faster. Perfect. Dear colleagues, Let me present my next presentation, the experience of non-invasive ventilation in Russia. I would rather talk about organizational aspects, and they are probably important, but it should have been better to call it, kind of chauvinistically, the experience of non-invasive ventilation in Moscow. Because in Moscow, well, of course we deal with patients from Russia, but still, this is the experience of what we had in Moscow in the last 10 years, in terms of non-invasive ventilation. I really want this experience to be scaled up all over the country.
And I will try to show those organizational aspects that we have been working with and that we try to change to improve the ability to hold ventilation for our patients. The following slide, please. Yes, the first thing to mention is that Moscow is a huge city. It is the biggest, one of the biggest cities in Europe, and the most dense populated in Europe. Moscow's population is comparable to a small European country, and some countries are even smaller. So in general, what's happening in Moscow can be used as an experience of a whole country. And unfortunately, of course, the fact that Moscow is so different from other cities is a huge drawback. And of course, from the point of federal management of the country, of course, it has to be done in a way so that everything is like in Moscow. And but the reality is the following: that Moscow has a lot of money, and there is a chance to use some administrative resource. What we started doing is that we started working with charity for patients about 10 years ago. We practically didn't use at all any state funds, and the help that the patients received actually was not state aid. So for first, we didn't rely on the aid of the state. For now, actually, Moscow local authorities allocate a lot of funds for the support of patients with ALS and other diseases, but we didn't have that before. There is another peculiarity. It's a big distances between the patients, so we work not just with Moscow, but also with Moscow region. We have a problem that we can't always manage to reach all patients to come to their home. And in Moscow, actually, there were lots of hospitals, but when we started, we didn't see this big help, even though practically in all neighborhood we have worked with different experts, but we didn't feel that help in the beginning. So we were like in this huge sea in the people, and it was very hard for us to understand how to help our patients. The following slide, please. So, what was the structure of medical assistance in Russia, in Moscow, and in many cities of our country? We have federal hospitals. These are big centers, mostly with planned hospitalization. So we have at least one polyclinic with neighborhood. We have some hospices, like in this picture we can see the first Moscow hospice. This is one of the best hospices in Moscow, and several sleep labs, what was actually a big advantage. Moscow actually knew what respiratory support was, but in general there were lots of problems. So the patients who needed non-invasive ventilation, they actually faced a terrible situation where they didn't have that medical structure where they could start non-invasive ventilation of the lungs. When they started with the hands of those enthusiasts who did ventilation in hospitals, then the patient was discharged home, but no help at home was provided. There was no patient visit and service. There was no expert center. There was this big federal clinic, but there was no expert center to turn with some tricky, complicated case. In particular, about ventilation or something, just couldn't solve that issue. There was no expert center. The hospice that was working mostly worked and still works for cancer patients. The sleep lab still, even though now the situation is happening, they used to work only for diagnostic apnea. So of course you could put a non-cancer patient to hospital and address the sleep lab, but they weren't getting the actual help that they needed for this category of the patients. The ventilators were not paid by state insurance. The patients had to buy them, and that is rather expensive equipment. Then palliative help was also not, palliative care was only developing. The patients, Liv was saying, were mostly dying with breathlessness, or they got a tracheostoma in ICUs. So the motive for hospitalization in ICU was not about putting tracheostoma to a patient. The patients didn't want to have that. They wanted to get rid of their breathlessness, and the only way who helped them was going to the ICU. The relatives didn't get there. Mostly these patients never returned from ICU, and very often these patients simply died from hospital infections. The following year we're going to have 10 years that this service for ALS patients was created. And we had the children's hospital first, but now this is the main palliative care, but also the ventilation care for children. We were thinking about Western multidisciplinary approach. First, we started working with respiratory support. First, we understood this is just the one component of assistance to the patients, not the only one. Except respiratory support, there is nutritional support. We actually we learned quickly how to put gastrostoma into our patients using endoscopic method. Also psychological support. There is support of psychologists working. It's practical from scratch that we started physiotherapy and ergotherapy. Probably ALS is the first disease that they started talking about physiotherapy, then palliative care, and also a long time ago we administered the first morphine to a patient with ALS, and we achieved the lowering of breathlessness against non-invasive ventilation. We also looked at multidisciplinary assistance. We understood that we need patient organization. It is by patients that this organization was created. Then of course, we also gave out ventilation equipment and the cough assist free of charge. We are helping our patients to get morphine. We also did some decision making, started talking a lot about decision making processes. This is a whole set of approaches for choosing this or that set of interventions into the life of patients. And finally, the fight for patients' rights. We were trying with the help of various legal institutions to actually look at patients' rights. Then, this slide actually shows the idea of multidisciplinary assistance, and here a small study is quoted which says that the patients who addressed for multidisciplinary help, these are the patients with neurological diseases, ALS in particular, if they were in multidisciplinary context, the very fact of it increased their quality of life and prognosis. So the idea is not just about collecting a different specialist. The idea of communication is of communication between the experts, so that there was a chance to have this more precise and more clear interaction among each other. So that probably does improve survival and allows for more high quality respiratory assistance. My main idea is that respiratory support is a part of something much bigger, and you cannot stress just on it alone. It is very important to also do many other things at the same time. The following slide, please. Well, on this slide, actually, it came into my head and I really wanted to write it down. It shows stages in the life of a patient, any patient with a respiratory insufficiency, and the patient fortunately doesn't always stay home. He or she might have some acute episodes. Then they would get to the clinic where they are hospitalized or they're in the ICU, and then they are just in inpatient. So this is a typical way. First, there is an ambulance arriving. They are trying to do something about the state with medication. It doesn't help. They even already can start respiratory support. I really hope that such patients won't have oxygen administered to them, only ventilation. The patient is taken to the hospital. They arrive either in the ICU or in the emergency. First, if they use mechanic ventilation, but in more intensive, but in the units where they are more about quality of life. Mostly they use non-invasive diagnostics and treatment. They use non-invasive ventilation. If it's about multi-organ deficiency, then of course they would be in the emergency. If it's about one organ disease like pneumonia, they would just be in the inpatient ICU. The patient is then brought to pulmonology unit, and here the acute stage, acute respiratory insufficiency finishes, and then the chronic respiratory insufficiency starts, because as a rule our patients are mostly chronic, with those with chronic insufficiency. Here the pulmonologists work. I'm among this category of doctors. Here we determine the indications. If the patient is not yet on ventilation, then there is indication for non-invasive. If they are not non-invasive, the correct parameters so that the patient doesn't go to emergency again. Then the relatives are trained, and if necessary, the parameters are titrated. And the patient is discharged. And it's very important that the assisted service of continuous home ventilation actually meets them there, so that they can help maintain the patient's state in outpatient conditions. And if necessary, if a patient is in terminal stage of the disease, can be hospitalized to the hospice and get assistance there, or they might get it to hospital again. That really depends on his or her decision about how the course of the disease and the patient's attitude to the disease. My main idea is that it is impossible to do respiratory support if not all stages are not correct. For example, just imagine this there was a patient on a non-invasive ventilation, and there is no non-invasive ventilation in ICU, so the patient doesn't get non-invasive ventilation. So when they go into ICU, the first patient is just intubated because they don't know how to do it otherwise. Or the patient is discharged from pulmonology department, but in outpatient context there is no service to support the patient at home with the ventilation, and again the patient is just somewhere in emptiness, and again there is an acute episode. So it is very important to create these conditions for respiratory support. The following slide, please. Yes, actually that's a repeat of the slide. Yes. So who pays for the assistance and where it is provided? These are the schemes. I think that for Russia and for Russian doctors, there is nothing new here. Acute respiratory insufficiency in ICUs, as a rule, these are state clinics, sometimes private clinics. Most often they're paid by general medical insurance, sometimes and the ventilation equipment from public clinics also provided. Then chronic respiratory insufficiency, home care. Most often it is provided at the expense of charity funds. Unfortunately, there is no big help from the state. Would have liked to have more of it, and sometimes also a private clinic can also organize it if the patient pays, and the patient can use his or the charity's money to buy this ventilation equipment. The main idea, which hasn't yet formed, it would be great if charity organizations and additional medical insurance actually helped in the ICUs more, and the state system and the general medical insurance worked more with home ventilation and with providing equipment to be ventilated home. I think that each of these three stages there should be assistance both from the state and the private sector, general, additional medical insurance, and charity. Well, we already talked about invasive ventilation. I think that I won't be too detailed about that. There are two methods: invasive, non-invasive ventilation. We faced that immediately. We had lots of patients on tracheostoma. We started talking to them about very different variants. When we had morphine, when we had active ventilation, of course, we actually moved away from tracheostomy towards palliative care and non-invasive ventilation. Well, it's interesting to see that these ideas about ventilations change in other countries according to this study. This is something of 2013. Now it would be relevant to do some repeated study. The preferences. We won't look at the 1990s, of course, the end of 90s and early 2000s. Mostly it would be mechanic ventilation, not non-invasive, but mid 2000s, non-invasive ventilation already dominates over mechanical ventilation. But as John correctly put it, invasive ventilation is a method that is used has been used for a long time, non-invasive ventilation, and in general, of course, the preferences should have been formed in the beginning of the 90s, but still the trend is there. And we are also part of this trend, and we showed that our patients very quickly moved away from tracheostoma to more intensive and more active use to non-invasive ventilation. Thank you. The following, please. So, the situation with acute respiratory insufficiency. The main idea of the ventilation, of course, it's about this, the hospital. And, of course, somewhere here we have to understand the place of non-invasive ventilation. It is in ICU. This is a unit with a good proportion of nurse to patient ratio, but it's not as hard as emergency care. But still, it is more intensive than the general unit. That would be an ideal option. The following slide, please. Well, this is called high dependency unit, HDU, sometimes respiratory intensive care or something else. This is half intensive, half regular department, some intermediary variant. Actually, non-invasive ventilation is also is an intermediary between mechanic ventilation and conservative drug therapy. And the main task of non-invasive ventilation of these high dependency units would be to take away some ICU patients. In most Russian clinics, it's either general departments or emergency. There are no, or if they are there, they are not, don't perform their role. The main idea would be to take these really serious patients from the general units and to take away light patients from ICU into the sort of half ICU. As an example, patient with moderate respiratory acidosis, 7.25, 735, this would be an ideal candidate for this taken away from ICU. 8 beds could be freed, and then they could be for graver patients like with COVID-19, for example. This is how, in my opinion, the scheme of patients' movement in the units looks like. The patients come in with acute respiratory deficiency, has ventilation done. Acute respiratory insufficiency is stopped. They are just brought into general department. And if the patient has chronic respiratory insufficiency, first we look at empirical parameters of ventilation. We look after his or her breathlessness. We evaluate the disease progression. We also do some neurological examinations. We evaluate ventilation under the control of sleep lab. Then we talk about decision making if it's possible. If it's possible, we also choose drug therapy for controlling breathlessness. I think these are good tasks for a patient who is now an inpatient, to also do some to use some additional methods that are also going to help prevent the following hospitalization. And again, non-invasive ventilation and acute respiratory deficiency is an intermediary link between the situation when ventilation is not needed and the situation when mechanic ventilation or trachea intubation is necessary. So here there's going to be an example. pH 725 to 735, that's from COPD. This is the place where you have to start non-invasive ventilation. The following slide, please. That's chronic respiratory insufficiency. And here there are different issues. Here we have to look and see. First of all, ventilation has to happen during the sleep. There is no proof that replacement of nighttime ventilation into daytime improves disease progression. So there should be nighttime ventilation. Of course, you can extend the time for ventilation, especially in acute episodes. Such increase of time, especially for progressive disease, has to be agreed with the patient or the legal representative of the patient. So we have to always say that the patient breathes more and more under the mask, that this shouldn't be just neglected. We have to talk to the patient that now there is more ventilation that they get, that the patient has to understand what's happening to them.
It's quite rational to use symptomatic methods to control breathlessness so that the patient would not have fully dependent on the machine, so that they have more autonomy, so that they would use other means to correct breathlessness. And if there is the idea to switch to mechanical ventilator, it's possible if the patient decides to do that and if they see advantage in that. Here we see the progression scheme of chronic respiratory failure, and there we start non-invasive ventilation at some moment. Of course, there are more acute phases or less, and here there was the increase in the time of ventilation, and symptomatic care is also prescribed at some stage, and then of course the tracheostomy can be indicated in terminal stage if the patient decides so. So when do we switch to ventilation? I think that first we'll have to try different masks, different ventilation modes. None of the masks is possible to ensure adequate ventilation. That's one criteria to switch to ventilator. If the patient has to aspirate fast, if they cannot cough out, and if they don't wean off. Even though John Bach said that it's quite possible to wean off the ventilators, but if they have to stay at the ventilator, then of course this is what we have to do. Next slide. Yeah, here. Thank you. When do we start? When do we continue ventilation? Of course, intensivists will say, well, in the ICU, because here we have the control, we can train the relatives here. But, and like John said, that there are physicians who deal with both children and adults. I only deal with children, and I forget to change my slide. So the slide has staying with a mom. Well, of course it should say with relatives. If they cannot be with the relative for 24 hours, of course, then it's in the ICU. In the general department, yeah, that is a good option for the adaptation to home ventilation, but still risks remain. And unfortunately, doctors in general departments, they are not as acquainted to respiratory equipment. At home, it's way better. But from home, it's difficult to get back to hospital. They don't have an intensivist nearby. And of course, there should be a physician that ensures the follow-up. But of course, home is the best situation for, well, home ventilation. The decision-making. Well, in the legislation of the Russian Federation, there is no definition for end-of-life decision. If we talk about children, if we talk about incapacitated patients, then also it's not really clear who takes the decision for the patients who cannot sign. It's quite similar to children. Also, the role of the physician is not very clear. The physician should be unbiased arbitrator, but they have their own motivations sometimes to skew the decision making. There is also the locked-in syndrome problem, which is developed in ALS, and some patients are afraid of this even more than the disease or death. Next slide. This picture is taken off the internet. I think This is a child with a trauma with a locked-in syndrome. Of course, it is a very unpleasant event when the patient cannot interact with the environment in any way. This is an article from the UK, or is it US? I don't really remember. Nevertheless, here, court. It was the court which petitioned switching off. The person with partial locked-in syndrome requested the switch off of the ventilator, and the court said no. This is a document for SMA type 1, where the British court was on the side of the physicians, which stopped the ventilation for patients with SMA type 1 because it was not in their interest. But the higher court in 2006 took the opposite stance. So here it's about this legal collision, whether we can or cannot switch off or avoid ventilation in patients at the terminal stage of breathing insufficiency. So the issue is worldwide, it's global, and it's very difficult, of course, to resolve, and nobody will be able to give an ultimate solution to this, I think. That is why the optimal path is taking the decision at the early stage of the disease. And of course there are two extreme options, the tracheostomy and mechanical ventilation when the patient wants to live as long as possible with the highest possible, or the highly intensive ventilation like John Bach taught us, or the palliative path, which teaches us, which David and Richard were teaching, and symptomatic care with the goal to maximize quality of life and control the symptoms, or something in between. Sometimes I'm criticized for trying to kind of sit on two stools. I try to pick the best from the intensive ventilation concept and the palliative care concept, and I try to discuss a lot of different aspects with patients, trying to find the balance between the ventilation and palliative care. Next slide. So, a few words about our service. The data is quite old. Unfortunately, we don't have any fresher data. Most patients who come to us, they already have indications for ventilation. VC is slightly over 50% from the norm. Most patients are informed about their disease. It's very good that a third of patients have symptomatic care. It's already good. Previously, we had 0 here. Next slide. Well, the distribution is almost equal. It's bulbar, neck and chest, and then lumbar. So most patients have respiratory support as non-invasive, some have invasive ventilation, some are not supported. About a third of patients get gastrostomy or feeding tube. Most patients have no gastrostomy. 27 patients with tracheostomy, only 3 have it planned. Unfortunately, we have a lot of urgent tracheostomies. A lot of patients die in the ICU after tracheostomies, with the median of 40 days after tracheostomy. Survival rate. The best survival rate is for patients who came to us in the early stage of the disease and patients without the bulbar form. Most patients, 80%, they die at home, 18% at hospital, and a small percentage in hospices. This is the curve that I have been showing. Invasive ventilation improves the prognosis as compared to lack of invasive ventilation. Next slide. 30% of patients discussed the death. A quarter of patients talked about their preference in the place of death. 2/3 of patients died at home, and most patients who responded prefer dying at home, not in the ICU. Next slide. This seems to be it. Thank you. This was a brief review of what we are doing and what we were doing. And I would like to answer the questions now, if possible. I don't see any active questions in the chat so far. We had quite a very streamlined presentation of our experience. People are probably still digesting the previous discussion. Yeah, I fit in 30 minutes as you asked. Now let us listen to Yegor Larin, and he will also share our experience. And then after that, if you have any questions, feel free to ask them actively. Then we will respond. Now Yegor Larin will talk. He is a reanimatologist. He worked in the Palliative Center first, and now he works in COVID-19 unit. Well, a lot of physicians had to change their profile. So anyway, he has quite a long experience working with ALS patients in the Palliative Center. So this experience, and this was a palliative center with access to ventilation. This experience is of interest for us. The combination of palliative and curative approach in the same facility in Russia. Igor, can you hear me? Very well. So, I report on the decision making. And a lot of things have already been said. So the standard path, and John mentioned that patients with acute phases, they get hospitalized, then they get tracheostomy. And I remember our conversation, we even were thinking the tracheostomy in patients without bulbar disruptions with NMDs, with neuromuscular disorders, the tracheostomy is actually a defect of care. It can be considered as such. So, if you were attending this similar conference yesterday, you saw this case. But now let's try to look at it from a different angle. I wanted really to show it to our international colleagues. Next slide. Patient with ALS, 52 years old, female. She is in consciousness with, and she is tetraplegic, but she remains conscious. She said no to tracheostomy. She did not tolerate the non-invasive ventilation, because of the beginning of bulbar disruptions. Back then, I didn't know John, and then, of course, if I had known John, if I would have known his advice on changing the setup, I would do this. She said no to gastrostoma, and also, as she had some bulbar disruptions, it was difficult to use cough assist. Then we have read that we have to use the oscillatory mode, but I think it wasn't available back then. Now, we did not use sedation drugs because she was afraid that she was lose consciousness. She was communicating with her nephew, and this was essentially the meaning of her life at the moment. Next slide. She had abdominal pains. We made ultrasound to be hospitalized her. Before that, we talked to her quite extensively. We chose the pros and cons of hospitalization. As the result, we decided that in general, with non-invasive ventilation, she'll be able to cope. We understood that there's a risk of switching to tracheostomy, but I promised her that we are not going to do that. And she actually had an acute surgical pathology which can be removed, and then we could continue respiratory support. So we did the surgery. She was on ventilation for 36 years through the endotracheal tube, and of course tracheostomy was discussed. And of course by the time she did not initiate her breathing in voluntarily on her own. And in that particular ICU, even though we had quite good machines, these expert class machines are not always good for non-invasive ventilations. For brief periods after extubation, after surgeries, yeah, for 2 or 3 4 hours they could go well, but for continuous ventilation they are not always comfortable for patients. And I think John has even mentioned a study when they did measure different pressure parameters. So next slide, what are we gonna do? Remember, the patient said no to tracheostomy. As doctors in the hospital agreed, we extubated, we switched her to 24-hour non-invasive ventilation using the cough assist, and it went well. Then we call the medical council, we transfer her back to the center. So this is how it was formalized. Our medical council defined it like that. We won't spend time. Essentially, the medical council said that we can avoid intubation if she has a terminal stage of incurable disease, and that we plan her transfer. Next slide. Unfortunately, we couldn't transfer her in time. By morning, she had a cardiac arrest. We do not know the reason, the cause, because the relatives said, do not do autopsy. Well, probably it's the progression of the disease. I don't think it was related. Well, it could have been related to difficulties of ventilation, but we don't know. And well, at the moment, it is not crucial. What I want to say here, that yes, we managed to take this patient not through the standard route. It took us a lot of effort and time, but what's the most important? We did what the patient wanted. We did not give tracheostomy to her because she was really afraid of the locked-in syndrome. So I think we helped her. And unfortunately, she died, but the most important is that the interests of the patient were considered in full. As for the CPR, the physician on duty took the decision that was needed. It was there, right? Because they were responsible for the life of the patient, and only they, only that doctor, not we as consultants. So I think they took the decision, and it cannot be discussed because it was their responsibility only. Next slide. Clinical case number 2. I will just show you a few cases, and then I think you might have questions. Female, 40 years old, ALS. She is conscious. She is tetraplegic. Lev knows this patient. She quite paradoxically, quite ironically, she was a nurse in the ALS unit, and she had bulbar disruptions. She had gastrostomy, and she rejected non-invasive ventilation. It was her choice, and any sort of respiratory support. She rejected that. And she even specified all her requests regarding the funeral. Like in her head, she had a very specific plan that she followed and she wanted to be followed. Our task was to ensure her comfort and quality of life, trying to maintain it as much as possible for as long as possible. Next slide.
Presently, the patient is alive, as she was adamant in refusing non-invasive ventilation. There were single cases in literature. We tried and we discussed with our German colleagues that actually we could look at HFOT, oxygen therapy, but here we mostly used it not as an oxygen therapy as such, but actually to take out CO2. I cannot say how efficient that is. Maybe just psychologically that gave her the feeling of airflow, like with palliative care, and actually maybe isn't her state in general. But that's what we have. The following slide. Clinical case number 3. A man, 32 years of age. Here, this is a very telling story. The patient's not with ALS, because actually the point of decision making is still the same. You still have to make the decision, and it doesn't matter what is your illness. He was diagnosed with glioblastoma. In all medical facilities, he was refused chemotherapy. They go to a private clinic, to several clinics, second, third, and in one of the clinics they still take him in, and that's the result of that. You can see that in the following slide. His state deteriorates. After the first paid chemo, he develops a coma. State deteriorates. He is put into mechanic lung ventilation, noradrenaline, parenteral nutrition, which is actually still something I wonder about. Why did you decide it? Because it was probably more expensive, and they decided they would simply pay for chemotherapy. But according to the agreement now, his treatment costs about 500,000 rubles per day, more or less. Of course, these people keep asking everywhere. They write, they call, they find the Center for Palliative Care. I go and consult this patient. So this is the following slide. That's what happens. So I come for consulting. Of course, the patient cannot speak his mind. We talk to his father, mother, and his wife and his son. That's a rather hard discussion that we're having, because on the one hand they want to continue his treatment. On the other hand, they understand that they simply have no money to live for, even if they stay here for just a couple more hours. So we make a decision about putting him on continuous respiratory support, and colleagues who actually do that, it's important to share this experience that for a very long time we discussed with them why and where they go, that they do not go to an ICU, that there will be no cardiovascular resuscitation due to the disease, that there will be no chemotherapy. And I had to, due to the urgency of the situation, normally we always recommend to the relatives to come and see where their relative is brought to take pictures, to show to that relative if he or she can make decisions, if he is conscious, and agree that then there are no surprises for the people. And no basis for conflict, for complaints. People promised, and the doctors and all the others actually kept their promise as a medical organization. That is why I make them repeat something that they don't really like, what they were chasing away from them, that they said, mother said that their son should die in comfortable conditions. On the other hand, we have no chance in our country to stop mechanic ventilation of the lungs if there are no indications. But he didn't have any indications for that. We cannot switch off the vasopressor support and noradrenaline also, but we have the right in different palliative care regime not to increase the dose. They were not that high, those doses. We cannot, in the absence of indications, decrease the oxygen fraction, but again, we don't have to increase it. So what I'm saying here, if we see on the monitor that the saturation is 100% and oxygen fraction is 40%, we have the right until 92% is achieved, we have the right to lower the oxygen fraction. But just looking to see, but simply turning the handle, we cannot do that. We need justifications for that. That is not very convenient. The following slide. So what this cost? He was transferred, everything was successful, as he received vasopressors and a rather high fraction of oxygen. His death came in 3 days. For all this time, his family was next to him for 24 hours. There was a psychologist, a psychotherapist working with them. And actually, during these 3 days, they managed to come to the acceptance stage, to accept the situation. Of course, that was incredibly hard, because there's a very young man with a small kid. But this happened. And I believe that this was a small victory that we had. Of course, this also shows us that these problems can be solved, even in the framework of the current legislation, without breaking this legislation by any means. And also we can offer some changes into that legislation. We could adapt it. Well, there are options. So the following slide. So what we have real. We say that there is a legal side to that the choice is something that only the patient has. We have informed voluntary consent, which is signed only by the patient or his or her legal representative, which was recognized by court decisions or by parents because they're legal representatives of a minor child. But if the patient is unable to express his or her will and they have no legal representative appointed by the court decision, or for example, if they are parents of a minor child, the consilium out of the board out of 3 doctors can make a decision, but this only works for life saving. We can make a decision that the patient has to be put on mechanic ventilation. The relatives actually have no rights to make decisions. They can ask, they can say, they can complain to anything else, and normally they write these complaints. But making decisions is not something that they have the right to. No right whatsoever. And partially that's a paradox that we have. And the most is that patient by informed consent can indicate last names, first names of relatives who they want to be informed about the state of the patient's health. It is possible, according to the law, not to resuscitate. I refer to that. That's Regulation 952. There are items for children and items for adults. That's what I mentioned. That in terminal stages, the patient if we recognize and if it has been proven that the disease is incurable, then we can do no resuscitation. What do we have actually? The opinion of relatives is taken into account. Sometimes, unfortunately, contrary to the interests of the patient, it is impossible to refuse life-saving procedures if it started. It is impossible to stop life maintenance if the patient is conscious and if the person can express their will. For example, a patient with quadriplegia, including patients with ALS or spinal trauma, and they say, I don't want to live anymore. The medical service, I want to stop this service, but nobody, legally has the right to refuse. We can document that refusal, but we cannot, or we won't find the person who is going to conduct this procedure of switching off. And the most important thing is that yes, well, everything is written, so following slide, please. Thank you for your attention. I have shared our experience. It's rather modest, but for now we're just making the first steps, and I believe that we already have a lot of success stories. So I wanted to share those with our colleagues to see maybe there are some questions, just to show that everything was possible, and hopefully I managed to do that. Yes, Igor, thanks a lot. It seems to me that here it's important not to look at the quantity but the quality, because something that we faced discussing with Western colleagues is that the first obstacle is specialists who are not informed enough, but when we got some knowledge and some idea how to do that, we understood that the second obstacle would be organization, legislation, and things like which are very hard to overcome when you're on your own. So each successful case, more or less, of application of the knowledge and something we've gained in our experience is something that is worthy of our attention. And thanks to this experience, I think that the legislation is going to change, and everybody will get the chance to, after get to this knowledge, to actually implement it. So thanks a lot. Coming to questions. In the English broadcast, there was a question, as I understand, initially to Richard, but you might answer that, I think. Can we use slow release medications like diazepam instead of morphine to reduce breathlessness if we don't have morphine? Well, first of all, we have to know what diagnosis is, then we'll make a decision. Okay, ALS. It's ALS. Yes, we can do that. The question is whether there is non-invasive ventilation happening or mechanic ventilation. Diazepam is their drug of choice. In the protocol, it can be used. Actually, any methods would be good. It depends on what you have access to. Of course, the drug of choice is morphine, and now we have, if you don't know yet, we have this fast release morphine in pills that's going to work for 4 hours, and the dosage is going to be very low. As for diazepam, I believe it's going to impact more the mental state. I mean, honestly, for example, in ICU practice, they are moving away from benzodiazepines. They just move, but there are descriptions of that. Well, the availability of conscious, whether the patient agrees, whether the patient is ready. And Richard answered in the following way. He wrote his answer. He emailed the answer, but he is already off the broadcast. That lorazepam sublingually is used in crisis situations. For example, acute breathlessness. But for long term, as far as I can interpret his answer, it's not too desirable. But in our experience, some patients receive lorazepam several times a day, and they note the reduction in breathlessness. Of course, it's not the best scheme, but with certain accompanying conditions, I think it is accessible. For example, anxiety. There are some effects of this drug, and with a certain combination of symptoms, I think that that's why our patients note that their breathlessness is reduced in such use, even though the scheme is not optimal. But there is also another question: how do you legally document the patient's decision on mechanic ventilation, and actually whether it is possible at all? Well, the point is that muscular atrophy is going to progress and motor function suffers. So, I mean, the point is not about not receiving mechanic ventilation. Yes, if the reason of going on mechanic ventilation is, for example, the development of pneumonia due to inadequate sanation of trachea, then of course you can put the person on mechanical ventilation, treat pneumonia, and put the person back on non-invasive ventilation or with the cough assist, what you saw in the first clinical case that we discussed. But I think that it is about, I mean, of course I'm just adding up. I think what is meant here is how you document maybe the refusal of mechanical ventilation. The person is not on it yet and doesn't want to go on it under any circumstances. Here, unfortunately, no signed documents presently are not going to work. They are not enforceable. Because any doctor who is going to have patient brought to him unconscious and without breathing, or if the doctor doesn't know it, of course, the doctor has to provide assistance in full, because the doctor cannot use this confirmed disease as the foundation, because the doctor just doesn't know about it. And the format refusal is not about going after medical assistance presently. For this, there should be good palliative service provided. And the first question, when the relatives or family start calling, first of all, they have to accept the position of their loved one. They have to share that stand. And when they start calling, first they have to call palliative care and not the emergency. And they are going to give you advice. And let's not forget that, for example, if there are some conditional reversible conditions, they do not exclude the need for palliative care and the care of other types. For example, if we take our favorite gastrostoma. Actually, this is yet another type of medical care, palliative care. This is specialized surgical procedure. I don't know how technical it is, but still it is provided to the patient, not because he has ALS, but because he has nutrition issues, right? Yes. And the patient might have pneumonia developed. There were cases when, after ventilation, the ALS patient and with patient, they actually managed to take the patient to wean off ventilation, but there are different situations. And of course, you have to act depending on the situation. But now, there is no paper that you can sign beforehand. Something like do not resuscitate document. We don't have it as far as I understand, right? And it has no full legal force. Am I right?
Я хочу
I would like to say thanks to all the participants. I think we had quite a productive discussion over many issues regarding ALS patients. I hope it was useful for those who manage these patients, and I hope some people might have learned something new, some have heard some tiny nuances that will help improving the life of our patients. Thank you so much. Thanks to the Live Now Foundation, thanks to all the speakers, thanks to Philips, which supported this conference, and thanks to all who have stayed with us all day long, and even those who have joined in, who have tuned in for a limited time. Take care. See you at future events.
A natural cough. Cough Assist T70 is an effective, comfortable way to help clear the airway. It gradually delivers a large volume of air to the lungs, similar to a deep breath, then quickly reverses the airflow to pull secretions out. Cough Assist T70 is designed to be easy to set up and operate. To power the device, press the power cord firmly into the back of the device and plug the other end into an AC outlet. If you prefer, you can attach the optional lithium-ion battery into the detachable battery slot on the back of the device. A DC power adapter can also be used to connect to an external power source, such as a car battery. Cough Assist T70 can be used with a mask, tracheostomy tube, or mouthpiece. To build the patient breathing circuit, attach a bacteria filter to the breathing circuit connection. Attach the circuit tubing to the bacteria filter. Press the filter onto the connector on the side of the device. If the patient will be using a face mask or mouthpiece, attach it to the circuit tubing. If the patient has a tracheostomy tube, place a trach adapter on the circuit tubing. If the trach has a cuffed tube, inflate the cuff. Help the patient into as upright a position as he can tolerate. Press the round Start-Stop button on the front of the Cough Assist T70 to enter standby. If the device is running on AC power, the button will illuminate. Check the treatment settings to make sure they match the doctor's prescription. Before the first treatment session, it's a good idea to let the patient feel the airflow so he knows what to expect. This is helpful when working with children. Consider giving the patient an opportunity to get familiar with the mask or mouthpiece. You may also want to work out a stop treatment signal in case he needs a break. Press the rectangular right button below Therapy to begin treatment. If you are operating Cough Assist T70 in manual mode, slide the control lever to the right to trigger an inhalation, or press forward on the optional foot pedal. When the inhalation is complete, slide the manual switch to the left or press back on your heel for an exhalation. Position the mask, mouthpiece, or trach adapter on the patient. When using a mask, make sure it is well fitted to eliminate possible leaks. If you hear or feel an excessive air leak during the inhalation period, support the back of the head with your hand or a pillow to improve the seal. If you're using a mouthpiece, nose clips may be needed. Instruct the patient to open his mouth and actively inhale during inhalation and exhale during exhalation, which will open the airway for unobstructed airflow. Ask him to keep his mouth open and tongue down throughout the therapy. Encourage the patient to be relaxed and passive during the inhalation and the exhalation cycles. When providing a treatment in the manual mode, you can see how long you are delivering the inspiratory pressure and how long you are delivering the exhaled pressure on the screen. The center position on the lever activates a pause. Depending on patient preference, you can pause for a few seconds after exhalation before initiating the next in-breath. Exhalation pressures appear on the left as negative numbers on the Cough Assist T70 screen. Inhalations are shown as positive. Both appear in real time. A simple screen view with less respiratory information is also available through menu options. The detailed screen provides additional clinical information. For the initial treatment, you may want to begin with lower pressures to give the patient a chance to get comfortable. You can gradually increase pressure as described in the pressure and timing adjustment portion of this program. A cough cycle is defined as inhale plus exhale plus pause time. Deliver 4 to 6 cough cycles in rapid succession, followed by a rest period of 20 to 30 seconds. Repeat this sequence, 4 to 6 cough cycles and rest period, 4 to 6 times for a complete treatment. When the treatment is finished, press the right button to halt the airflow and return to standby. The patient's prescription will determine how many treatments are to be administered each day, for example, a treatment every 4 hours. If the doctor orders the treatment as needed, the patient can determine how many treatments he receives during the day, depending on how often he's to clear secretions. Cough Assist T70 can be operated manually, which you have just seen demonstrated, or in automatic mode. In automatic mode, inhale, exhale, and pause times are controlled by the time settings entered. When using the cough track option, the device will automatically detect inspiration effort and respond with an inhalation. With automatic operation, there is no need to toggle the manual switch between inspiration, exhalation, and pause. Cough Assist T70 will do it for you and display the pressures in real time. Here again, the patient should actively inhale and exhale. You can pause the treatment at any time by pressing the right button under Standby. After the treatment, clear any secretions from his mouth, tubing, and patient interface. It is important to wash the breathing circuit and patient interface with mild liquid detergent and water. The parts must dry completely before next use. The bacteria filter cannot be washed, so you should replace it if it becomes blocked with mucus or trapped moisture. You should clean the air filter at least once every 2 weeks and replace it with a new one every 6 months. 3 unique prescription settings can be stored in Cough Assist T70, so you can quickly select treatment pressures based on a patient's current needs. On the upper right-hand side of the screen, if you see a small open lock icon, you will be able to make changes to the settings. Changes can be made to the settings during standby or therapy. A specific prescription can be entered during standby, but titrating is easier to accomplish during therapy. To enter prescribed settings, press the left button under Settings. A setting menu will appear. The first item on the list will be highlighted, in this case, Preset. Press the Modify button. You can select which one of the 3 presets you wish to modify. Press the OK button to confirm the preset. You can select other settings by using the center Navigate buttons. Let's say you want to change the pressure temporarily while a patient is being introduced to treatment for the first time. Use the center Up-Down button to move down the list until inhale pressure is highlighted. Press on the right button under Modify. Use the center Up-Down button below Edit to lower the pressure to the new setting. For an initial treatment, a low exhale pressure of -10 to -15 cm H2O may be a good starting point for an adult. Once the patient is accustomed to the therapy, exhale pressures of -40 to -45 cm H2O may prove more effective at clearing the airway. Press the right button under OK. Press the right button under Modify to change the next item on the list, which is Inhale Flow. Use the Up-Down Edit button to adjust. If you try to change a setting beyond the available parameters, a Limit Reached message appears. In this case, after you have entered the correct pressure, press OK to accept the new setting. Use the right button under Modify to highlight inhale time. A typical inhale time for adults with a low flow setting is 3 to 4 seconds, 1 to 2 seconds in adults with higher settings. For small children with low flow, 1 to 2 seconds is typical, 0.5 to 1.5 for high flow. OK accepts the new inhale time. All the settings listed can be adjusted in this manner. When you have made all of your modifications, press the left button under Finish to return to standby. Cough Assist T70 comes with an SD card inserted in the SD card slot on the side. An SD card icon will appear on the top right corner of the screen. Your clinician may ask you to remove this card in order to review information about your treatment. From the standby screen, press up on the center button under Menu. You will see a list of items. Use the down button under Navigate to move down the list until Safely Remove SD Card is highlighted. Press the right button under Select. A Remove SD Card message will appear to let you know that the card can be removed. Press the left button under Exit to return to standby. The SD card and other features make Cough Assist T70 easy for caregivers and patients to use in the hospital and at home.